Dr. Nirav Shah has joined us. And then we'll be moving on to a work session. So first, let's start by introducing the committee. Representative Zager, would you go first?
Sure. Thank you, Mr. Chair. Good morning, everyone. Good morning, Dr. Shah. My name is Sam Zager. Honored to represent District 41 in Portland.
Representative Lemelin?
Good morning, everyone. I'm Michael Lemelin. I represent District 88, Chelsea, Jefferson, Whitefield, and half the Nobleboro.
Representative Stover?
Good morning and welcome, Dr. Shah. My name is Holly Stover. I represent House District 89, including the towns of Boothbay, Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
And Representative Connor?
Thank you, Mr. Chair. Good morning, everyone. My name is John Connor. I represent House District 58, which is part of Lewiston.
Representative Craven?
Thank you, Mr. Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Madigan?
Thank you, Mr. Chair. Good morning. Welcome, Dr. Shah. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Representative Meyer?
Thank you, Mr. Chair. Good morning. Very nice to have you here this morning, Dr. Shah. I'm Representative Michelle Myers, serving Southern Maine's House District 2, which is all of Elliott and parts of Kittery and South Berwick.
Representative Griffin, good morning.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Kedeskeg.
And I'm Ned Claxton. I'm honored to represent the people in Senate District 20, which consists of Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. Our staff are also here today, and I'll let Ms. Dooling introduce herself.
Good morning. My name is Erin Dooling. I'm one of the legislative staff for the Office of Policy and Legal Analysis.
Ms. Broom.
Hi, I'm Anna Broom. I'm the other legislative analyst from this committee, and I also work in the Office of Policy and Legal Analysis.
And Ms. Withy.
Good morning. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
So with those quick introductions and to maximally use the time, we'll turn it over to Dr. Shah. Again, welcome, sir.
Great. Well, good morning, everyone, and members of the committee. Thank you so much for having me back. Senator, if it's okay with you, I would propose to just spend a few minutes recapping where we are and then turn it back over to you and Co-Chair Meyer for the questions.
Sounds good.
Very good. Well, again, good morning, everybody, and thank you again for making some time in your very busy calendar to have me back to discuss where we are with COVID. In recent meetings, we've talked more and more about vaccination efforts, which I look forward to talking about. But sometimes a corollary of that is where we are from just an epidemiological perspective, which is to say there remain some concerning signs on the horizon. And that's what I wanted to start by discussing today. Sometime in the next day or so, Maine as a state will likely cross a number of concerning thresholds. So just already today, we've crossed the 60,000 case threshold. We are now at 60,005 cases of COVID-19 statewide. And the number of new daily cases continues to be at a high level. That is deeply concerning. It is matched by a hospitalization rate that is a significant margin higher than what it was just even a month ago. As of yesterday, there were 116 people in Maine who were in the hospital with confirmed COVID-19 disease, many of whom were either in an intensive care unit or on a ventilator. So we continue to have sustained community levels of transmission of COVID-19 across the state, top to bottom, left to right. Statewide, we are continuing to see high rates of disease. We are, however, continuing to make great progress with respect to vaccinations. As a state, overall, we have vaccinated now fully. Oops, my computer is about to plug this thing in. As a state, we have vaccinated now, excuse me, my apologies, I forgot to plug my computer in. Okay, so as a state, we have vaccinated quite a large fraction of the population, just about 35%, or over 1 in 3 of all Maine people who have completed their vaccination series. And just under half, about 45%, of everyone in Maine has at least gotten their first dose. If you zero in on just those who are eligible for vaccine, that is to say, just those who are 16 and over, the numbers are even more favorable. Have completed their vaccination series, and about 54% have gotten at least their first dose on board. When you restrict that population even further to focus on the most vulnerable, that is to say those who are 60, 70, and above, the numbers are even more favorable from an epidemiological perspective. About 76%
You're on mute, Senator.
We're losing your audio every once in a while.
I'm sorry. Oh, wait. Sorry about that. Is it any better now?
We'll see. Yes.
We'll see. Well, I'm wrapping up right now. But what we've seen in recent months is a very pronounced decrease in new cases among Maine people in their 60s and over. That's been met with a decrease in hospitalization rates among people in Maine 60 and over. What's also happened at the same time is more transmission among people in their 20s, 30s, and 40s. And sadly, with it, more hospitalizations in that group. All of that speaks to the need to continue our vaccination rate. I'm proud of the work that we've done as a state. We rank among the better performing states by some measures. The best performing state with respect to the percentage of our population that has been fully vaccinated, but we still have a pretty long runway ahead of us. So that is where we stand, Mr. Chairman. I will hope that my audio is a little better, and in any event, turn it back over to you.
No, that sounds better. So that's working. So I think I was one of the ones who submitted some questions. So do you want to speak to the Androscoggin circumstances for a moment?
So no picture of COVID-19, either as a disease or from vaccinations, is complete without talking about the variations that exist, either by geography, by racial and ethnic group, or as age, as I discussed. Androscoggin County in particular, Senator, remains an area of concern. There are two factors that are at play there, but they are very closely related. Androscoggin County, in terms of all of the residents of Androscoggin who have completed their vaccination series, Androscoggin is 16th out of 16. They're at the bottom of the league table. It should be of no surprise then that their case rates, as well as their positivity rates, are on the very high end. And there is, of course, a direct relationship between those. That's of deep concern. We've done a couple of things pretty squarely to try to increase vaccination rates and simultaneously tamp down on levels of disease. Now, much of the case rates in Androscoggin County are connected with a very large outbreak at Bates that started around about a month ago now, late March, in connection with a party that was held there. But Bates is not the end all and be all. Indeed, in their latest round of universal testing across campus, they detected no new cases. That's a very good sign. What has happened, though, is again, college campuses are not on an island. There's obviously a lot of the virus knows no boundary of that nature. So we started our work in Androscoggin County by making sure that the large outbreak, the focal outbreak at Bates, was getting under control. Thankfully, it has. We've also then been working with members of different very vulnerable communities, whether it's communities that focus in providing services for the elderly, as well as those who provide services for various new Mainer populations, to make sure that members of those communities had access to testing, things of that sort. And then the third, of course, is by making vaccines as available as possible. We've been working pretty closely and have continued to with Central Maine Medical Center and Auburn Fire and Rescue at their site at the Auburn Mall to build out more hours of appointments, making them more easily accessible. We're working with them now to build out walk-in hours, things of that nature. We've also tried to blanket the various retail pharmacies in the area with as much vaccine as possible to make it as easy as it can be for folks in that area to get vaccine. things have started to level off, and perhaps soon they will decrease. But that remains the area of Maine that is the highest concern right now.
And has the mobile van been deployed in Androscoggin? Is that on the radar?
It is on the radar. It's not. It hasn't gone there yet. It's now at its third stop in Biddeford. It had started in Oxford, then Wyndham, now in Biddeford. Androscoggin is on the radar, or is on the list, but no, it hasn't made it there yet.
Okay. And what about an alternative site closer to the downtown area and walking distance?
Yep. So that's very much on the horizon right now. In fact, there was one that was slated to open not too long ago, but with the pause in the Johnson & Johnson vaccine for 12 days, that threw, unfortunately, everything into either a longer pause from our planning or into outright disarray. And so what we've had to do is regroup. Now that the J&J vaccine has been reauthorized, that's a good step forward. Unfortunately, we haven't gotten any J&J, so it's not as if any new vaccine is coming into the state in that regard. We've been working with our colleagues at the White House and the CDC to figure out when it will actually be delivered. But having a walk-in option closer to downtown that is accessible to many, that's very, very high on the radar. Hopefully we'll be able to get some J&J supplies that come in. We've also heard at the same time that there's some reticence among community members to use the J&J vaccine. So that's got to be something we balance in. Offering a vaccine that by our lights is one shot and works great is of no moment if the folks that want to get it don't want that vaccine. So we're trying to come up with a contingency plan to use Moderna if that's what the preference on the ground is.
And one last question, is there any evidence of the clotting issue, as incredibly rare as it is, occurring in men?
In the United States, there is not. But again, there may not have been enough vaccines administered. In the EU, where the AstraZeneca vaccine has predominated, they have seen a number of instances of what is now called thrombosis with thrombocytopenia syndrome, or TTS. They have seen a number of cases of TTS occurring in men. The ratio seems to be about 3 to 1 women to men. The exact mechanism for that is not yet well elucidated as to the gender difference. We haven't seen any of that emerge in the US, but again, there's been far fewer cases of J&J vaccine, about 7 million as of Friday, that have been administered versus the higher numbers of AstraZeneca in the EU. All that being said, the rate of TTS amongst the population remains at around 1 in a million, 1 to 1.9 per million. We could vaccinate the entire state of Maine and not see a single case.
Okay, thank you.
Mhm.
All right, so I'm sorry I took that over, but are there people from the committee who have questions for Dr. Shaw? If you put your hand up, I'll recognize Representative Craven.
Thank you, Mr. Chair. Thank you, Dr. Shaw, for taking care of all of us. This question is actually from a constituent, and she wanted to know whether anybody that's been vaccinated, whether anybody who has been vaccinated has gotten the COVID.
Yep. So we've had in the state of Maine about 104 what are so-called breakthrough cases. That is to say, individuals who have been fully vaccinated 2 weeks after their final shot, who have then been diagnosed with COVID. When you consider that we've administered round about 400,000 or so, or there's around about 400 plus thousand people who've been fully vaccinated, the way that I think about that number is that 99.998% of people who were fully vaccinated did not end up getting COVID. It underscores that vaccines are amongst not only the safest, but most effective medical interventions that we have. The other interesting thing to note about those so-called breakthrough cases is that many of them didn't even know they had COVID, or to the extent they did, they had exceedingly mild symptoms. Their hospitalization rates are exceedingly low compared to the non-vaccinated. So this is all consistent with what the vaccine does, which is that it protects about 99.98% of people. And for those folks who are in that 0.002%, if they do get COVID, they don't even know they had it, or if they do have any symptoms, they're very mild.
Thank you.
Are there, yes, Representative Zager.
Thank you, Mr. Chair. And Dr. Shaw, thank you again. I think we're being a little humble in terms of Maine's, how well Maine is faring. This is an awful, awful pandemic, but we are, in the elites in terms of the United States. So I really appreciate your work towards that. My question is, do you feel like going forward, the biggest threats to further progress against the virus is resources? And if so, what do you need, or vaccine reluctance, or some other variable?
Yep, it's more on the latter side of that spectrum, Representative Zager, and I'll break that down a bit more. The biggest way, the most fruitful avenue for us to be done with COVID as a state, as a country, is through widespread vaccination uptake. And sometimes when we talk about vaccine uptake, we assume it's a monolith. We use words like hesitance and such, when there may be a part of that. There may be a part of it that is hesitant or reluctant. But right now, what I am seeing in large measure is not so much driven by hesitance or reluctance, it's driven by convenience. We have across the state worked with providers and vaccination sites to change a lot of the existing concepts of operation to make them walk-in hours only, to offer walk-in hours, not only walk-in hours, but to have designated walk-in hours. That's been our model, for example, in Biddeford right now, where the mobile unit is currently set up at Biddeford High School. And so right now, my focus, it is on getting folks, on board who have questions, no doubt about that. But our main focus right now is convenience. So can we offer more walk-in hours? Can we offer early morning and later evening hours for those who have to work? Can we get as much J&J vaccine into the state? I just over the weekend when I was at the Biddeford site, both Saturday and Sunday, I heard from countless people. I mean, at least 24 people who said, I wouldn't have come here had it not been for the walk-in hours. Because I don't have control over my schedule, and I wouldn't have come here had it not been for the J&J vaccine, because I don't have time to come back 21.2 days exactly at 1:34 p.m. I don't have that kind of control. So right now, my focus is on removing a lot of those convenience constraints and making vaccination easy. We will undoubtedly have to do more work to answer people's earnest questions about the safety and efficacy of the vaccine. But for me right now, it's about convenience.
Thank you.
Representative Meyer.
Thank you, Mr. Chair. Dr. Shaw, to your point about convenience, and I have heard from my constituents that they're anxious to be able to schedule an appointment with their primary care physician, and in the privacy of the exam room discuss some of their concerns and just that piece of being able to receive the vaccine. So when might the primary care practices be able to schedule?
Oh, they're already receiving vaccine.
Okay.
Not all, by no means. Not every primary care doctor in Maine who wishes to be vaccinating has been able to receive vaccine. Much of that was a function of the J&J pause nationwide. But we are providing we are providing COVID vaccine to primary care offices. Again, not all of them, but we're starting the process. The barriers to doing it in widespread fashion are, one, the lack of availability of J&J vaccine. The Moderna vaccine is great, but it has more doses per vial. And so, it's soon going to have 15 to 17 doses per vial, which means that an office has a couple of hours after they crack the seal to do 15 to 17 vaccinations in pretty rapid succession. And if they don't, they waste all those doses. So we've been working with primary care offices and the medical society to make sure that they're set up. J&J was a perfect venue for that, because we agreed a lot of folks, the data shows a lot of folks are not interested in hearing about vaccines from me or anyone else. They'll talk to their doctor, but beyond that, not so much. So as the J&J supply increases, we are hoping to be able to provide more and more vaccine to primary care offices, but the limiting constraint there is the volume of J&J. If there's a practice that wishes to use Moderna and can deliver the 10 doses that are currently in a vial, 10 or 11, and soon to be 16 to 17, that's great. We've been working with them.
Thank you. And then to the issue of supply, the pause in J&J notwithstanding, how has supply been week over week?
It's been uneven. Some weeks, for example, the week that we're in right now, we got an increased supply of Moderna vaccine, which is great. The J&J supply has not really budged at all. And because of some production concerns in connection with one of their manufacturing facilities in Baltimore, I'm told that the supply of J&J may not increase appreciably for another month, maybe even into mid-June. The supply of Pfizer has not gone up that significantly. It's gone up a little bit over a multi-week period in very small step increments, but the supply of vaccine has certainly gotten better. There's no question about that, but we're not at the point yet where every single provider of any stripe that wants vaccine is always able to get it.
Are there other questions of Dr. Shaw? So I know you don't have a crystal ball. If the current volume of available vaccines stays flat, how are we going to be doing a month or two from now?
You know, thank you for that question, Senator. I've been running models using various and different assumptions to try to project out to those very same things. One of the things that I'm quite proud of that we've got is headroom in the system. That is to say, we can, if there's an increase in supply of vaccine, we can really pretty efficiently turn it into vaccinations. So basically, that's a long-winded way of saying virtually every provider in the state of Maine has signaled to me and our agency, we can do more. We've got vaccinators, we've got more hours, you just got to get us more vaccine. So that means that when there's more vaccine supply, we're in good stead. But if we go back to the assumption you noted, which is a flat supply, a steady supply, that means A, that headroom is not being used, and B, it means that the velocity that we're on doesn't really change. That takes us into early to mid-July before everyone in Maine who wants a vaccine it can get one, such that we are at that 85% or so threshold. I'm ready to move more quickly, provided we get more vaccine. But that's really the supply remains the constraint right now.
Thank you. Are there other questions of, yes, Representative Connor?
Thank you, Mr. Chair, and good morning, Dr. Shaw. Thank you for what you've done. I'm not a virologist. I'm not a medical doctor. I have no idea what I'm talking about usually when it comes to this, so I'll just ask you your forgiveness and patience with me when I ask my question here. So prior to COVID, we hear the term herd immunity. You know, when everybody gets the disease, now we have herd immunity. Does that come into play with the vaccine for those that may have already contracted the disease? They don't get the vaccination. Does that mix in with those that are getting vaccinated to increase the overall herd immunity numbers?
It's a great question. Not a off topic or not a. It's a great question. So yes, they do. When we run models, or when I run models to try to, to back to Senator Claxton's question, such as it is, get my crystal ball out and try to see where we're going. We account for those who have not just had confirmed cases of COVID, but also for those who we know are out there who had COVID, but just weren't diagnosed. In any epidemic or outbreak situation, let alone a global pandemic, we never know exactly how many people are infected. We don't test every single person in Maine 3 times a day. That would be the only way to know day on day exactly how many people have been infected, and then also run an antibody test on them every 36 hours or so. If we were to do that, I would know with surgical precision exactly how many people in Maine have been infected and their degree of immunity. We never know that. That would be crazy. So we run models with different assumptions built into them to say that for the 60,000 people that we've got who have gotten confirmed, X number, 1X, 2X, 3X, 5X are out there who haven't been infected. And we run it with different assumptions. We then build that on top, and then on top of that, we layer on those who have been vaccinated. Now, you can refine the models in various and interesting ways. For example, the immunity that you get from just having been infected with COVID, the natural immunity, is not as strong or as long lasting as the immunity you get from having been vaccinated. The nature of the response, both from B cells and an antibody mediated response, as well as a T cell mediated response, is just not as strong. So you can build all of those nuances into the model, but we absolutely take into account that baseline level of natural immunity in the population.
Excellent, thank you. So given that, and you may have already said it and I just didn't hear it, what is our current percentage of estimation of herd immunity in our state?
Well, let's start at the top end, which is to say what you need to get to. And generally speaking, you need to be at anywhere from 75 to 85% of the population that has some degree of immunity, be it natural or vaccine acquired immunity. That's kind of where you need to be before you start seeing population level effects. The second thing is to have a finer, just to make sure we all understand what population level immunity means. It is not a switch on the wall. So it does not mean that when you get to 77.3%, COVID goes away. What it means is that the rate of new cases goes down and outbreaks become less frequent, but there is still COVID after you get to population immunity. There's still measles cases, so on and so forth. What it means though is that those who are unvaccinated can enjoy the benefits of being vaccinated because there's not enough unvaccinated souls around to propagate the virus and cause outbreaks. That's important for folks who have, say, had an organ transplant or so on and so forth, who can't get vaccinated. So when you set that aside, we've had about 60,000 confirmed cases across the state, and we've had about 477,000 people or so who have gotten their final dose of vaccine. If you assume for a second, for every case we know, those 60,000, there's another person out there who hasn't been diagnosed. That means there's about 120,000 or so people who have had COVID, and then about 477,000 who have been vaccinated. So that takes us to about 589, we'll call it 600,000 out of a population of about 1.3 million.
Thank you very much for those answers, Dr. Shaw. That's all I have, Mr. Chair.
And that 1.3 million is reduced somewhat by kids under a certain age and that kind of thing.
Not for epidemiological purposes.
Thank you.
Right.
Yeah.
So even though a 12-year-old may not be eligible for vaccine right now, they can certainly be conduits of COVID-19 infection.
And this takes us back to the R naught conversation that we first started having about 100 years ago. So we're not close to an R naught below 1. Is that being calculated at all? But that's really the goal for herd immunity, is to shrink that number to a manageable level. And that does better with outbreaks than it does with community transmission. Is that correct?
Could you just,
Sure.
I want to make sure I answer your question directly.
Well, there were about 3 of them in there. So let's start with R naught. We're a long way from getting ahead of this in terms of an R naught less than 1. Is that correct?
Yes, that is correct. R naught is comprised of a number of different variables in the way that it's derived. The main variable that you use to affect R naught is S sub T, which is the fraction of the population that are susceptible. By vaccinating them, you remove them. But no, we, as a globe, we are still not there. But keep in mind, Senator, the R naught for TB is not under 1 either.
Okay.
Right. So,
Yeah.
TB has been around for, immemorial. So.
Right. Okay. Representative Stover?
Thank you, Dr. Shaw. I have a question. We've had limited information about the booster vaccine that may be needed at some point. I know that vaccines began in late January, early February for first responders. I'm just wondering if we know or can anticipate when more information will be available about the booster, or even when that might become available.
Sure, Representative Stover. One quick note at the top: vaccinations began on December 14th for frontline workers, first responders, frontline healthcare workers. That was the first day of vaccination in Maine. In terms of any booster doses that may be needed, it is too early to tell scientifically, and of course that's a decision that is made by scientists, the U.S. FDA. It's not a Maine CDC decision. It is too early to tell whether any booster doses may be needed. We can't rule out that possibility. It's a possibility based on how much the virus changes. I will tell you that what is going on in other parts of the world right now with effectively uncontrolled spread of COVID greatly increases the likelihood that there will be variants that will escape the protection afforded by the vaccine. And so this is an argument for why it's not just Maine that needs to be vaccinated. It's not just the United States. It's literally the globe, because what's happening in a small corner of the world somewhere distant can be back at our doorstep in a matter of weeks. But whether we will need any type of booster dose really depends on what unfolds over the next couple of months, and whether what transpires as a result of that is something that is not protected for by the vaccine, or whether the vaccine will cover it.
Thank you very much.
Representative Javner, would you want to introduce yourself and ask your questions?
Good morning, everyone. I'm Representative Javner, and I represent District 1.
We're having trouble with your audio.
Very
good. You want to try stopping the video and see if that helps?
Yeah. Is that any better?
Yes.
Okay, I'm Kathy Javner. I represent House District 141, which is located in Penobscot in Washington County. Thank you, Dr. Shaw, for being with us this morning. I appreciate it greatly. The one number that I have followed very closely throughout this whole situation has been the hospitalization number. As we progress into the vaccination period here, what are we seeing as a trend with our hospitals being overwhelmed, which is the term that we were told, that we did not want to reach that threshold. And along with that, what is happening with the treatment plans for the hospitalizations? Has there been any increase in understanding of treating on a more effective basis?
Sure, Representative Javner, you're right to follow hospitalizations. It's a pretty good number to give you a sense of what's going on, particularly amongst severe cases of COVID. It is a lagging indicator. It typically lags case numbers by 10 to 12 days, but nevertheless, it's a good way to get a sense of the severity of the outbreak, but maybe not so much the scope, because of course, some things have changed throughout the pandemic. Early on, about a year ago, even those with relatively mild symptoms, well, maybe not mild, those who were either at higher risk or who had moderate to severe symptoms were hospitalized. Nowadays, though, there's a big push to keep people out of the hospital, which gets to your question around treatments. One of the more useful treatments that has come on the horizon, maybe 10 months ago, are so-called monoclonal antibodies. They are best used and deployed to keep people out of the hospital. So someone with severe comorbidities who is at risk for complications, if they get diagnosed with COVID, early administration of a monoclonal antibody can actually keep them out of the hospital, which is exactly what we want to see. Now, in terms of treatment and care within the hospital, I'm not a critical care expert by any means, but the ones I've spoken with have indicated that there have been great strides made in the management of COVID patients, both in terms of how they're managed before they may need a ventilator, as well as once they do need to be mechanically ventilated. I think that's one reason mortality rates have thankfully come down for hospitalized patients. We are seeing a concerning trend, though, which is that even as cases have now been more driven by younger populations, we're seeing significant hospitalizations still among younger folks. You may recall a year ago, there was a notion that younger folks, people in their 20s, 30s, and 40s, even if they got COVID, wasn't that big of a deal. But we're not seeing that here. We're seeing that as younger people have been affected, they are also being hospitalized in great numbers. That's deeply concerning.
Does
Thank
that
you.
answer your question, Representative Jabner?
Yes, thank you very much.
Representative Meyer.
Thank you, Mr. Chair. Dr. Shaw, I'm wondering if you could comment on the plan for vaccinating Maine's incarcerated men and women.
Mm-hmm. Yep. So ever since, particularly with the J&J vaccine, we have been working with the Department of Corrections, and they in turn have been working with county jails to provide that vaccine for, particularly for their residents. Again, the pause on the use of J&J vaccine came at the time when we were really ramping up. I think the week of the pause, we had delivered, I can go back and check, but quite a few number of doses for administration that had to be put on pause, unfortunately. Now, with the news from Friday, they too have resumed their vaccination operations. But in the meantime, not knowing whether the pause would ever be lifted or when, DOC converted their vaccination operations to using Moderna vaccine. And you'll see on our weekly allocation tracker, for this week, we allocated about 400 doses. And then late last week, transferred another 180 doses, which was about their weekly allocation. Most sites in Maine, whether it's a hospital or the DOC, are doing 500 to 700 shots per week. And that's where DOC is right now. They're doing those 500 to 500 or so, maybe a bit more, with some going to county jails to get their population vaccinated. Now, this is using Moderna, which means that plans for the second doses will have to be made, which is totally doable. The J&J vaccine would have been a little bit preferable, so we don't lose individuals to follow up if they are released, say, from a county jail in a couple of days. But, you know, it's a pandemic. We're doing the best we can. We'll adapt every step of the way.
Thank you. And the uptake among corrections staff?
The data that I've got there are several weeks old. So I don't want to, I know it's changed as more folks have seen the value of vaccines. In fact, the Deputy Commissioner of DOC shared with me that one of their corrections officers, after initially saying, I'm going to wait and see, realized that after being vaccinated, they could go on a vacation to go fishing or something of that nature and not have to worry about quarantine, and then said, hey, I want that. But in terms of the actual uptake percentage, Representative, my data there are a bit outdated, so I don't want to give you a wrong number. Deputy Commissioner Thornell or Commissioner Liberty would know it off the top of their head.
Thank you.
Are there other questions of Dr. Shaw? I'm not seeing any. That being the case, we'll thank you for setting aside some time. We'll thank you for the progress that's being made and for keeping us posted. We'll continue to send questions through Molly, and she's been good about getting back to us with some answers. So it sounds like the biggest constraint is supply. Well, number 2 and number 3, is there anything we can help with those?
As to non-supply related, I think one of the things that is always helpful is to If you have questions from your constituents about safety, access, efficacy, why they should be vaccinated, where they can get vaccinated, we will pledge to get you answers to those. But in your communities, folks are obviously reaching out to you. It is never a bad idea to underscore the value of vaccines for them, even if they themselves may be someone who they think is at low risk. I talked to someone in Biddeford. I'm sorry, not in Biddeford. While I was in Biddeford, I spoke with somebody on the phone on Saturday who conveyed to me that they themselves are immunocompromised, and they are not able to interact with anybody unless the people that they're interacting with are fully vaccinated against everything. And so that brought into sharp focus for me why, even if you don't want to get vaccinated to prevent yourself from getting sick, although I think you should, if you have someone in your life who is elderly, who is young and can't be vaccinated, or who is immunocompromised, getting the shot helps them too.
Okay, thank you. I'm not seeing other questions, so have a good rest of the day.
Thank you, everyone. I appreciate the time. I'll chat with everyone soon.
All righty. So I guess that puts us in a position about 15 minutes early for a work session, but we might deal with LD 415 right now and get that out of the way. So for those of you who are listening, whenever a vote is registered in error and the person voting recognizes that, then we bring up the bill again for reconsideration. That's happening in all of our committees because we have a new way of communicating the vote. So it's not on any one person that this is happening, because it's happening in other committees too. So because of that, we had one in that vein, we had one person vote other than how she intended. And so for that reason, we're going to, I would entertain a motion of reconsideration on LD 415.
So moved.
Seconded.
I hear a motion moved and seconded. I guess officially we should tally this vote, Ms. Withy. So this is a vote on reconsideration of LD 415.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry. Representative Perry is absent. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore. Senator Moore is absent. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
So as I remember the vote on 415, it was ought to pass as amended, but I'm going to look at I see head nodding from the people. All right, so I would entertain a motion on LD 415 ought to pass as amended.
So moved.
Seconded.
So it's been moved and seconded. It's up for reconsideration. That vote passed. Is there any further discussion? Okay, so that being the case, then we can vote again, Ms. Withy, on the ought to pass as amended motion. And I leave it to you to record the vote.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin. Representative Lemlin is absent. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry. Representative Perry is absent. Representative Griffin,
Yes.
Representative Griffin, yes. Representative Connor,
Yes.
Representative Connor, yes. Representative Craven,
Yes.
Representative Craven, yes. Representative Madigan,
Yes.
Representative Madigan, yes. Representative Javner,
Yes.
Representative Javner, yes. Senator Moore, Senator Moore is absent. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. Representative Lemlin, would you like to register your vote?
Yes, and a yes.
Representative Lemlin, yes. That's 10 yes, 3 absent.
Thank you for doing that. And I think we have the vote straight on that one. It's going to happen again. I didn't do the traditional welcoming that we do at the start of our sessions, but we'll put that on the list of technical issues that we guarantee are going to come up something every day, at least once, and often more often. So I give people a heads up for that and I ask for your patience during this time. For those of you who want to watch as well as listen, you can go to legislature.maine.gov and look for the Health and Human Services Committee. If you click on that, it'll take you to some options, including our YouTube channel. Everything is recorded, so you can go back and see what we've been doing before, and this session is recorded, so you can see it later on if that works better for you. We'll be working on a number of bills this morning before we go to a public hearing this afternoon. And we usually start those with the analysis from our legal resources. And if there's nothing else to do right off, we can start with consideration of LD 822.
So I'm sorry, you're not waiting until 10, is that correct? We're starting early.
We'll talk slowly. Okay, we'll take a 12-minute break. We'll take a 12-minute break, come back at 10 because we haven't given the requisite 30-minute notice. And we'll see everybody back here at 10 and we'll officially start our work session then. Carrie, do we know who's on the phone?
We don't, but we could ask.
Sure. Why don't we get a name under the phone number there?
It's Senator Moore, I think.
Ah, all righty. So it being 10 o'clock, we can resume our work. Now that Anna doesn't have to remind me that we had to wait till 10 o'clock. I appreciate that. Thank you. one of the many ways our staff keeps things working the way they're supposed to. So at this point, we're going to hear from Anna about LD 822.
I like the fact that you thought I was going to talk slowly. I thought that was very entertaining.
Inside joke.
Yeah. All right, LDA 22. This is an act to affirm that food seeds are a necessity in Maine. This bill adds seeds to the definitions of necessities in the law in Title 10, which is a section that prohibits profiteering from supply disruptions. And it also includes it in the definition of basic necessities in the law governing municipal general assistance. So if you were looking at the bill in your hand, you would see section 1 is in Title 10 and section 2 is in Title 22. You heard that the bill is seeking to establish the right of Maine people to save, swap, share, and obtain seeds without interference from the government. You also received some testimony from the department that SNAP can already be used to purchase seeds and seedlings, and that general assistance offers immediate relief of insecurity by providing food vouchers. So this took a little detective work for me to figure out what was happening here. So the Title 10 law was enacted in 2006 to prevent price gouging of necessities during periods of abnormal price disruption. And that was a bill that came out of the Judiciary Committee in 2006. In 2019, potable water was added to the list of basic necessities in LD 1121, which was enacted, and it was drafted in almost exactly the same way, in the sense that section 1 of that bill added it into the profiteering law under necessities, and section 2 put it into the GA law. That bill also had added potable water to the law regarding county procurement for jail supplies in Title 30A. That bill went to the E&R committee, presumably because it was about potable water. And LD 822 is drafted in the same way as the first two sections of that bill. The GA law, which is more familiar to me than the profiteering law, requires people applying for the general assistance to prove that they are spending their income on basic necessities. That's why there's a definition of basic necessities in the GA law. So this would add seeds to that list, and the bill doesn't specify what kind of seeds, it just says seeds. And we haven't yet received a preliminary fiscal impact statement from OFPR yet.
Okay, does that prompt any questions from the committee members? And that bill was brought forward by
Senator Kime.
And I don't see her. There she is. Do we want to bring her in and we'll find out if she has any questions about that analysis? And then when she's in, we can go to Representative Connor. Let's go to you first, and then to Senator Kime.
Thank you, Mr. Chair. I guess this is a question for the group as a whole, since it's a work session. Is by labeling seeds a necessity, does that do away with the tax on it? Is that what I'm to understand? Or is it still a taxable item? I'm just curious.
All it does is put it into the profiteering law and the general assistance definition of basic necessities, so that an overseer would look at how a person was spending their income to ensure they were spending it on basic necessities. But it doesn't affect tax law at all, and neither did 1121, although I don't know how you would tax potable water.
Okay, thank you. Thank you for the clarification.
Okay. Representative Senator Kime, did you have any questions after that analysis?
I'm sorry that I joined late and I didn't hear all of
Oh,
the
that's
analysis.
So basically, the analysis said it's a two-part. One is in the first section, it refers to MRSA 10 and addresses profiteering. And section 2 addresses in MRSA 22 general assistance. And the one thing that she noted was there was no definition of seed or limitation of seed. And I noticed that too, in that all the testimony referred to food seed.
Mm-hmm. So I think that it makes sense to change it to food seeds and then leave it at that. And then we're defining it more, tailoring that, because that is the intent of the bill, is that it's food seeds. There isn't I think one of the questions that arose was whether or not we would be expecting the department to be providing food seeds as part of general assistance. That was not intended in this bill. It was more just a matter of making sure that food seeds are not limited ever to the people of Maine. So if there is an amendment that's needed to make sure that is clear and understood, and then I would be amenable to that as well.
Okay. Representative Craven?
Thank you, Mr. Chair. I noticed that Molly's here and I wanted to know what kind of input she would have.
Ms. Bogart, thank you for joining us.
Good morning. Thank you. I'm Molly Bogart, Director of Government Relations for DHHS. And I turned my screen on when Representative Connor asked his question, and Anna covered it. But, from the DHHS perspective, we have no concerns, obviously, on making sure that food seeds are available to Maine people. I think the way this is drafted would have us include those as something that could be covered by general assistance. And so since general assistance is generally calculated based on needs for 30 days, food seeds would be somewhat in conflict with that, since usually they do not propagate food within 30 days and can likely not meet someone's immediate basic needs as general assistance is intended. And so really what we raise is the drafting question about where, if this is more of a statement about the importance of food seeds to Maine people versus an additional item that should be covered under general assistance as administered by municipalities. That is the question that we raise.
Thank you for that. Other questions? I also noted, reading through the testimony, there was reference to food seedlings as being a more proximate source of food than simple seeds. So that raises the question about whether the author's intent was to include seedlings in there too. Okay. I see a head shake. And then another question I heard was about the definition of food. Is there food defined in statute? Anna, anywhere, that term?
Oh boy, I feel like I need to be the agriculture committee for that.
Okay.
Honestly, I don't know.
Okay. All right. Just occurred to me that if we're talking about food seeds. Yes, Representative Zager.
Thank you, Mr. Chair. I appreciate Ms. Bogart giving the perspective of the department. It triggered a question. How long do people typically stay on receive general assistance? Like what percent of people have it for more than 30 days, or are there any such statistics readily available?
I would have to get that for you. I'm sure they're readily available. That would be different than readily available to me. So I will, I'll send a note and see if I can get that as we're working this.
Appreciate that. Thank you.
A question to the sponsor. Senator Keim, how would you feel if we left out the GA proviso, the general allowance, general assistance proviso, and just left it as a no profiteering on the sale of seeds and seedlings if you wanted or didn't want? That way, at least the powers that, there wouldn't be any restriction based on profiteering. And it would apply, and it still apply to all Maine residents.
So I think that if we do that, we're missing part of the point of this bill, which is the fact that we want to make sure that it's listed as something that is necessary. So there can't also be a law that would come in and say, well, I think it was I forgot it was in my testimony, but there are a couple of states that actually during the pandemic limited the ability for people to go purchase seeds. And obviously they're not an immediate source of food, but they are a source of ongoing food. So my concern is that we would be too limiting the intent of the bill. And I'm wondering, Molly, maybe you know, and good morning, everyone. I don't even think I actually introduced myself, but I live in Dixfield, Maine, and my name is Lisa Keim. I represent Senate District 18. Aren't there other items listed as necessities that aren't all supplied by the department under general assistance?
Sure. So general assistance is largely provided through vouchers. So for most of the items under that list, the department is not sort of procuring those and providing them to people. The municipalities really are paying for those, and then the department refunds the municipalities for a portion of those. And so, clarity that we wouldn't be required to actually procure the seeds and then provide them is certainly helpful, but it's also the expectation that municipalities would be paying for the seeds under general assistance. So I believe everything that is listed as a basic necessity under general assistance is something that municipalities are expected to reimburse for should it fall under someone's needs. And I also forgot to mention that the Supplemental Nutrition Assistance Program, also known as SNAP or food stamps, does cover seeds and seedlings. Those dollars, I should say, can be used for those.
Mm-hmm. Okay. Anna?
I'm not sure that this is going to answer the Senator's question exactly, but when I went back and looked at the bill from the 129th, what the testimony from the sponsor of that bill said was they had gone into the statute and looked for every definition of basic necessity and added it in. And this is all there is. I guess that's because we don't write the law that way. And I would argue that it doesn't actually get at what I'm hearing the sponsor is looking for, because general assistance is one program. And as Molly said, SNAP already covers seeds and seedlings, and that's not in state law because it's federal law. So I don't know. I don't know how to get at what you're actually looking for, but I don't think that this does it, and I don't think that 1121 with potable water did it either.
Yes, Representative Meyer.
Thank you, Mr. Chair. I was going to add that that SNAP benefits do cover seedlings and seeds. And I just don't see how how seeds have any place in general assistance. Applicants to general assistance are with regard to food insecurity, are looking for immediate relief. And we already meet those needs with vouchers. So I would be unable to support this should we continue to be looking to amend the general assistance aspect.
And yes, Senator Keim.
I wonder if the committee would allow me some time to look for a different place in law. I do understand and agree with what Representative Meyer was saying, and listening to, we basically don't have a place in law to sort of outline what we consider to be basic necessities that would be protected from any government interference. I think profiteering is good. That part is necessary and important part of this bill, but it doesn't then get at other issue, which is to prevent government interference. So I wonder if I should, I don't know, do some comparison of something in other states or work more with your committee analysts to try to find a place in law where this fits. I think it's really important that we establish this, but I don't know. I'm not an expert and can't come up with where it would be in law.
And my sense is that adding it to profiteering makes a lot of sense. I think once we get into how to avoid what you're shooting for, which is that sales gets restricted on seeds during disruption, I'm not sure that's a long suit for Health and Human Services. That sounds like more a judiciary or legal affairs question. So I just share that thought for what it's worth. And I understand the want to get it right. I also have presiding officers breathing down my neck to get bills out of committee. You're familiar with that, I'm sure. So that would certainly not preclude your bringing that up as a separate bill. And then it would end up with people who were much more comfortable with judicial questions than this group is. So that would be a thought, would be to split it out, support the section 10 profiteering concern, which I think is a step and moves the needle, and then eliminate the section 22 reference to GA because that applies to a relatively small portion of the state at any one time. How does that sound to you?
I think that sounds fair. I understand that we are in a tight scheduling and, you know, trying to move our bill. So I think that sounds fair.
Okay. Are there other questions or discussions related to consideration of LD 822? Then based on that conversation, I would entertain a motion to approve LD 822 with removing the reference to MRSA 22 as in striking section 2. Is that acceptable to the sponsor?
So
Okay.
moved.
So there's been a move
Second.
and a second. Any further discussion? The only other, okay, so the motion has been ought to pass as amended. It's been moved and seconded. I don't see any further discussion. So Ms. Withy, can you run the vote?
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry. Representative Perry is absent. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore. Trying to see if she can, oh,
Can't show a picture though, Kerry.
Yeah, I was going to say, I
Oh.
think you need my video, and I'm just dialed in.
you are right. Thank you for correcting me.
No problem. I will call in my vote. It is ought to pass as amended, but I will call
Okay.
that in.
Thank
Thank you. Sure.
Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
Okay. Thank you, Senator Kime, for bringing that forward. I think you have a new direction to go with the next bill.
Yes, thank you so much. Have a good day, everyone.
You too. All right. Now we'll move to consideration of LD 1324.
Okay. 15, 20. Right, LD 1324. This is a resolve directing DHHS to conduct an assessment of human trafficking in the state. This resolve directs the department to conduct an assessment of human trafficking in the state patterned on an assessment conducted in 2015 and to provide the assessment and recommendations to the legislature on how to combat human trafficking with regard to prevention and re-entry. And the report is due by December the 7th of 2022. You heard during the public hearing that there was a national study that gave Maine a D rating on the handling of sex trafficking. I can't enlighten you on that. I didn't look it up. But there's a lack of current information in Maine specific data. You heard from proponents that there was a 2015 study that was specifically sex trafficking, and it identified the need to include labor trafficking as well. And there was there's a request to amend this bill to include labor trafficking and also to shorten and broaden the measures for the study because the understanding is that this study was based on the one that they did in 2015. So they're looking for something different. So that was the MICASA requests. OCFS is in the process of conducting a needs assessment for the domestic violence and sexual assault services in Maine, and it's unclear that the 2015 assessment is outdated. And they also argued that the federal government is in the best position to do this assessment. So just a reminder, if you do want to go down this road, that there were requests for amendments. And there was also a request for the last study, which I sent to you on Saturday, so that if you wanted to read it, you could. And we haven't yet received this from OFPR.
Okay. Any questions from the committee about that report on 1324? I don't see any. Yes, Representative Craven.
Thank you, Mr. Chair. I'm sorry that I didn't look at the amendments, but what were some of the amendments, Anna?
So if you were able to get at the MICASA, and I don't know if Elizabeth is here or not, because she would be the person who could go into the details of that. But the first was she suggested that it would be expanded to focus the assessment to include labor trafficking rather than sex trafficking. I know that labor is in here, but it's as an aside. And then she also said, and I don't have the details of this, it would require some discussion by the committee and the advocates, specifically what it would look like. But what she said was, the second suggestion is to shorten and broaden the measures for the study outlined in this bill. It appears that the measures chosen came from the results of the last study. If this section was shortened and broadened, the experts who will shape this new assessment will have more control over how and where to spend their limited resources and let data drive the process more organically. She also said if this can't happen, they would be interested in looking more broadly at trauma and poverty as risk factors. So the specifics of that, you would need to talk to the advocates, but those are the amendments that they're looking for, because the argument, and this is MICASA in particular, I don't know what the sponsor or some of the other advocates were looking for, but I believe MICASA had the contract for this last study. So this was really their bailiwick.
Yes, Representative Craven, did that answer your question, or you have another one?
Yeah, no, do we have advocates in the queue that we could talk to?
If you're somebody who wants to speak to this particular bill, 1324, please.
We have the bill sponsor here.
Oh, there she is. Oh, welcome, Representative Roberts. Didn't see you come in.
That's okay. Thank you, Mr. Chair.
So we heard it from our analyst. Did you hear any of what Ms. Broom had to say?
I did. And just to reference the report with the D rating it was from an organization called Shared Hope International, which with all the other sex trafficking bills that are out there right now, you'll see is kind of a reoccurring kind of theme as to where data is coming from that's giving us this poor rating. It is a national study, which is where I think we kind of are lacking, and where the federal may not be the best route to go, because it doesn't have the people on the ground that we do, like MICASA and our domestic violence advocates. I'm completely open to any amendments that MCASA would like to add to it since they were part of the original study. And I would just kind of add that all my discussions with the AG's office and with survivors and advocates is that a lot has changed since 2015 in regards to trafficking, and we can't adequately address it until we have new data. Going on 2015 data is not going to allow us to adequately address this issue.
Representative Craven, did you have something, another question or?
Yeah, thank you. Thank you for bringing the bill forward. We have a catch-22 here in Lewiston, and I would be very interested, to see what could be done to support our law enforcement, or have another method for all and that sort of thing. But I wanted to ask about the difference in the resources and the process for a study on sex trafficking compared to labor trafficking. I wonder if you had looked into the differences.
Was that for me, Representative?
Yes, please.
Yes, no, the labor trafficking was brought to me by MCASA, so it was not originally on my radar until they brought it up.
Okay. Any other thoughts, Representative Meyer?
Thank you, Mr. Chair. So, Anna, just sort of circling back to what MCASA was recommending for amendments, narrowing the scope of the study, did I hear that right?
The expression was shorten and broaden. So I think because all of the measures in here are specifically related to sex trafficking, I think that they were looking for making it more broad, but I don't know exactly what they would look like. I mean, obviously I could work with them if that's what you would like, but I don't know right now what those things are.
Yeah. So is there anyone from MCASA here? No.
I had trouble with that phrase too, broaden and shorten.
Yeah,
that didn't help me.
No, nor I.
So the
and
option,
then,
go ahead.
So just one more thing, Mr. Chair, if you will. So the sponsor is stating that the labor trafficking was also from MCASA. So I guess my question is, we had discussed potentially striking that piece of this so that the focus was on sex trafficking and the new data that we need for that. So yeah, so I guess I'm looking for a little clarity around exactly what the advocates are looking for here. I'm ready to support this, but I'd like to know exactly what the study is comprised of.
You want to take a run at that, Representative Roberts, or?
Sure, I'm not sure that I'm going to provide 100% clarity because as I had alluded to in my original testimony, in my meetings with various advocates, service providers, law enforcement, it differed as to what was needed, which is why I based this bill on the previous study, focusing on human trafficking and the benchmarks. And I had added a couple of my own that I felt relevant from speaking with the victims and survivors groups. But I'm sorry that I can't provide a lot of clarity there, but it does not seem to be in between parties as far as what the solution, the answer, the best path forward is, if that makes sense.
So it seems that the options are to exclude labor trafficking and make this a sex trafficking bill, which is what the original intent was. Am I correct about that, Representative Ron? Yeah. Versus adding in labor trafficking and making it a broader bill with not as narrow and specific a focus. Yes, Representative Zager.
Thank you, Mr. Chair. Forgive me, this probably came up in the hearing, but did the 2015 study look at labor trafficking at all?
No.
Okay, that's great.
It recommended that it be extended to labor. That's what the reference to the 2015 study was.
Thank you.
And I think the page number was given and everything. I could probably even pull it up for you if that was helpful.
It was referenced as part of their recommendations. It wasn't part of a study. It was a recommendation that came out of the sex trafficking study. Okay. Yeah, that was an interesting report. Any other thoughts? So how does the committee feel about narrow versus broader? Any thoughts? Representative Javner, looks like you're reaching for your unmute button. Please.
I will turn there. Is that better? Can you hear me?
It is. It makes a difference. Must be windy out today.
It is very windy. Yes, thank you, Chair Claxton. I am definitely willing to support something that is narrower, specifically focused on the sex trafficking issue. I'm also very curious to know exactly what the law enforcement side of the piece here would like us to include in the report. I think that would be very important. And I think until, we get a better understanding of what exactly it is that we're looking at for the amendment, I'm more than willing to move forward though with just the human trafficking, the sex trafficking piece of this. And this is exceptionally important for us as a state to be looking at. So.
Is that in the form of an amendment or a motion to approve as amended, striking any reference to labor trafficking?
Absolutely. I'd be willing to make that motion.
I second that.
Yep.
Moved and seconded. The motion on the floor is to approve as amended, the amendment being to strike sex trafficking and in anticipation of a possible fiscal note, because there was some cost to the 2015 study. Yes, Representative Zager.
Thank you, Mr. Chair. I'm wondering if the idea of a labor trafficking study could be referred perhaps in the form of a letter from this committee to another committee of jurisdiction. I'm relatively new to all this, so looking for suggestions or ideas about how that idea can best be gotten to the place where it can be dealt with.
That's certainly a possibility. Representative Jedner, you made the initial motion. Would you be comfortable with including a letter to labor recommending that they address this issue?
Absolutely. I agree.
Representative Madigan?
I was just going to agree with Representative Zager that I think sending a letter to the Labor Housing Committee asking them to look into this, and maybe they already have, would be a good idea to get a handle on that.
Okay. Okay.
This may also fall under the Judiciary Committee. It could be either.
We will send letters to, how about if we send letters to both? That this has come up as an important consideration at HHS and deserves its own study focused on the issues that have been raised. Okay. So there's a motion on the floor. Do you have all the amendments captured, Anna? Okay. So the motion on the floor is ought to pass as amended. I see no further discussion, so we'll defer to Ms. Withy for running a vote.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lumlin.
Yes.
Representative Lumlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry. Representative Perry is absent. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore. Senator Moore is absent. Representative Meyer,
Yes.
Representative Meyer, yes. Senator Claxton,
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
So Representative Roberts will be sending a letter to the folks at Judiciary and Labor recommending a thorough study of the issue you've raised and finding out if somebody else has already done something similar or not. But that'll be our next step out of committee from here.
Thank you, Mr. Chair and the committee. Have a good morning.
Good morning. Thanks for bringing this forward. All right. So that'll let us progress to, I think you did analysis of both 423 and 1386 together, Anna. So if you want to go ahead with that.
I did do that. So LD 1386, this resolve requires the department to develop a plan to provide up to 16 new specialized bariatric care nursing facility beds with an RFI by August of 2021, a review of the RFI by October, adopting rules with rate changes by December, and RFP by March of 2022, and the contracts awarded by June of 2022. Rate changes build on the resource utilization group, that's called the RUG system, to capture clinical intensity needs of residents. Would also allow for 30 bed hold days and direct billing for medical equipment, transportation, and behavioral health services. That's also an emergency bill. LD 423, this bill requires the department to provide bariatric care centres embedded in nursing facilities to provide requisite care within the nursing facility setting. So you heard from during the public hearing that bariatric patients can be difficult to place at an appropriate level of care. And you heard from the Long-Term Care Ombudsman Program and the hospitals that they plead with facilities to take residents, and the process can take a long time to get through, that the facility agrees to consider the patient, then they do the planning, they determine the cost, and then they negotiate with the department for a specific rate for that individual person. And so the sponsors are looking, and the advocates are looking for a way that it would be easier if there were designated beds or facilities. And there was also some discussion about whether those beds would all need to come online at once. The department testimony that they cover bariatric services under Section 67, which is the nursing facility chapter, with additional reimbursement through a prior authorization, and that Main Care is working on issuing guidance to nursing facilities so that they can be aware that durable medical equipment is covered and the facilities are not expected to incur those costs. There is an administrative burden in LD 1386. This is the one that develops the RFI and so on, and that LD 423 lacks specificity for them to comment on. So I'm just reminding you that there is this cost issue sort of disagreement in terms of whether you've heard from one side that the department is already paying for these people, these residents, so they there wouldn't necessarily be an additional cost, but you also hear from the department that there would. So that's just something for you to keep in mind. If you want to go into LD 423, I think you may need some more detail. It's unclear what a specialty bariatric care centre is, and the bill requires the department to embed them in nursing facilities, and nursing facilities are private businesses, so I'm not really sure I know what that really looks like. LD 1386 is focused more on beds and developing contracts with providers for those beds. And I just had a quick question about whether there was a reference to 30 bed hold days. I assume that's 30 bed hold days a year, but I'm not really entirely sure. And this, for those of you that were on the committee in the past, LD 177 was in the 129th, and that LD 1386 is clearly modeled on that, with some updates for, you know, the fact that we're in the 130th as opposed to the 129th. And we haven't yet received the preliminary fiscals from OFPR for either of those bills.
Any comments, questions from the committee? As I remember the discussion from last session, there was at least some consideration of whether there would be construction costs relating to making the doorways wide enough and things like that. So it's hard to imagine this going forward without some sort of fiscal note. But then you'd have to figure out if that was for all the beds or some of the beds as they came online. Maybe we'd learn from the first year and know more for the second year. But at least the phased in option is in 1386. Any comments from folks? Yes, Representative Craven.
Thank you, Mr. Chair. Could we have an amendment that would make it more specific so that OFPR would be able to actually offer a, offer a fiscal note, like 2 beds a year or something like that, and then that would probably not be able to include further construction or whatever, but
So you're looking for a clarifying amendment that would allow OFPR to do a fiscal note.
Mhm.
Okay, Representative Javner?
Yes, thank you, Mr. Chair. I see from the testimony from the department that they are stating that, this is going to cause perhaps more problems than it will solve. Is Ms. Probert here from the department, or can Molly address that specifically and how they would want us to address that in this bill? I mean, I want to support this. I don't want to make more issues for, department than necessary.
Ms. Bogart.
Morning. Thank you. I think the gist of our testimony on both of these is just that more clarity about exactly how you would like us to implement this would be helpful. I think certainly we want to make sure that these services are available to folks and there are mechanisms to pay for them through main care. I think especially, and I'm going to forget which number it is, but one of them has us developing specific physical placements across the state. And I think that one creates some challenges for us as to implementation, to making sure that those are available to the folks who need them, and that we have clarity what the expectations are around how much, physical plant changes we would be offering and how we do those in an equitable way. So, are they in the right level of care? Are they in the right geography? Things like that. So I think that the gist of our letters are that more clarity would be helpful, because as drafted, we don't feel as though it offers exactly what we need, similar to the bills last session.
Okay, so the more prescriptive then that we can be, the better for the department.
Right. And I think a number of us recognize the problems with LD 423, which is the bill that you referenced, Molly, which is a step or two away from a concept draft. Okay. Yes, Representative Meyer.
Thank you, Mr. Chair. In light of that last comment just made on 423, I would move that 423 ought not to pass.
I second that.
The motion's been made and seconded that LD 423 ought not to pass. Is there discussion about that? Any questions? Ms. Withy, can you run the vote? The motion on the floor is ought not to pass on LD 423.
Representative Zager.
Yes.
Representative Zager. Yes. Representative Lemlin.
Yes.
Representative Lemlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry. Representative Perry is absent. Representative Griffin.
Yes.
Representative Griffin. Yes. Representative Connor.
Yes.
Representative Connor. Yes. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan.
Yes.
Representative Madigan? Yes. Representative Javner?
Yes.
Representative Javner? Yes. Senator Moore? Senator Moore is absent. Representative Meyer?
Yes.
Representative Meyer? Yes. Senator Claxton?
Yes.
Senator Claxton? Yes. That's 10 yes, 3 absent.
Okay, so that leaves us with consideration of LD 1386. Are there any thoughts, questions, comments? So Ms. Bogart, with eliminating 423, are there still questions for which the department would like some additional clarity?
Let me pull that up just very briefly.
Okay. All right. So any thoughts about how to get a clarifying statement in there to allow for a fiscal note to be generated? Any thoughts about how to do that by setting a number per year, setting a limit? Any thoughts from Anna about how that might be accomplished to give OFPR a little firmer ground to stand on in terms of doing a fiscal note?
I mean, I'm sure that Luke has just been busy with the budget as opposed to not having gotten to this, but you did have some conversations about how you would want to bring them online. And I know that was one of the suggestions that Lisa Harvey McPherson made, for example, that you might not want to bring them all online at once. Right. It's up to you how you want to go about doing it, but I don't want to, and also Luke will get information from the department, so that is also part of this process.
And the other variable in here, let's ask, Lisa has joined us. Good. Miss Harvey McPherson, welcome.
Good morning, thank you.
So we're in the process of discussing LD 1386. I think you've been listening. The question is, do we need to put some guardrails on it so that we can get a fiscal note and make it manageable and learn from the process?
Okay. I think what may provide clarity around a fiscal note is removing from the bill a request for information and just determining that as a committee, we will set a number of beds that we want. We put the request for information in there because we do know that there are nursing facilities that are interested in expanding their scope of services into the specialty area. And we wanted to have a process to gather information, but you could sidestep that process, set the number of beds. That helps with the fiscal note. And then the department could work with the provider community on establishing the rate and determining where those beds will be located. I think that makes it cleaner. And Molly, I don't know if you want to share thoughts on that.
Sure, I think that would be helpful. I think, as long as the committee does not have any sort of intent beyond us making decisions based on that process that's outlined in the RFI, then that certainly is helpful to us. If there's a clear thought in the committee's mind that they want 16 beds of a certain, care level, that would be helpful to have in there. But that should be fine.
Traditionally, the committee has made recommendations based on needs-based assessment. And I don't think we've adequately done the kind of assessment that needs to be done and develop the kind of proposal that needs to be developed to turn that into real specifics right now. How about if we add a proviso that no more than 4 beds a year? That would make it up to a 4-year process as the way the bill's written. That way we could learn from what we've been doing about what was involved. We might also, so just a thought. Representative Craven?
Thank you, Mr. Chair. As to Lisa, really, do you think that there would be a lot of reconstruction regarding opening up doors and other kinds of construction to be able to build? So I figured that there would, but then if you're limiting so many beds each year, is that going to have people having to do construction every year as opposed to a one-time reconstruction?
I think the construction will depend on the age of the facility. When a lot of the older nursing facilities were constructed, we just didn't have these very, very large patients, particularly in long-term care facilities. Some of the newer facilities, I think, have a physical plant structure that is more accommodating than our older facilities. So I think that's going to be part of the determining factor on construction.
And just for the reference, the major need for the wider bed is for the bigger bed. The wider door is for the bigger bed, right? Yeah.
Yeah. It's wider doors. Sometimes it's bracing the floors. Sometimes it's bracing the ceilings, depending on the lifts. It's reconstructing bathrooms with special equipment.
Access.
Yep.
Yeah. And also making for more room. If you expand the bed and you expand the bathroom, then the room shrinks unless you do some construction.
Yep.
Okay.
And I can also answer the 30-day bed hold question that Anna raised.
Go right ahead.
So when we talked about this last year, typically when these individuals are hospitalized, they have a high number of comorbidities, so they tend to have a longer length of stay in the hospital. So because these beds are unique for these individuals, we wanted to extend the bed hold so that they would have the bed to return back to.
Ah, okay. And that's 30 days in a year.
Mhm.
Okay. How are we doing on specificity, Ms. Bogart?
Good. And I hesitate always to add more information, but the folks at the Division of Licensing are listening in and mentioned that perhaps the certificate of need process would be helpful in determining where these beds might be best suited. And so I offer that for your consideration, but I know that's a new wrinkle as we're close to closing this conversation. So leave it to your judgment.
Thank you for that contribution, Ms. Bogart.
And when,
Yes, Ms. Harvey McPherson.
So generally, because these patients are difficult to place, the long-term care ombudsman, their care team that assists with hospital discharges, works with these patients. And so they, I think, probably have the most comprehensive statewide data on the number of bariatric patients that they've worked with to try and place them.
Okay. Yes, Representative Craven.
Thank you. Is Brenda here?
She is.
Could we hear from her?
She's going to join us shortly. Welcome, Ms. Glenn. Welcome, Brenda.
Good morning. Trying to get you so you can see me. We had 12 referrals from hospitals last year, and then the year before that 8. So that's sort of, and those numbers are fairly consistent. But as I testified, it's really a long process to get people admitted. And I really think because of low occupancy in our nursing homes, I think the nursing homes, it would be very beneficial both to the residents that need care and to facilities to enter into some specialty care. And we definitely need these beds. And it would be just a much more efficient process if we had a few for people to move into, because they do sit in the hospital for a long time, sometimes months. So
thank you. So this is somewhere between a study and a specific directive, because we don't have all the information we need for sure about who and where these should be located and who's interested in having them in their facility. So there's that step. We also have the clear request for a shortened cycle in terms of, as it stands now, applying for a prior authorization. That could be worked out independently of the other issue if we decide to go down that route, or ought to be a separate part of this. Because that sounds like the most pressing need that providers have is a consistent shortened process for getting an answer to what we're going to get paid for admitting patient X. Am I reading that right, Brenda?
Yes.
Okay. So I think that's a high priority for the sponsor of the bill, who unfortunately isn't with us, right? I don't see her. So I want to respect that. And we also have the question about bringing some of these beds, making some of these beds available, which is physically a separate step. Okay. So one of the proposals, let's go to the specific proposals I've heard. One is eliminate the RFI. Does that help the department, Molly, in working through this?
I'd have to talk to the folks who are going to implement it. I do think that eliminates some of the information that would help with the decision making. And so, I would appreciate, I think, Lisa and Brenda's thoughts on whether that would still get us to a result that they would be comfortable with.
Ms. Lynn?
Oh, well, I think you could even just, I think that we could just have an informal work group involving Maine Healthcare Association and just reach out to providers and have a conversation about here's the need with interested parties and begin the process that way. I mean, it doesn't have to be, and then we could just proceed further with those that are interested, if that makes sense. I don't know what Lisa thinks about that, but that would eliminate that first step, because very quickly you would know which corporations and owners are interested in doing this. And I think there would be a few, probably not a large group.
I think the concern of the department would be identifying where the nexus of that interest and then also the need is. And so if we think we can meet that through the work group, then that would be good. But interest is one piece of the puzzle, I think.
Yeah, interested parties. And so that eliminating the RFI, I'm not hearing lots of support for that as being helpful. Or is that too formal a process and should be eliminated?
Just to put a finer point on my comment,
Yeah.
Senator, I think, if the informal work group would get us where we wanted to go, it certainly would be more quickly executed than an RFI. And so, again, I'd want to make sure the advocates are comfortable with that. But from our perspective, eliminating some of the bureaucratic pieces like that can move things more quickly.
And I think moving that ahead without the RFI and with an informal work group sounds like it makes some sense. We've already talked about the shortened cycle. I think the CON comes in when you're going to spend money, and we're not there yet. So I would not look to add CON to a process we don't know yet, especially if there's several facilities who are willing to do this without capital cost. But we would depend upon the work group to help sort that out a little bit. Okay. All right. So that would accomplish, I think, some portion of Representative Craven's wish. That's much more specific. If we add something like the informal work group and no more than 4 a year, or how people feel about that.
I like it.
Okay. Is that something people can live with?
Yes.
Okay. So is there additional conversation? What I'm hearing an amendment so far is to eliminate the RFI portion and replace it with an informal work group, and to make specific the work of shortening the cycle for prior authorization by clarifying reimbursement, and do that as soon as possible so that process is shortened. So those are the two things I've heard so far that seem to have some support. And I see a puzzled look on Anna's face. That's always a bad thing.
I'm sorry, I'm a little confused about the PA versus the rules. And Lisa, you can tell me if I'm going down the garden path here. So I thought that the idea was that the department would adopt rules that were to establish what those reimbursement rates would be, right? So that's different from you. You wouldn't want a PA, right? Like that's the whole point. Or do you still have a PA? Is that still part of that? I guess it could be. I'm sorry, I'm flailing a little here.
Come on in. The water's fine. Yes, go ahead, Ms. McPherson.
So if we've established that we're going to do it, let's say, for example, 4 beds per year, and we have a rate for those beds, that's clear. If we have 12 patients a year needing this service, then demand exceeds capacity. So there will still have to be a PA process until we've kind of leveled out, built the build out.
Okay, thank you.
Okay. All right. Other thoughts? So the third edition would then be I made that up and people can push back, the 4 per year. I don't see anybody pushing back. So at this point, I think there's 3 amendments to the bill. So I'd entertain, yes, Anna?
Oh, I'm sorry. I just wanted to ask a couple of quick questions, whether the dates are still the same in terms of when these beds come online. And the second thing was whether I'm assuming that it's the department that would be doing the work group. I mean, with Brenda and
would be convening the work group.
Right. I just wanted to make sure that that was indeed what I'm hearing.
That's what I've heard so far.
And the dates remain the same in terms of when the beds come online. The first 4 beds come online.
Yeah. Representative Meyer?
Thank you, Mr. Chair. So I would like to make a motion that LD 1386 ought to pass as amended. Do you want me to list what we've agreed on?
Sure.
So that was eliminating the RFI in favor of an internal work group, no more than 4 beds per year, and shortening the cycle for the PA.
I second that.
And you said internal, but maybe informal is a better term to include multiple
Informal,
parties.
I'm sorry.
Yeah, multiple interested parties.
Yep.
That's considered a friendly amendment. Okay. All right, so that's been moved and seconded. It ought to pass as amended. Is there additional discussion? Very good. Then we'll go to Ms. Withy to run the vote.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry. Representative Perry is absent. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore. Senator Moore is absent. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 10 yes, 3 absent.
Okay. after some work, we've gotten to a good spot. Now, the next item on the agenda does not appear on our website, but we've been asked by the sponsor to, at least it didn't when I looked at it 2 seconds
He
ago.
advertised it.
Well, you may have advertised it, but it's not on the
Oh,
HHS hearing date under 426 that I see. Anyway, doesn't matter. We're going there. So we've been asked to reconsider LD 1139 at the request of the sponsor. So to do that, we need a motion for reconsideration. I see the sponsors joined us. Let's do the reconsideration. Anybody want to make a motion to reconsider? Moved? Seconded? Okay, so the motion to reconsider LD 1139 has been moved and seconded. In the interest of moving things along, can we do this with a show of hands? And then I'll report on the vote. All those who are in favor, looks like unanimous of those present. So the motion to reconsider carries. And then that opens us up to reconsideration of LD 1139. So I think we've heard some of the concerns. Do you have any additional concerns or analysis to share with us, Ms. Brum? No, we're going to go with what we had from before. So why don't we go to the author, Representative Libby, welcome.
Thank you, Mr. Chair, and thank you all for reconsidering as I was unavailable during the work session last week. I appreciate your consideration. I truly do wish that this bill were not necessary, and I've read through the reasons that it is thought to be unnecessary. And when I look through the CMS guidelines, because I do have those, I have the guidelines from last fall, I have the guidelines from last spring, and then the updated guidelines from March 10th of this year. Had those guidelines been followed throughout COVID, this bill would not sit in front of you. But it's here because Maine nursing homes have taken a fractured approach to visitation. And I'll give you a very recent example, an example that's ongoing right now. And that is my constituent, whose story I told you, and she then testified in the public hearing, whose father died in a local nursing home last summer after a very quick decline. Her husband recently had a stroke, and after hospitalization and rehab, he has now been discharged to a nursing home for continued rehab. And despite the fact that he had lab verified COVID in December, she has been barred from visitation for 2 weeks. She may be allowed to visit once per week for a kind of compassion care psych relief, because in the midst of this stroke, he has become understandably very emotional and confused and had a very difficult time with this transition. And that kind of visitation is not what the CMS guidelines calls for. And in fact, when they released updated guidelines last fall on September 17th, they noted in the rationale for the guidelines that compassion care was paramount. And they gave examples in the guidelines of what should be considered compassion care. And it's not just end of life scenarios, which is what Maine nursing homes have largely been treating it as. It includes a resident who is living with family before being admitted and is struggling, a resident grieving after a friend or family member has passed away, a resident who needs cueing or encouragement for eating and drinking, or a resident who used to talk and interact with others that is experiencing emotional distress. Those are all reasons that are supposed to be considered for compassion care visitation that have not been. And that was guidelines given out in September of last year by CMS. So if those guidelines had been followed, there'd be no need for this bill. But instead, there's been a lack of focus on these compassion care kind of visits. And as such, we've had a problem here in Maine with this kind of fractured planning. We have residents who have been allowed to see their family members because facilities were short-staffed and needed a family member to take them to doctor appointments or PT appointments, but then not allowed to visit them inside the home. So there's just not been any consistency, and visitation has been, it's been very arbitrary, depending on which facility you're talking about, where in the state. The other piece that has had little to no attention is the piece related to, and this is on page 3 of the guidelines from September, and it's been updated as well, but that facilities should use the COVID-19 county positivity rate. And if the rate was under 5%, visitation should occur according to the core principles of these CMS policies. And what we've seen across the state throughout COVID is that those the county positivity rates have not correlated with visitation and nursing facilities. So had these CMS guidelines been followed as they should have been by DHHS, by the Maine Healthcare Association members, this bill would be redundant. And so that is why this bill is before you guys. It's because the dozens of people who testified on this bill have been dealing with these inconsistencies and arbitrary guidelines for the last year, and it's been extraordinarily detrimental to their loved one's health, resulting even in death in some cases. So I'm happy to answer any questions. I am fully aware of the changes to the guidelines, and I would point you to the guidelines from DHHS from April 15th, indicating that the visitation policies, again, there's very little to explain what should be included in compassionate care. And according to CMS guidelines, as I said, it's not just end of life scenarios, and that is very much what it has been used as here in Maine, is that compassion care is only for those end of life scenarios and not the other ones, which are pretty broad, that I read from the CMS guidelines themselves. So I'm happy to answer any questions that you might have. And I do have the states that have implemented something like this, whether through legislation or through their own DHHS departments getting creative to make sure that the states didn't have an issue of failure to thrive. New York, Indiana, Minnesota, New Jersey, Florida, and Texas. Those all at this point have instituted some sort of essential caregiver visits, whether through legislation or not, to make sure that these failure to thrive situations are not occurring in their state.
Comments, thoughts, questions for the sponsor? Representative Craven.
Thank you, Mr. Chair. I wonder if we could hear from the Ombudsman.
Sure, we also have several other folks we can hear from too. So let's hear from Brenda Galland.
Hi, I'm Brenda Gallant, long-term care ombudsman. I would agree that it has been a very difficult process because of, as you all know, because of the number of outbreaks in facilities, the residents and staff that have been impacted. And I would say that at this point, our office has been available to work with families, to work with facilities when there have been concerns around visitation. I know there's been a lot of education on the part of the department and along with providers to talk about the CMS guidelines and to encourage visitation within those guidelines. Tomorrow, we're doing a webinar. We have 440 individuals signed up. This is focused on family information so that families are armed with information about what the guidelines allow, the resources that the Ombudsman program can provide. Bill Monteo, who's on and can answer questions around the specific guidelines, will be available to present the guidelines to families, along with Dr. Sears from CDC. So I want to reinforce that we are available to help. I would agree initially we had to do a lot of work with facilities around compassionate care and it was interpreted very narrowly. We did some work in that area. And again, I would just say that anybody that has any barriers can come to us. We are in regular communication with licensing and regulatory services. They can intervene, and there's just a lot of education that needs to happen, both for facilities to support them as they open up for visitation, and also to give families information.
Thank you. Before we go to Mr. Monteo, let's hear from Rick Erb. Would you like to join us? Welcome.
Morning, Senator, members of the committee. I can speak to this.
You want to introduce yourself just quickly?
I'm sorry. Rick Erb, President and CEO, Maine Healthcare Association. We represent the nursing homes and assisted living facilities. Regulations changed many times, but I think that there is a far better understanding of what is required. Facilities, I believe, have adapted. I think that there is much more openness now than there was, but there's much more clarity in the regulations as well. I really am proud of what our facilities have been able to do to adapt, particularly to the compassionate care visits. And I would agree, the definition of it is far broader than end-of-life care. There were individuals who were very important in interpreting these things. One is the medical director for the facility, who has an overall responsibility. And also, we're appreciative of what the Ombudsman Office has been able to do. To me, there are much clearer guidelines and regulations now. I think that this comes down to an enforcement issue, if indeed that there are problems. I don't believe that there are nearly as many problems as we were dealing with before. But in the instances, if there are, the state has the obligation to enforce regulations, and we understand that and believe that that's what they should do. I am concerned about conflicting standards between the federal government and what this legislation would require. It's a concern for me going forward. Perhaps others from DHHS can comment on that as well. That's really what I have to offer right now. This has obviously been a very difficult time for all of us, and I'm sympathetic to the families here. I think that we have a far better situation now and far better standards than we had earlier in the process.
Thank you for that. Let's hear from Bill Monteo. Welcome.
Thank you, Senator. My name is Bill Monteo. I'm the Director of Licensing. And as I mentioned previously, there has been a lot of additional guidance and clarification on visitation. And I understand yet back in December when the bill was put in, there was still a lot of confusion. I will be very honest with you. We are still engaging in enforcement and investigating complaints. As I mentioned previously, the Ombudsman acts as a mediator in many of these cases between family and facilities to kind of help resolve before it gets to an enforcement action to hopefully clear up the visitation issue. But the guidance that's out and the enforcement actions that we are engaging in, we still, even after these have come out, still get complaints. We are still going to be going out and investigating them. And I can tell you just from a case we've had recently, well over a year into this pandemic, with CMS having very specific guidelines regarding infection control, we are still finding infection control violations in nursing homes that we are citing to. So the biggest concern that I have with this bill, as I mentioned previously, is that it creates a conflict between the federal regulations in two areas. One is, as noted in the guidance from CMS, that CMS does not recognize an essential caregiver as anything other than a visitor, and would hold facilities to the same standards for allowing visitation, whether they're an essential caregiver or a visitor. The other big issue that I have with the bill and the language within the bill is it requires facilities to allow these individuals in at all times, regardless of CDC and pandemic. control measures, which puts them at odds with federal regulations where they are required to follow CDC guidance. We will continue. Whether this bill passes or not, we will continue to get facilities that don't fully understand that we are working with to try and clear, and we will continue to get enforcement actions going forward. But we are hopeful that we have provided a substantial amount of guidance. We do several calls with both providers and medical directors on a regular basis. And as Brenda alluded to, we have a call tomorrow with families where there was over 400 to try and provide clarification and guidance on the visitation standards.
Thank you for that. Are there additional comments or concerns? Did you have your hand up, Brenda?
Yeah, and I just wanted to reinforce for families, if if you have constituents that call you or you're aware of families that have concerns, call our program, because we will work with the family and the facility. And if the facility is not following the CMS guidelines, we will work with licensing, and you know that we will respond. Even I've had weekend calls where I've responded. So we will, we're committed to working with families and with the department on this and with providers.
Thank you for that. It seems to me, if I just might comment in a minute, that there's really two intents with this bill. One is to increase compliance and encourage enforcement. The problem I see is that there's no additional consequences, and having it in law isn't any more potent, as far as I can see, to a nursing home than CMS guidelines, which address reimbursement issues. So I'm not sure that it materially adds. If we were adding people for inspection, it might be helpful. The other intent seems to me to be establish a protocol. And my question always when we run into this is, does it belong in statute? Because then it becomes inflexible, and we risk, as somebody as Mr. Erb pointed out, conflicting intents with CMS guidelines. So the other thing I noticed was that in the language of the bill, an individual can designate somebody, but that automatically excludes the folks who are confused, because how do we know what their plans are? So that made me uncomfortable, and that isn't clarified and is part of what I consider a protocol and not statute. And the same thing applies for family and permission. Since a lot of these places are double bedded, how does the family going to feel having people visiting? So I think the protocol, as I told somebody this morning, the more I read the bill, the more I liked the concept, but I didn't think this was the right tool. I do think there ought to be some conversations about how to, some more conversations about maybe structuring a compassionate visitor or a concerned family member, or some other term that isn't used elsewhere related to marijuana. I do like that idea, and I think it deserves some more work. I'm not sure this is the vehicle to get that done. So that's a lot more pontification than I usually offer, but it's only because I think the concept is a good one. Yes, Representative Meyer.
Thank you, Mr. Chair. And you just reiterated many of the thoughts that I have around this piece of legislation. I wonder if either Ms. Bogart or Mr. Monteo might just refresh the committee's recall of the mortality data arising out of the last year in long-term care and similar settings.
Sure, I can do that. So I'll give you the same data that I gave you last week, which was from April 6th. Earlier this month. And at that point, 451 of the total 746 deaths occurred in congregate care settings, most of which were long-term care. And so that's 60.5% of the deaths across 83 different facilities. And we are in a different place in the pandemic now, but especially for the first several months, these congregate care centers were the epicenter of where we were seeing the outbreaks in Maine.
Thank you, Molly.
Senator Moore? Did you want to say something?
I'm sorry, Senator Clapp. Did you have a question for me?
I saw your light go on and I assumed you wanted to say something.
No, I was actually just getting back in. My phone, I lost service, so I was just dialing back in so I could listen.
Okay, very good. All right.
Thank you.
Any other comments that anybody would like to make? And yes, Representative Connor.
Thank you, Mr. Chair. I'm trying to read up on all of this and just wrap my head around all of it. My understanding of this bill is obviously we know COVID is new to all of us, and many different rules and regulations came about because of it. And, we're trying to deal with, the federal government and CMS guidelines and whatnot, and then what our state representatives all want to put forth for legislation. My understanding of this bill is, yes, our rules may have changed now, and people can go into nursing homes and visit their families now. But what happens during the next one? Because we all know that, now that this has happened, we're probably going to see something again in the future. So does this bill, future-proof us, if you will, to allow, family members, whatever we want to call them, whatever that semantics is, whether they're a visitor or a caregiver or whatever we call them, this bill will allow them to come in and follow the exact same protocols, safety measures that the workers at these facilities deal with. I mean, we just heard Molly talk about the number of deaths. My curiosity is, how did COVID get into these facilities if nobody was allowed into them? It had to have come from the workers. So if our protocols are going to be for the members going to visit their families, that they have to follow the exact same protocols as the workers that in the facilities, then I'm in favor of it. I just think that we should, as long as we're practicing the right protocols, we should allow these folks in to see them and make sure we're future proofing, all of this. And I agree with you, Senator Claxton. I think this deserves, much more conversation in how to flesh that out.
Representative Lemlin, you had your hand up.
Yes, thank you, Senator. Just like I stated before, in my opinion, if there's a high death rate, then I think there's a higher need of visitation. And so that just proves the other point, in my opinion. And again, if anyone can go into the room, meaning a doctor, a nurse, a caregiver from the facility, if you can prepare them to go into the room, you can prepare a visitor to go into the room. So there's really absolutely no reason not to have visitors, because you can protect them as much as you can protect the care workers, and you can teach them how to put it all on and make sure that they take it all off properly. And so there's really no reason to stop visitation. None at all. Thank you.
Representative Craven.
Thank you, Mr. Chair. My question is for Mr. Montiel. Did he go away?
No, he's still here.
So I just wonder what in an emergency that federal law supersedes state law at any rate, and we would have to follow the CMS guidelines, the CDC guidelines in an emergency. Is that right?
So in the nursing homes are required to follow federal CMS conditions of participation for nursing homes. They are required to have an infection preventionist and have a very complex infection control and monitoring program. But the federal regulations also require them to comply with CDC guidelines. So whenever there's an epidemic or a pandemic, it would be the CDC guidelines that would come into play for the nursing homes. So the concern is we could potentially have a state law that's in conflict with federal conditions of participation, and the nursing homes would end up being cited for violation of one, and they would end up having to choose which law am I going to break. And Rick Erb could could probably speak more to this, but if I was a nursing home administrator, I'm going to choose the one that's going to fine me the least because I can't comply with both.
You had your hand up, Representative Meyer.
Thank you, Mr. Chair. Could Mr. Erb comment on compliance and making those kinds of decisions?
Certainly. Rick Erb, Maine Healthcare Association. It's a no-win situation when you have conflicting requirements. You know, my instinct would say that the federal standards trump the state ones, but in all honesty, you could be cited and fined for either one. So either way, you have broken the regulations. So no-win situation.
Yes, Representative Connor.
Thank you, Mr. Chair. Mr. Montejo, could part of your plan that you had mentioned, you had to have an infectious plan in place. Does part of that plan have visitation in mind? Is there something in your plan that regards what you do for visitors if visitors are to continue coming in?
CMS conditions of participation have everything as a patient-centered or resident-centered, which means the visitation is resident-specific. And one of the concerns is if you have dual occupancy rooms, how do you allow for visitation that doesn't impede on the other resident in the room? The guidelines that CMS has put out on this, currently the revised ones that came out on March 10th address that, and there are very limited circumstances currently where visitation could be denied. Probably the biggest one, which is still occurring, and Molly gave you the numbers on the death rate, but we are still seeing, as Dr. Shaw, I'm sure, mentioned to you earlier this morning, breakthrough cases, and they're predominantly occurring in nursing homes because we are still testing staff in nursing homes, and that's where the majority of the 104 cases that you're hearing of people who have been fully vaccinated who are still contracting COVID are occurring, is in these congregate settings. There was an article that came out this weekend in the New York Times that referenced how an unvaccinated healthcare worker in a long-term care, one unvaccinated healthcare worker resulted in 22 COVID positive cases in the nursing home. And the majority of them, thankfully, were no symptoms or minor symptoms. And we are seeing that in Maine when we have outbreak cases. We test staff and we find one positive staff. The regulations say that you would stop visitation to conduct testing of everybody, or if the CDC directs, just that one particular unit. But as soon as you get the results back, if there's no other cases, you immediately reopen for visitation. So the guidelines right now are much more visitation focused and centered. Facilities should not be closing the entire facility. They're really taking a more surgical approach of just limiting the unit, but still allowing for external visitation, still allowing for compassionate care visitation, which is much broader than it was originally interpreted. So we are, making more clarifications and efforts, and facilities. In my experience, there's always going to be a handful of facilities that are going to take an extremely conservative approach, because the reality is these facilities don't want COVID in their facility. It spreads, especially with these new variants. They're trying to really keep people safe as much as possible. But the majority of facility administrators that call us are calling us for guidance saying, we have one case, can we clarify the guidance? We want to allow for visitation. How do we do it? It's that we're not getting as many calls from facility administrators saying, how do I restrict my visitation? And many of them are coming on board.
Follow up, if I may, Mr. Chair.
Sure.
So just so I'm understanding you correctly, Mr. Mateo, you said a lot of the 104 breakthrough cases were with staff in the congregate facilities, or with the residents?
It's a mixture of both. What happens when there's the current guidance is when there's one positive case and facilities are continuing to test on a routine basis. They're testing staff. When there's one positive case, they then test staff and residents, and they're finding in some cases it's just staff, in some cases it's staff and a mix of residents. But so far that I'm aware of, out of the 104, we have not had any residents who have been fully immunized and still contracted COVID who have died or needed to go to the hospital. In most occurrences, it's minor symptoms.
Thank you. That's all I have, Mr. Chair.
Thank you. Representative Javner.
Turn my video off again. Mr. Monteo, at any point in this last year, in a couple months, when have the Maine guidelines differed from federal guidelines?
There has been a couple of differences. One is we, as you are aware, we put in a infection control emergency rule for a licensing rule early on. That rule was mirrored actually by the federal government 2 months after that rule was implemented. We've also in Maine early on in the pandemic put in a requirement for facilities consistent with CMS, which gave the state the authority to do this, that rather than follow the county positivity, we're using the number of new cases per 10,000 in the county to determine testing. And so testing frequencies in Maine were occurring at a much greater rate than they were at a national level. And that was so we could monitor what was going on in Maine. But that was also allowed under the CMS provisions for us to do that.
If I may, Chair.
Sure.
Thank you. So from my understanding then, there has not been what quote unquote major conflicts between the two guidelines.
No, a state can implement standards that are more restrictive than federal, but not less restrictive than federal, and also not in conflict with federal.
Thank you.
Are there any additional questions or discussion? Representative Meyer.
Yes, thank you, Mr. Chair. I just want to remind the committee about what this bill actually would allow. So it would allow multiple visitors at any time throughout a facility, no regard for roommate privacy or preference. Although it says facilities may restrict essential caregiver contact with other residents, anyone who's ever worked in or even visited a nursing home would know it's likely unrealistic to expect that could be managed or monitored effectively for every resident at any given time. Considering most rooms are semi-private, the potential for contact with other residents is great, and that increases risk. The bill also allows essential visitors at any time, regardless of Maine's county positivity rates, and allows for continued visitation in an outbreak situation. This is in direct conflict with regulations and with evidence-based practice with regard to infection control and visitation. So I just want to make sure we are centered on exactly what this bill is going to allow.
Representative Zager.
Thank you, Mr. Chair. I guess I'm not understand. I thought I understood that this would put nursing homes in having to choose between following state or federal law. But in light of what Director Monteo just said, if it's if federal law trumps the state law, then is this permissible?
No.
If I may, Senator.
Please.
If you were to pass this bill, it would be a state law that the federal government, and I am not a federal government expert, the federal conditions of participation and federal regulations would override or supersede. So what passing of this would do would be put a potential conflict for facilities to, if they allow the visitation, regardless of the number of visitors, and in conflict with the federal regulation, they would be in compliance with this, but out of compliance with federal regulations and would be cited federally. And that would impact both their nursing home 5-star rating and also be public record. Now, if they comply with federal regulations, they would be out of compliance if they restrict essential caregivers with this statute, which would then put them subject to any sanctions that under the rules, the state licensure rule for violation of a state statute. So that's the concern that I have, Representative, is that this creates conflict that I can perceive many of the facilities having to choose, what am I going to comply with, the state law or the federal condition of participation, because I can't comply with both.
Does that answer your question?
It doesn't. I appreciate the explanation, Mr. Monteo. I really do. But I guess I'm not understanding how the state would have authority to enforce something in direct conflict with federal law. But maybe that's a more general discussion for another day. I'll defer. Thank you. I appreciate it.
Representative Madigan.
Thank you, Mr. Chair. Representative Zager just asked my question, so.
Representative Griffin.
I was wondering if it would be okay if the sponsor of this bill talked about the federal versus the Maine CDC.
Sure. No, you're welcome to. She's welcome to put her hand up anytime she wants to contribute. Ms. Libby, Representative Libby.
Thank you so much, Mr. Chair. I'm sorry, I would have raised my hand a long time ago, but I was not sure of your committee policy.
Oh,
and
sorry, I thought I included.
We don't generally do that in our committee. I'm happy to speak to the federal. As I had said before, this bill would not be before the committee if the nursing homes and DHHS and various offices across our state had simply followed the CMS guidelines from the beginning. It seems like we're getting down to a discussion of semantics. I am literally going to read from the CMS guidelines, and it says right here that compassionate care visits should be permitted at all times. And what I'm asking for in this bill is that compassion care visits, be understood fully to what they should be and what they should have been since last year, so that compassion care visits are extending beyond half an hour visit for family members immediately preceding death, but be fully applied to what the federal government has laid out in the CMS guidelines, and then that simply be followed. So whether it's the essential caregiver verbiage that is objected to, I'm certainly happy to change words to simply put in compassion care visits instead. But I would bring your attention to the fact that I haven't seen headlines of Indiana, Minnesota, New Jersey, Florida, and Texas lacking reimbursement for their nursing homes. This is not a new concept. This bill is modeled after other states. And if they are still getting reimbursement, why on earth would Maine be unable to get reimbursement for simply following the CMS guidelines that are before us?
Representative Stover.
I had a question for Mr. Monteo. I don't see him here, but I'm sure he's here. It was a follow-up to Representative Zager's question. I just wanted to clarify, when you said that there could be sanctions to the violation of federal law, did you mean fines? Would Maine facilities be fined by the federal CMS for violating the federal rules?
Yes, they could. The CMS regulations require a determination of what's called the scope and severity on how the impact has. If it impacts one individual or many within the facility, changes the designation of the scope and severity, and facilities would be subject to fine.
Thank you.
Any Mr. Erb.
I'd like it to be clear that Bill Monteo's organization is required to enforce federal regulations. It's not that the federal government comes in and makes those decisions on enforcement. The Division of Licensing is required to do that. In fact, nursing homes are essentially regulated by the federal government, not by the state government, and they are required to enforce federal laws as well as state laws. The other thing I would point out is that many, if not all of those states that have adopted compassionate, the caregiver language, have done so as a recommendation, not as a requirement.
Representative Libby?
Thank you. I did want to address one more concern, which I think is very valid, but that is the concern that people coming into the facility would be disrupting things for a roommate or something like that. And I do want to point out that the fact that compassion care visits are, according to CMS guidelines, to be permitted at all times addresses that. It is at all times, regardless of county positivity rate or however that is being calculated. It is that compassion care visits should be permitted at all times, very clearly to be following the protocols, the safety and infection control protocols set in place by the facilities and by DHHS. But that's already in place, that compassion care visits are allowed. So there's no additional concern that a roommate would be disrupted because it's already allowed by CMS guidelines. My bill will simply, at the state level, say that we need to follow the CMS guidelines that are already in place at the federal level.
Thank you. Representative Craven, and then Representative Meyer.
Thank you, Mr. Chair. This is from Mr. Monte again. And so Representative Libby cites the regs from September. And I haven't looked, but was there emergency regs issued after that continued through the pandemic?
The federal CMS regulations and the guidance for September would have been in play. And I don't know off the top of my head of when our emergency infection control rule went into place. But we've had and continue to provide a lot of guidance and clarification to facilities regarding the regulations. And the long-term care ombudsman has really done the lion's share of trying to help mitigate and resolve complaints regarding this. But the September guidance document that was issued would have been the regulations that facilities would have had to comply with. There have been several CMS guidances, particularly as it relates to testing and visitation. The current one, which is the revised guidance that came out on March 10th, is the one that is in place now, and the one that we have been providing a lot of guidance and clarification to facilities, and the one that we are enforcing.
Representative Meyer.
Thank you, Mr. Chair. I'm looking for where in the bill compassionate care is referenced.
Yes, Representative Libby.
Thank you. As I said, it's an issue of verbiage. The essential caregiver, it talks about an essential caregiver being able to provide assistance with the activities of daily living. And when you look at the statistics across the country of weight loss and mental regression and failure to thrive that we've seen in states that have done studies on the topic, having family members in, or whoever they should choose to fill that role to help with those activities of daily living. That is that compassion care idea. And when you look at the CMS guidelines, and let's see, the updated March 10th version talks about the compassionate care visit. examples, such as the resident who was living with their family before being admitted and is struggling with a change of environment and lack of family support. Someone had testified in the public hearing on this bill to that very scenario. They were not allowed to help in March. After these updated guidelines came out, their father was admitted to a facility and they were not allowed to visit to help with the compassionate care visits as outlined in CMS guidelines. They were not allowed to be in the facility to help with the transition. Then a resident who was grieving after a friend or family member recently passed away. It was his own stroke, but I give you the example of my constituent who this week is not allowed to visit her husband, who is crying frequently such that it's interrupting his progress recovering from his stroke, and is actively not being allowed to have his wife visit the nursing home. That's a compassion care visit. Then a resident who needs cueing and encouragement with eating or drinking. There was someone who testified about their father losing 30 to 40 pounds before they took him home. And he then died in their home because he was not able to have his family who had previously been visiting to assist with eating and drinking there to cue him. A resident who used to talk and interact with others and is experiencing emotional distress, seldom speaking or crying more frequently. That has been a frequent case that I've heard of from folks who've contacted me, that their loved one is unable to talk with them on the phone or via Zoom, that they simply cry and are not interacting even with staff anymore. That is, again, in the CMS guidelines from September 27th, updated March 10th. That is a reason that they should have compassion care visits, whether you want to call it essential caregiver or compassion care visits, one person named to have compassion care visits with their loved one. That's all semantics. These residents should have someone who is authorized to come in and visit them, regardless of the way that Maine has decided to arbitrarily allow visitation that has not been in line with the CMS guidelines. There are so many compassion care examples I could give you that have been ignored. So essential caregiver, compassion care, I don't care what we call it.
Representative Griffin.
Along with, thank you, Senator Claxton. Along with what Representative Libby just said, I was wondering if there's a way to change the rules or make an amendment where in a long-term care facility, a family member would be designated as a family advocate, just so that patient, that loved one has somebody there that's watching over them. And it would just be possibly that one person, so you wouldn't have any of that contact that is a concern. That's just a thought I had. And that way, you know, the testimonies that Representative Libby just talked about that wouldn't happen because they would have that family member watching over them. Thank you.
Are there any other thoughts or suggestions? Anything different that people want to bring up or questions they want to raise? I'm not seeing any. I would entertain a motion then. Representative Meyer.
Thank you, Mr. Chair. I would move that LD 1139 ought not to pass.
Second.
It's been moved and seconded, ought not to pass. Is there additional discussion? Not seeing any, we'll defer to Ms. Withy for collecting the vote.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
No.
Representative Lemlin, no. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry. Representative Perry is absent. Representative Griffin.
No.
Representative Griffin? No. Representative Connor?
No.
Representative Connor? No. Representative Craven?
Yes.
Representative Craven? Yes. Representative Madigan?
Yes.
Representative Madigan? Yes. Representative Javner? Representative Javner? No. Senator Moore?
No.
Senator Moore? No. Representative Meyer?
Yes.
Representative Meyer? Yes. Senator Claxton?
Yes.
Senator Claxton? Yes. That's 6 yes, 5 no, 2 absent.
So at this point, we can thank the sponsor for bringing this forward, for identifying so that there's lots of work yet to be done in getting visitation to match up with guidelines, and for a animated conversation. Representative Griffin.
I just wanted to thank the chairs for allowing reconsideration on this bill. Thank you very much.
Yes, Representative Connor.
Thank you, Mr. Chair. I didn't want to overstep my bounds with my lead, but should we have a minority report?
We should. And that's not overstepping your bounds. That's being helpful. Thank you.
There you go. Thank you.
That's so Anna doesn't have to yell at me. So the minority report.
Ought to pass and hopefully amendment.
Did you want to speak to the amendment?
Well, I'd like to add something if it's along the lines of having that one designated family member that would be able to come into the long-term care and nursing facility. But I'm willing to work with Representative Libby on that.
Is that okay with the rest of the folks in the minority?
I'm sorry, I'm not understanding the difference between what's in the bill and the suggestion. I'm sorry, I don't mean to be dense, Representative Griffin, but I'm not understanding at all.
Okay, from what I understood was that the concern was that more than one visitor was coming into the facility.
Oh, I'm sorry, then I am misunderstanding. My understanding is that each person can have one designated person, but the bill doesn't address how many people are in the facility at the same time. Are you suggesting that, and I'm not trying to tell you, are you saying that the facility would have some control over who comes in, or not who comes in, when they come in? Is that what you're saying? So that you don't have several people in one room at a time? Is that what you're saying? Because the bill currently only has one person per resident at the moment already.
For the individual?
Yes.
Okay. Well, is it possible to just work with Representative Libby on this before or do I have to say something right now?
I think it's mostly at this point, I mean, I'm turning a little bit of a blind eye here. It's mostly important that Kerry can put down the right motion right now. And it sounds like the minority report is ought to pass as amended, and that you'll, like I said, you're supposed to say what you're looking for, but I'm going to turn a blind eye on this because I'm hungry. And we can figure that out later.
Okay. Thank you for being patient for me. I'm on a learning curve here.
That's okay. I have no problem with that at all.
An amendment to be determined, right? Okay.
Right. Thank you.
And you'll let us know when that's ready for language, as part of language review. Yeah. Okay. Very good. Is there any other business to come before us this morning? Yes, Senator Moore, you never had a chance to introduce yourself.
And say goodbye at the same time, right? Thank you for, I've listened to the call all the way while I was doing my Meals on Wheels, but I'm Mary Ann Moore and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan as well. And I guess I was just asking if it would be possible for me to record the votes that I was not able to file earlier throughout the day.
That would be yes, and I will stay and visibly verify, and everybody else can go to lunch.
Thank
Except for Carrie, I guess. Did you want to run the list, or did you, Carrie, are you ready?
Sure thing. So we have LD 415, which was being reconsidered, and the motion was ought to pass as amended, with the current vote being 10 yes.
Then I will record my vote as yes as well.
Okay, and then we have LD 822. The motion was ought to pass as amended, and the current vote is at 10 yes.
I will also record my vote as yes on LD 822.
LD 1324, the motion was ought to pass as amended, and the current vote stands at 10 yes.
And I will record my vote as yes as well on LD 1324.
LD 423, the motion was ought not to pass, and the current vote stands at 10 yes.
And I will record my vote as yes on LD 423.
Lastly, LD 1386, the motion was ought to pass as amended, and the current vote stands at 10 yes.
And I would like to record my vote as yes on LD 1386 as well.
And that was the last one. Thank you, Senator Moore. I have all of those votes down.
Thank you. I appreciate that. Now go to lunch.
All right. I'll take that as a motion to adjourn until 1 o'clock.
Sounds like a plan.
All those
you.
in favor? Thank you for the motion. See everybody at 1.
Senator Claxton, would it be possible for me to give Carrie my votes right now and get that over with?
If Carrie's available and wants to do that, can we do that right off,
Ask
Carrie?
here.
Yes, Representative Perry, give me just one moment to grab the vote sheets.
Okay.
We missed you all morning and now you show up and you want special treatment.
Of course. I won't tell you the mind fuzz that I had. I got so busy trying to get a present out for my grandson and mailing
Okay.
and stuff that I lost all track of what I was doing.
We'll consider that a semi-excused absence for the grandkid.
Yeah, right.
I wondered what happened, Anne. I was like, wait a minute, I saw her this morning.
I know. You know, no.
Okay.
I realized that about
Was
noon.
the pillow you made for him?
Yeah.
Let's get this. Representative Perry, can you talk to Miss Withy and I'll watch?
Okay, here we go. LD 423 ought not to pass.
Okay.
LD 822 ought to pass as amended.
Okay.
LD 1139 ought not to pass.
Okay.
LD 324.
1324.
Yeah, 1324, I'm sorry. And that's an ought to pass as amended. I think was
Yes.
it. Yeah.
Okay.
And then LD 1386, also an ought to pass as amended.
Okay, thank you.
Yeah, thank you. And my apologies.
Just don't let it happen again. All right, so welcome back to the scheduled afternoon session for the Committee on Health and Human Services. This afternoon is a work session. We'll be hearing several bills related to dental health and a couple others are related to behavioral health issues. Welcome. Glad you could join us. If you go to legislature.maine.gov on the internet and look up Health and Human Services, you'll be able to find our website. We have a link there to our YouTube channel. Everything's recorded, so you can go back and view prior episodes of this continuing saga, or you can watch live today. We'll be taking testimony in a somewhat different form this afternoon. We'll hear the first three bills, 62, 72, and 996 in order. We'll ask the sponsors to present those, and any co-sponsors will be invited to speak to those bills, and then we'll hear from the public. A quick calculation suggests that there are probably 60 people who'd like to testify on the dental bills. So we'd be grateful if you didn't repeat, but help us understand your particular story as it applies to these bills. This is a public hearing. We might ask some clarifying questions, but mostly this is the public's opportunity to share their thinking about particular bills. So that'll be the afternoon agenda. Yes, Senator Moore, did you have your hand up?
Yes, I did. Thank you, Senator Claxton. Will we be running a 3-minute clock or a 4-minute clock?
We'll be running I think with 30 people, I think we should stick with a 3-minute clock.
Right, thank you.
And order takeout so for later on. All right. Thank you for getting that clarification. And I'm going to rely on Representative Griffin to remind us when we need to take a break for a few minutes in the mid-afternoon. All right. It's a team effort. All right. So let's go around and introduce ourselves. We'll start this time with Representative Zager.
Good afternoon, everyone. Good afternoon, Mr. Chair. Thank you. My name is Sam Zager. I represent District 41 in Portland.
Representative Lemelin.
Good afternoon, everyone. My name is Michael Lemlin. I represent District 88, Chelsea, Jefferson, Whitefield, and half of Nobleboro.
Representative Stover.
Good afternoon. My name is Holly Stover. I represent House District 89, including the towns of Boothbay Harbor, Southport Edgecombe, Westport Island, and part of South Bristol.
Representative Perry.
Good afternoon. I'm Representative Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Bering, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Representative Craven.
Thank you, Mr. Chair. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston, and I'll be leaving for a little while to go to education.
Representative Madigan.
Thank you, Mr. Chair. Good afternoon. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Representative Javner.
Good afternoon, Representative Kathy Javner, and I represent House District 141, which is located in Penobscot and Washington County.
Senator Moore.
Good afternoon. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan as well.
Representative Meyer.
Good afternoon. Thank you, Mr. Chair. I'm Representative Michelle Myers, serving Southern Maine's House District 2, which is Elliott, where I live, and parts of Kittery and South Berwick.
And I'm Ned Claxton. I represent Senate District 20, which consists of Auburn, where I live, Minot, Mechanic Falls, Poland, and New Gloucester. One of the things I forgot to mention in the introduction is that there are frequently technical glitches. We count on them regularly. We have some with marginal connections. We have some errors in voting, and sometimes we forget that we promised 4 minutes for the folks who are testifying on the first 3 bills. So if your testimony is in support of 62, 72, and or 996, we'll go with 4 minutes for those 3 bills. Yes, Representative Griffin.
Did you miss me in the introduction?
Oh, yes, I did, because I was saving the best for last. Yes, go ahead, Representative Griffin.
Good afternoon. I'm Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Cadescade.
I'm moving you and Representative Javner around on my chair seating, and sorry about that. All right. So any other business to conduct before? Oh, yes, we need to introduce our staff that tries to hold all this together, starting with Ms. Dooling.
Good afternoon. My name is Erin Dooling. I'm one of the legislative analysts with the Office of Policy and Legal Analysis, which is a nonpartisan office at the legislature.
And Ms. Withy.
Good afternoon. My name is Carrie Withy. I'm the clerk for the Health and Human Services Committee. If you need any assistance during the hearings today, you can email me at hhs@legislature.maine.gov.
And those 2 folks are the ones who help get us through a full schedule. So I see we're joined by Representative Brooks. And so this might be a good time for you to introduce your bills. Welcome.
Thank you. Thank you, chairs. Good afternoon, Senator Claxton, Representative Meyer, and the honorable members of the Health and Human Services Committee. My name is Heidi Brooks, and I gratefully represent House District 61, part of Lewiston. I'm here today to introduce LD 62, an act to promote cost effectiveness in the Maine Care Program and improve the oral health of Maine adults and children. And LD 772. Is it permissible to have both at once?
That would be blessed. Thank you.
Okay, great. And LD 72, an act to improve dental health for Maine children and adults with low incomes. We have a dental health crisis for many in Maine. Far too many Mainers are suffering from severe dental pain, infections, and dental deterioration. I know many people who have suffered with dental problems. One of my friends suffered with dental pain. She was finally able to see a dentist who recommended an extraction. Currently, Maine Care covers limited dental services. When she found a friend willing to give her funds to seek a second opinion, The second dentist filled the cavity and she didn't need to have an extraction. Many people are forced to go to the emergency room when they are faced with dental pain. In the emergency rooms, there are limited options. Last session, Representative Drew Katine introduced legislation to help solve these problems. LD 62 and LD 72 are reintroducing initiatives to provide comprehensive, preventative, and restorative services. LD 62 would add these measures and directs the Department of Health and Human Services to work with providers to increase acceptance of MaineCare patients. The department would also participate in an educational campaign as outlined in the bill and work on a 5-year report on the cost of comprehensive services and savings from decreased emergency room visits and medications. LD 72 includes the coverage from LD 62 and creates a financial incentive program to incentivize providers to accept MaineCare. Many dentists don't accept MaineCare, and many who do accept MaineCare have a limited percentage of MaineCare patients. Dental health is a vital part of our overall health. I strongly support 996, LD 996 as well, which will be introduced by Representative Fecto. It includes several improvements. And I appreciate your consideration of this important issue, and I'll take any questions.
Are there any questions for Representative Brooks related to her first the bills, the 62 and 72? Yes, Representative Craven.
Thank you, Mr. Chair. Thank you, Representative, for both those bills. Are you requiring the department to reimburse for preventive care as opposed to just, distracting teeth or giving medication for pain?
Yeah, that's the intent behind the bill. We all know that if we can prevent advanced disease, it will solve a lot of pain and suffering, and also it would be less costly. Dental issues are all encompassing. Many people are suffering with dental pain, and again, with the only recourse being emergency rooms and extractions, that doesn't leave a lot of options for restorative work and preventative care for the teeth, and it affects the whole health of the person.
Are there any other questions for Representative Brooks? I don't see any, so thank you for bringing these two forward. We'll be hearing next from Representative Fecto, and then we'll be going to co-sponsors. Welcome, Representative Fecto.
Thank you, Senator Claxton, Representative Meyer, and distinguished members of the Health and Human Services Committee. I am Ryan Fecto, and I represent my hometown of Biddeford. I also have the distinct honor of serving as Speaker of the Maine House. I am here today to present LD 996, an act to improve dental health access for Maine children and adults with low incomes. Public health experts and economists alike agree that LD 996 is a smart investment that will improve the health of Maine's people and save the state money in the long run. In Maine today, MaineCare only provides coverage for dental services to adults in emergency situations. In other words, in order to receive dental care under MaineCare, a Mainer has to wait until their health of their teeth and gums have deteriorated to the point where they are in tremendous pain and likely suffering from infection, and of course, at risk of loss of their teeth. The way that MaineCare delivers oral health to adults is irrational, financially wasteful, and promotes low quality results. It is at odds with the goals of the program, which should support the efforts of Maine people to live the most healthy and productive lives possible. Today, you will hear the stories of Maine people who have experienced a system that forces them to allow their health to deteriorate and for them to experience tremendous pain before spending even a single dollar to help them, and even then, only does the minimum amount necessary. This emergency dental care is often provided in a hospital emergency room or emergency dental clinic, costing far more and resulting in a worse outcome than if the patient had access to routine, preventative dental care. It is documented that for people ages 25 to 44 who are uninsured or have Medicaid, dental disease is the #1 reason that they go to the emergency room. In 2012, the MaineCare Redesign Task Force, convened by then Commissioner Mayhew, concluded that MaineCare provided $17 million in emergency room care that could have been avoided if the patient had received dental treatment in the community. And I'll just repeat that number again. That was $17 million in emergency room care that could have been avoided if the patient received dental treatment in their own community. Expanding dental coverage will strengthen dental networks and relieve our emergency rooms, bring new dollars to the state, and save Maine roughly $4 million a year in emergency dental care. As a child, I will never forget the day I was in middle school. I bit into a Rice Krispie square in my school cafeteria, and my molar crumbled into my mouth. My family didn't have dental insurance, and we didn't have access to regular dental care. And I needed an emergency root canal, but neither my mom nor my dad had the extra savings to cover this cost. Not only was I in pain, this caused a great deal of stress for my family. And so I can understand Maine families who are feeling this burden every single day. In today's dollars, that root canal would have cost $500 to $1,000 for a molar, or for a front tooth rather, and $800 to $1,500 for a molar. And an orthodontist might charge 50% higher, up to $3,000 in total. For a family on the edge without access to dental care, and I think for just about any family, this kind of cost is insurmountable and very difficult to achieve. Ultimately, it would likely lead them to resorting to the emergency room for care. An unexpected life event, like the one that happened to me in the cafeteria of my school, could cause a child great pain, and if untreated, a health-threatening infection, not to mention the social stigma around a missing tooth. Poor oral health is a contributor to far more serious and chronic conditions, including heart disease and cancer. This isn't just tragic, it's costly. If we keep going on our current path, Medicaid will continue to have to cover emergency services, and the state will face long-term costs from untreated dental disease, including chronic diseases like heart disease. Poor oral health is also a barrier to employment. By addressing dental health, we are addressing the workforce shortage Maine's business community is asking us to spearhead. Dental care is healthcare, and just like in other parts of our healthcare system, we realize the benefits of quality preventive care delivered in a primary care setting. 35 states already recognize this and include preventative dental care in their Medicaid programs. When we join these states, we will improve the overall health of so many Mainers who are at risk of the negative health impacts from poor oral health. Maine would save millions of dollars if we include necessary preventative and diagnostic treatment services in the basic benefit package for MaineCare. At the same time, Maine would protect the dignity of thousands of Maine people. It is common sense. Before I close, I'd like to mention that this bill has been years in the making. In February 2020, a similar version of this bill, LD 1955, received unanimous support from this very committee. It was a bipartisan measure that every legislator understood would be game-changing for the people in our districts. Unfortunately, when COVID-19 hit and the legislature adjourned abruptly, we sadly left this important priority on the table. I'm really thankful for your consideration of this legislation. I hope that you'll join me in supporting LD 996 and that you'll vote ought to pass. I'm happy to answer any questions. I would also note, as it relates to the economic perspective on this bill, that I think it also is a measure that fits within the 10-year economic strategy that the state released a few years ago. We know how important oral health is to employment. Oftentimes our smiles are the first impression we leave upon people. And so when you think of folks who are interviewing for jobs, we just know how important it is that that dental health, oral health be a part of the way in which we solve the shortage of employees we have across the state, and making sure that people can remain gainfully employed in all parts of the state, of course, both urban and rural. So happy to take any questions.
Thank you for that, Mr. Speaker. Are there any questions of the representative? I don't see any. So now that we've heard the presentation of the three bills, we'll go and invite legislators to speak in support, co-sponsors, beginning with Senator Moore.
Thank you. I wasn't expecting that. Excellent. Let me get my testimony up here. Good afternoon, Senator Claxton, Representative Meyer, and my fellow members of the Health and Human Services Joint Standing Committee. As you know, my name is Mary Ann Moore, and I proudly represent Senate District 6, which includes all of the Washington County, along with Winter Harbor, Goldsboro, and Sullivan and Hancock County as well. I am testifying in support of LD 996, an act to improve dental health access for Maine children and adults with low incomes. I also do support 62 and 72, but my testimony is based on 996. As noted by Speaker Fecteau, this bill addresses comprehensive preventative, diagnostic, and restorative dental service to the limited dental service currently available to Maine Care members 21 years of age and over. During my 9 years serving on the Calais City Council and 4 years as the elected mayor of Calais, my path crossed many constituents who struggled to obtain dental care they could not afford. During my campaign for the senatorial race in 2018 and 2020 to represent Washington County and several towns in Hancock County, I often met potential constituents who needed more than the emergency dental coverage, where they found their teeth being extracted to deal with oral health issues without any preventative dental services being covered by Maine Care. As a retired AT&T employee and now a state senator, I have been and am blessed to be able to visit my dentist every 6 months for a teeth cleaning and exam to assure my dental health remains good. So many in the state of Maine do not have this privilege. In my experience and studies as a healthcare educator, I know how important it is to have good dental care regardless of one's economic status. This bill addresses coverage for full and partial dentures under the United States Social Security Act Title X1X. I guess it's 11, I forget the number of my codes here. I am not, guys, with 18, yes, that's 10, and then that's 19, so it's 19. I am sure most of you have come across someone who is missing teeth and probably can't afford partial or full dentures. Often this becomes a hindrance for being hired for a job, as Representative Fecteau mentioned, or places them in a position where they remain behind the scenes rather than customer facing. At times, this could be a major health issue. Having served as a cancer patient navigator in Washington County, I would like to share a story about one of my clients who has since passed away. My client was diagnosed with throat cancer and encouraged to have his teeth pulled to avoid any gum issues that might occur after heavy radiation and chemo. After weeks and weeks of treatment, he struggled without teeth to eat the foods he loved, such as steak. As a patient of one of the locally federally qualified health centers, he was ecstatic to learn he could qualify for dentures under a special program they had made available for their Maine Care patients. The center chose to use their 340B, which is the prescriptive incentive program that is funded by our pharmaceutical companies. They chose to use their 340B monies to fund dentures for patients such as my client. Having dentures not only improved his attitude on life and himself, but allowed him to eat the foods he dearly loved before losing his battle with cancer. One last story I would like to share with you is one of a woman in substance use disorder recovery that I met at an Arise recovery benefit. She lost most of her teeth during her years of drug abuse. Now on the road to recovery, she is struggling to find a job and is ashamed of her smile when being interviewed by the potential employer. One of her major asks is not rental assistance or food assistance or housing assistance, but rather help in improving her smile. I hope you will join me in voting ought to pass on this bill to not only help citizens such as the two constituents I've mentioned, but those throughout the state of Maine who desperately need attention to their dental needs. Thank you for hearing me, and I would welcome any questions if you have any for me at this time.
Any questions for our colleague on the committee? We'll be easy on you. Next, we'll hear from Representative Stover.
Thank you, Senator. Good afternoon. As you know, my name is Holly Stover, and I represent House District 89, including the towns of Boothbay, Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol. And I'm here this afternoon to testify on behalf of LD 996, an act to improve dental health access for Maine's children with low incomes. As some of you know, I serve as the Director of Development for Lincoln County Dental and have for the past 4 years. Lincoln County Dental is a not-for-profit agency that supports the health of people in our community by providing access to high-quality, compassionate, comprehensive oral health care through participation in MaineCare and an income-based sliding fee scale. I write grants and raise money to help compensate for the funding gap that presently exists between MaineCare reimbursement and the actual cost of care for adults and children. We also provide funds for oral health services that are not currently covered under the MaineCare benefit. Imagine if you had a toothache greater than anything you had experienced before. You have an infection and an abscess that you can feel on your gum, and it throbs with every beat of your heart. You have exhausted over-the-counter medications, and your stomach feels like there's a small propeller inside running on high. The over-the-counter medicine does not work. You have had this happen before. You go to the emergency department, you receive a prescription for penicillin and maybe something for pain. In 24 hours, the throbbing and aching subsides temporarily, the swelling around the abscess relaxes, and for now, you have only a short reprieve of relief. You have MaineCare, but no one in your area takes MaineCare, and the other clinics out of town can't take you because they're overbooked with their own patients. You have no money, no options, and know without some type of treatment, this abscess will return. This isn't an unusual scenario for the people who do not have the type of insurance or the cash to pay in hand. Dental care still remains unavailable to them. LD 966 seeks to address this. Adult patients have severe and very complex oral health diseases. Frequently, there is a serious decay that can include abscesses and infections. And due to the lack of adequate coverage, there's a high utilization rate of our local emergency departments, other people have spoken to this, for treatment of oral pain and infection. The emergency department of a hospital is not the most effective or most efficient way to provide dental care. LD 966 provides a mechanism to encourage more dentists to participate in the MaineCare program. This will help to improve the overall health and quality of life who have limited access to dentistry. It will also reduce unnecessary emergency room visits for dental pain and infection. The provision of a public health campaign about the access and availability of oral health care is critical. There's very good evidence that's data-driven that oral health programs work. The more people know, the more likely they are to seek and engage in treatment. A great example of a good public health campaign is From the First Tooth. If you're not familiar with that, it's a pediatric oral campaign we have here in Maine that promotes oral health during pregnancy and for infants, toddlers, and preschoolers. This bill calls for a varied stakeholder group to help shape the comprehensive oral health benefit and reimbursement structures that will be needed to cover the costs. It also provides some data and information back to our committee that will be valuable in furthering the committee's understanding of the proposed oral health benefit and creative reimbursement structures to pay for this. Oral health is a major health disparity that impacts all aspects of a person's life. The lack of affordable and accessible dental care in Maine has resulted in greater numbers of people living with untreated pain and infection. LD 966 will be effective in mitigating the impact of infection and disease while improving the overall health of Maine people. In places where affordable dental care exists, people have improved access and subsequently improved health outcomes. Thank you again for the opportunity to testify on behalf of this bill today, and I urge you to please vote out to pass on LD 966.
Are there any questions for Representative Stover? So that is for 996, great. Okay, very good. All right, now we can go to Representative Sachs. Welcome.
Thank you. Can you hear me okay? Because my video will not work for some reason.
We can hear you.
Okay, we'll just have to be charmed by my voice. Thank you so much. Senator Claxton, Representative Meyer, and esteemed members of the Joint Standing Committee on Health and Human Services. My name is Melanie Sachs. I'm honored to represent House District 48, which includes Freeport and part of Pownell. I'm here today in a fit of enthusiasm and efficiency in full support of the slate of oral health bills in front of you today. I've come before this committee recently to discuss the need to expand healthcare services for children through school-based centers, several of which have oral health services attached. So you may not be surprised at my supportive testimony today. There is no shortage of data linking better health outcomes with dental care. As noted by the federal government's Office of Disease Prevention and Health Promotion, that oral, and I cite this in my written testimony, the link, so you can read it in greater depth if you wish. Oral diseases ranging from dental cavities to oral cancers cause pain and disability for millions of Americans. As Speaker Fecteau noted, the impact of these diseases does not stop at the mouth and teeth. A growing body of evidence has linked oral health, particularly gum disease, to several chronic diseases, including diabetes, heart disease, and stroke. I was an elected official with the National Association of Perinatal Social Workers for 6 years, an international board. And in pregnant women, poor oral health has also been associated with premature births and low birth weights. So very important aspect of oral health that's not often brought up. These conditions, according to the Office of Disease Prevention, can be prevented in part with regular visits to the dentist. This same report indicates the systemic disparities in care that are so often noted by this committee, where racial and income inequities exist in outcomes and access, are found in the oral health system of care as well. These oral health bills before you directly attempt to address these issues of inequity. I will note, Senator Claxton, that you said this afternoon is devoted to dental and behavioral health care. I will note a quote that has stuck with me from your esteemed colleague, Representative Stover, who once indicated that we do a terrible job for care from the neck up. And as she's shaking her head, and I would say that we have an opportunity this afternoon to remedy that neglect. Thank you for the opportunity to express my support for these pieces of legislation, and I'm happy to answer any questions.
Thank you for that testimony. Are there any questions, Representative Sachs? Not seeing any, we can go to Amran Osman to hear.
Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. My name is Amran Osman. I live in Lewiston, Maine, and I am here to testify in favor of LD 996. I believe that dental care is a must for everyone and is a human right. I came to America when I was 3 years old, and throughout my adolescence, my mother went out of her way to make sure I never had to think about dental care access. She put in so much time, effort, and work in making sure I had dental care. Once I hit 21, it felt like I was hit by a truck because I was unaware of how much I took for granted the fact that I had dental care throughout my childhood. I went to the dentist one day and I was told I couldn't go there anymore. It dawned on me that I had to choose between paying for the bare necessities and the health of my teeth. As a student, it's hard for me to choose between paying for school or having to pay to go to the dentist. When I get tooth pain, I don't go to the dentist. I have to power through it, even if it affects my overall health or how I perform in my classes, making me have trouble concentrate, leading to it affecting my grades. There are several students throughout Maine who have to suffer because they have aged out of the main care of dental coverage, leading them to suffer in silence, hindering their schoolwork and their learning experience. Instead of focusing on being students and classwork, they have to suffer through pain. I urge you guys to pass this bill for the health of all Mainers and so that people don't have to choose between their health and school.
Thank you for your testimony. Thank you for being here. Are there any questions? I don't see any. So now we can go to Angela Westhoff was here a minute ago.
Hello, Senator Claxton.
There she is.
Yeah. Thank you very much. Hello, thank you very much for the opportunity to speak. Senator Claxton, Representative Meyer, and distinguished members of the Health and Human Services Committee. My name is Angela Westhoff, and I serve as the Executive Director of the Maine Dental Association. The MDA is a statewide association that is dedicated to advancing excellence in dentistry, and we represent about 85% of the dentists in Maine. On behalf of the MDA, I am pleased to provide our enthusiastic support of LD 62, 72, and 996. These three bills seek to create comprehensive dental services to Maine Care members age 21 and older that would include preventive, diagnostic, and restorative dental services. My testimony is long and I've uploaded that, so I'm just going to summarize in respect of your time. And I know that there's a long list of folks that want to also testify. So essentially, you'll hear both from patients and from providers that management of dental pain in emergency departments is a skyrocketing expense. And that also consists of prescribing antibiotics and pain relieving medications. Management of dental infections through oral medications does not treat the root cause of dental pain and may actually increase antibiotic resistant infections and dependency on pain medications. As you know, Maine Care provides very limited dental services for adults, and without the financial resources for treatment, people often end up in the emergency room seeking relief from oral pain and infection, and you'll hear that a lot from patients today. There was a report in December of 2012, and the Maine Care Redesign Task Force recognized that Maine Care provides these limited services for adult dental, and also cited that the concern that dental pain is a driver of emergency room utilization, which really leads to more expensive treatment. So these three bills seek to address that. Further this afternoon, you'll hear from the Health Policy Institute of the American Dental Association, which is a trusted resource for health policy, data, and research. And they recently conducted a comprehensive financial analysis of an adult Medicaid dental benefit in Maine. They concluded that investing in a comprehensive dental benefit for Medicaid enrolled adults will lead to long-term reductions in medical care costs in the Medicaid program, with further positive economic impact to Maine's economy, particularly in rural Maine. The proposed bills would also seek to expand Medicare coverage for adults to include both preventative and restorative services and dentures, as you've heard. This was the #1 recommendation of the 2009 Governor's Task Force on improving access to oral health care in Maine, and the #2 recommendation was to increase Maine Care reimbursement rates. The MDA strongly believes that a comprehensive adult dental benefit is critical to adequately addressing oral health care needs of all Mainers. It's also important to note as well that Maine Care dental reimbursement rates are abysmally low. The last time an across the board Maine Care rate increase for dental procedure codes was in 1991. In 2002, fees increased, but only 9 procedure codes were included, and Maine Care reimbursement remains about 50% of commercial dental insurance reimbursement rates. These low rates threaten the viability of safety net dental clinics and undermine the availability of private practice dentists to treat significant number of Maine Care patients. We actively participated in the Maine Care rate system evaluation process, and in the Myers and Stafford's interim report dated January 26, 2021, dental codes were among the
40
top
seconds, Angela.
Thank you. The top 5 priority areas. In conclusion, we urge you to vote for LD 62, 92, and 996, and at the same time, carefully consider the recommended changes to the dental fees. Thank you.
Thank you, Ms. Westhoff. I'm not seeing any questions, so we can go to Anna Brewer. Welcome.
Good afternoon, Senator Claxton, Representative Meyer, and esteemed members of the Committee on Health and Human Services. My name is Anna Brewer, and I'm a team leader at Preble Street, an anti-poverty human services agency with over a dozen programs and services provided across the state. I am here today to testify on behalf of Preble Street in support of LD 996. Every day, Preble Street staff work with hundreds of individuals struggling to take care of their basic health and well-being, which is continually threatened and undermined by their marginalized socioeconomic status. Although the implementation of Maine Care expansion has greatly improved access to care for the people we work with, access to dental care continues to be difficult to obtain for low-income Mainers who rely on Maine Care for their health and well-being needs. At the Maine Medical Center Preble Street Learning Collaborative, we see this difficulty every day. Before the pandemic, with support from volunteer dentists, the Learning Collaborative hosted a free weekly dental clinic to provide fillings and extractions to Mainers in need. The relief that the patients of this clinic clinic experienced was immediate and powerful, but often short-lived. Without ongoing access to preventative, diagnostic, and restorative dental services, they remain stuck in a cycle of poor oral health. Many of the people we work with have not been able to see a dentist in years and suffer from conditions like untreated tooth decay, periodontal disease, and abscessed teeth. Our caseworkers see their faces contorted in pain when clients experience these conditions, knowing that there are few referrals we can make to help ease their pain, and those places we can refer them to have long waiting lists full of other low-income people with dental needs. And while this is not true for everyone who suffers from dental pain, we have seen many individuals use dangerous opioids and other street drugs as a way to self-medicate chronic pain from tooth decay. This creates a vicious cycle that exacerbates oral health conditions, leading to greater pain, desperation, and shame. For food insecure Mainers with oral health conditions, their oral health can present a barrier to getting their food needs met. Those with untreated tooth decay and other oral health conditions often have specific food needs that are hard to meet with the food available at soup kitchens and food pantries. By increasing access to dental care, access to food will increase too. Finally, for some of the people that we work with, tooth damage has been caused by domestic violence or other experiences of physical assault. Recently, one of our caseworkers was working with a woman who was poised to move into her own apartment after years of chronic homelessness and health struggles. The first goal she identified was connecting to dental care. She shared that her teeth had been broken as a result of domestic violence several years ago, and that she felt constant shame about the ongoing oral health effects these injuries have had, and the lack of solution she was able to find in the community. Proper access to dental care can be an important part of healing for victims and survivors. Preventative care is a smart, dignified way to approach healthcare and cost saving in the long run. Dental care is healthcare, and including dental benefits and main care will afford the people we work with the dignity of access to the oral health care that they need. For this reason, Preble Street urgently asks you to support LD 996 to ensure that all Mainers have greater access to this critical form of healthcare.
Thank you for your testimony. I'm not seeing any questions. Have a good day. So we can go to Barbara Covey. As soon as you're unmuted.
Yes,
there we go.
Thank you. Thank you for the opportunity to testify regarding this important bill. So Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. My name is Barbara Covey. I live in Oakland, Maine, and I am here today to testify in favor of LD 996. I was a primary care physician for 12 years and have been an emergency department physician for 29 years. I have also worked on the board of the nonprofit Waterville Community Dental Center, serving income-challenged residents of Central Maine for 21 years. You have heard the statistics regarding Mainers' use of emergency departments for care of their dental disease. I can confirm this reality. It is one of the reasons I became so familiar with the sad state of oral health in this state and was moved to work for the past 21 years to improve Mainers' access to oral health care. The emergency department is an inappropriate and expensive site for dental care, especially since treatment is largely restricted to infection control and supportive care, not the definitive treatment needed to treat the underlying disease. This and the lack of access to preventative care leads to progressive dental disease with recurring cycles of acute infection, pain, and tooth destruction, and repetitive, non-definitive, and costly emergency treatments. The problem goes beyond the already severe consequences of pain, oral infections, and lost teeth. I have treated hundreds of diabetics whose diabetic control was seriously impaired by their chronic dental disease. Patients with dental infections so advanced they have required ICU management for sepsis and airway blockage, and many others with life-threatening pneumonias and other lung infections related to their underlying dental infections. There has to be a better way. After Missouri restored Medicaid dental benefits to 350,000 adults in 2016, the state observed a 38% fall in the rate of ED visits for non-traumatic dental conditions. Improved oral health is associated not only with better overall health and lower dental costs, but lower medical care costs for those patients with diabetes, cardiovascular disease, and those who are pregnant. And I would add also better health outcomes for those patients. Essential oral health care remains out of reach for far too many Mainers. LD 996 uses matching federal dollars to offer access for adults covered by MaineCare to the comprehensive, preventive, diagnostic, and restorative dental care so sorely needed to stop the cycle of chronic dental disease and its negative impact on health and well-being. It will allow dental clinics like ours to serve whole families, which improves outcomes for the children as well as the adults. Improving community oral health is also in our economic interest. It will improve the productivity and employability of our workforce. It will reduce the wasteful use of healthcare dollars for a chronic disease that is preventable and far better managed by regular care in dental centers than with non-definitive and expensive Band-Aid emergency department care. I urge you to pass LD 996. It is a healthy investment for Maine's future. Thank you for your time, and I would be happy to answer any questions you might have either now or in the future. Thank you.
Thank you for your work. I don't see any questions. So now we can go to Becca Masovich.
Thank you, Senator Claxton.
We're not hearing you very well, Becca. You're unmuted, but
yeah.
Can you turn off your audio and see if it's throughput on your bandwidth? I'm sorry, can you turn off your video and see if we can hear you better?
Does that work better?
Much better.
Okay. Something changed in my AirPods. Sorry about that. Senator Claxton, Representative Meyer, members of the Joint Standing Committee on Health and Human Services, thank you for the opportunity to submit these comments in support of LD 996. My name is Becca Matasovich, and I'm here today as Executive Director of the Partnership for Children's Oral Health. The partnership is a collaborative effort funded by philanthropic dollars to build a broad network of individuals and organizations working together to create a Maine where no child suffers from preventable dental disease. In the work we've been doing with a wide range of partners, we've heard over and over from many different perspectives that Maine needs a comprehensive dental adult benefit within MaineCare. Research has clearly demonstrated that when parents have access to care, they are more likely to bring their kids in for care as well. Therefore, we strongly support the goal of providing a comprehensive dental benefit that will improve access both for adults who have no doorway into the dental system and also for kids who currently lack access because their parents have no relationship with the dental system. A comprehensive adult benefit will help grow the capacity of Maine's oral health system and improve oral health outcomes. This will pay off in many ways that you've already heard. I'll just mention also the reduction in medical debt, especially for young adults who are just joining the workforce and who all too often have to forego dental care when they lack dental benefits and are making minimum wage. One provision we especially appreciate is the formation of the broadly representative stakeholder group to work through the many considerations for how to design and implement this benefit. I know that all of us agree it's very important that we work on increasing access for adults without reducing children's access. We're confident this is possible with a well-designed and thoughtfully implemented adult benefit, along with expanding prevention efforts for children, strengthening the state's public health infrastructure, and supporting workforce development strategies to train, recruit, and retain more oral health providers. This will help ensure that we can maximize the capacity of our dental system to serve both children and adults who need treatment for dental disease now, while also reducing decay rates for the next generation of adults, which will decrease future costs of treatment for preventable oral disease and all the other health problems that are exacerbated by it. Lastly, it's important to recognize that although access to dental care has been a longstanding issue, COVID-19 has laid bare many inequities in our health system in new ways. Poor oral health is interconnected with many of the other systemic challenges that drive these inequities, as well as with the biology of COVID-19 itself. The pandemic has given us a chance to rethink how we want to approach the terrible gaps in our system and has opened up opportunities for innovations that did not seem possible even a couple years ago. For instance, tomorrow in the Health Coverage, Insurance, and Financial Services Committee, a bill is being heard that would authorize teledentistry, which is an important tool in expanding access. This is just one example of how the opportunity and urgency created by the pandemic make this the right moment to expand access to care that has been desperately needed for years. And LD 996 is a key piece of the puzzle. The bottom line is that this is good policy from both a health and an economic perspective. Thank you for the opportunity to offer input, and I'm happy to answer any questions you might have.
Thank you very much. So we can go to Beth Barada.
Hello, to the chairs and honorable members of the Joint Standing Committee on Health and Human Services. I'm Beth Barada, I'm a resident of Bangor, here to testify in favor of LD 996. As a family medicine physician who practices outpatient primary care in the community, I have a lot to say about the importance of making dental health care affordable and available to everybody. Teeth are not, strictly speaking, bones because they don't repair themselves the way bones do. What you start with after you lose your baby teeth is what you get for the rest of your life. It makes it extremely important to maintain them with regular cleanings, monitoring for cavities, and treating them before the teeth themselves are made non-functional. Dental infections, as others have spoken about before, are extremely painful. They're also pretty scary too. Anytime there's an infection that's that close to the brain, I get pretty nervous because the risk of that infection going past the protection we evolved, the blood-brain barrier, to reach the central nervous system, or CNS, which is made up of the spinal cord and brain, is higher. A CNS infection can kill you pretty easily, or it can leave your cognitive and emotional abilities permanently impaired. I like to only prescribe antibiotics when it's completely necessary, but more often than respiratory, urogenital, and skin infections combined, dental infections are a very common reason that I will write a script for an antibiotic. And often they're longer than they, strictly speaking, need to be. And this is because dentists don't often provide definitive treatment, pulling the damaged teeth unless the infection has been treated with antibiotics. And so you have to time it just right so that the patient will have gotten enough antibiotics, but not too short of a course so that they won't have a flare-up of the infection before they can get their procedure. I worry a lot about dental infections in my pregnant patients. I saw a woman recently who was coming in for ear pain, but it turned out it was her teeth. She was able to scrape fragments of rotten tooth off with her fingernail. She had no dental coverage and was going to only be able to get her teeth pulled at an emergency clinic, which had that same problem, only available on a first come, first served basis. And so she couldn't finish the course of antibiotics too early. Pregnant women with dental infections are much more likely to have worse maternal and neonatal outcomes, from the risk of miscarriage being higher to a higher likelihood of having infections of the heart and blood. So it also is a problem for people who don't get, like dental insurance is an issue for people who need other care. So if you get all your teeth pulled, you have two major options: live without those teeth, like I said, or try to get dentures. Most of the time people will have to change what they eat so they don't have to chew, because it's hard and to get dentures. They're not easily accessible. Unless you meet very specific criteria, you have to pay for them out of pocket, and that's quite a bit of money right there. And I have many patients for whom others have mentioned diabetes, for example, that patients who can't treat constipation the way we prefer to treat it by having a diet rich in fruit and vegetables, they have to take multiple medications every day. And then there are people who have conditions that don't qualify them for it, but their health will still worsen. Thank you very much. I'd also like to finish up by saying this weight loss requirement puts a large fraction of our community at risk, specifically our growing population of elders. It's a group of people who should really avoid having any sort of weight loss because it weakens their ability to rebound from other illnesses or having acute conditions. They have enough going on health-wise, and it's hard for them to keep weight on with having a fixed incomes, poor access to transportation, etc. So by passing this bill, we can help provide medical and nutritional support to many who would otherwise have a poorer quality of life and help them live happier, healthier, and safer lives. Thank you.
Thank you, Dr. Barada. I'm not seeing any questions. Thank you for being here. We'll go to Beth Pierce.
Good afternoon. Senator Claxton, Representative Meyer, and distinguished members of the Health and Human Services Committee. I am Beth Pierce, and I serve as the Oral Health Coordinator at the Maine Primary Care Association, or MPCA. MPCA is a membership organization that includes all of Maine's 20 community health centers. Maine's community health centers make up the largest primary care network in the state, providing comprehensive, high-quality medical, behavioral, and dental care to more than 210,000 people each year, or approximately 1 in 6 Mainers. CHCs are the forefront of delivering care to rural and underserved Maine communities and serve patients regardless of their ability to pay or their insurance status. Maine Primary Care Association strongly supports LD 996 and thanks Speaker Fecto and the other sponsors for bringing this extremely important and timely legislation forward. Oral health care is one of the core services of the community health centers are required to offer, either on site or through coordinated referrals. Community health centers, or CHCs, often located in communities of need, serve as critical oral health access points for Maine people. Part of the health center model is to provide comprehensive care, of which dental services are a critical component to a patient's overall health. Simply put, we believe dental care is health care. The lack of a comprehensive dental benefit in Maine care leaves vulnerable adults to seek emergency departments, care in emergency departments, EDs, or not at all. For those who are able to find a dental practice that will treat adults with Maine care, the care they receive is primarily episodic based on the issue at hand and limited to the appropriate treatment to, I quote, alleviate pain, infection, or prevent imminent tooth loss, as per the current Maine Care dental policy, outlining the criteria for covered services for adults. This is wholly inadequate as it treats the escalated problem rather than focusing on prevention and improved overall health for the individual. By the time the patient is seen in the dental practice under these circumstances, their oral health conditions have often advanced and are irreversible, which frequently leads to extensive procedures or extractions, neither of which are ideal. The loss of teeth can lead to many unintended consequences, such as poor nutrition or bone loss, and can impact employability. While it's been known for some time that the comprehensive dental benefit for adults Maine care recipients would lead to the diversion of care sought in the ED, as well as healthcare savings in the setting, there's much more at stake here. Comprehensive dental services with adequate prevention and periodontal or gum tissue treatment are integral to the management of chronic health conditions such as diabetes, cardiovascular disease, and pregnancy. To that end, the MPCA has participated with the Health Policy Institute to conduct an economic evaluation that quantifies the healthcare savings that the Medicaid program would achieve by providing a full dental benefit, thus decreasing the health cost savings for the above 3 key diagnoses. For example, the total medical care cost savings for these diagnoses are estimated to be $1,997,273 in year 2 and $3,994,546 in year 3. These savings are in addition to the reduced ED expenses that do not provide adequate treatment for the adults who seek care in that setting.
30 seconds, Beth.
Okay. We believe it is clear that making the investment in primary care and preventative oral health services would produce long-term savings for reduced hospitalization and ED visits in the same way that investment would primary care have over time. I would be remiss if I did not point out that on average, Maine CHCs provide over $2.6 million in uncompensated dental care to patients each year. This is simply unsustainable. more to the point, consider how many more dentists and hygienists they could hire and how many more patients they could serve if we were able to get reimbursed through an adult dental benefit under Maine Care. On behalf of our patients, the staff, and volunteers at Maine Community Health Center, we urge the passage of LD 996. Thank you for the opportunity to testify in support of this bill.
And thank you for that testimony. We'll go now to Carolyn Silvius.
Good afternoon, Senator Claxton, Representative Meyer, and members of the Committee on Health and Human Services. My name is Carolyn Silvius, and I'm from Portland. Today, I wish to testify on behalf of LD 996, an act which would provide dental coverage to people covered by Maine Care. I must say the last thing I ever envisioned was talking to members of the state legislature about my teeth, but it seems like that's what I'm about to do. Due to some unusual childhood dental problems, I became in need of full dentures quite early, in my early 20s, and have been wearing these same dentures for about 50 years. They no longer fit properly. The bottoms float around and make speaking difficult and unsightly. People notice this when I speak, and it influences my effectiveness and how seriously I am taken when I speak on behalf of the organizations I represent. In addition, they are constantly causing cuts and sores on my gums, which are quite painful, especially when I try to chew. And this pain takes the joy out of food. But I continue to wear them because up until now, dental and particularly denture work has not been available through Maine Care, and my income is insufficient to replace or reline them. Dentures should be relined at least once every 10 years to accommodate changes and shrinking in the gums and jaw, but mine have been relined only once, and that was about 30 years ago. The result of this is the inability to chew my food to the texture that it is safe to swallow, which can cause choking and does cause some degree of indigestion. Certain foods need to be avoided, such as less tender cuts of meat and apples, for example, but these foods are affordable with my SNAP benefits. Dental care is health care, and dental care is critical for people to access nutrition for life. If you can't eat, you can't live. LD 996 is a life-saving bill and will help all Mainers achieve a good quality of life. Please vote not to pass in your workshop. Thank you, and I'm available to answer any questions you may have.
Thank you, Ms. Silvius. I see a question from Representative Zager.
Thank you, Mr. Chair. Not a question. I just wanted to extend a greeting to Carolyn. We met many months ago, and thank you so much for speaking up today.
It was nice seeing you too.
Thank you. Next, we'll go to Casey Knight. Hello, Casey. As soon as you're unmuted, as soon as we'll hear from you. There we go.
There we go. Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. My name is Casey Knight. I live in Auburn, and I'm here today to testify in favor of LD 996. Many of Maine's essential workers, immigrants, and lower income families make too little to attain dental coverage. This makes them no less worthy of holistic and inclusive health care. Dental care saves lives, and the lack of adult dental coverage contributes to systemic racism. As a social worker, I've had a number of clients affected by the lack of dental coverage. One immigrant woman lost her teeth to horrific abuse in a refugee camp. Broken and lost in a complex system with insufficient dental coverage, she is afraid to be ridiculed for her exacerbated mispronunciation of English words. She's ashamed of the scars of her survival, and she's been negated from employment. She wants people to see her for her resilience, but people grimace at her smile. Another client was denied dentures, though deemed medically necessary by her mental health provider. She attempted suicide due to the lack of positive self-esteem. Her face concave in the absence of teeth, her husband finding her unattractive. 4 children almost became motherless because of the lack of dental services. Both of these women are Black. The lack of adult dental coverage contributes to systemic racism. It's a racial issue as it affects a disproportionate number of people who exist in lower income brackets. Uncared teeth become sore. Healthy foods become painful to process. And I know this all too well. Recently, pain drove me to the dentist, where I learned I needed a number of crowns. Pain changed my diet, and I've been warned of diabetes, something Maine Care will cover. Adult dental coverage is estimated by the Health Policy Institute to reduce Maine Care costs related to diabetes alone by over $2.5 million. Adult dental coverage is essential. It can save lives and state funds, and the lack of coverage for Maine's low-income people contributes to systemic racism. Thank you, Senator Claxton, Representative Meyer, and honorable mentions of the Joint Standing Committee of Health and Human Services.
Thank you for being here and for your testimony. Next, we'll go to Elizabeth Sullivan.
Hi. Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. My name is Elizabeth Sullivan. I live in Marshfield, Maine, and I am here today to testify in favor of LD 996. I am here to express my deep concern for the lack of dental health care that is afforded to Mainers who receive Medicaid. I am here as a person who has had dental insurance and dental care for most of my life, but who is aware of the problem many individuals in Maine are facing. I have resided in Washington County for most of my adult life, and for the past 15 years have worked and spent time with people who receive Medicaid and thus do not have dental benefits. Many of the folks that I encounter in my daily life are experiencing dental problems or have experienced dental problems to the point that they are missing some or all of their teeth. Most of those people have been unable to afford dentures, and it's no secret that healthy teeth contribute greatly to a person's physical and mental health, as well as factors like self-esteem and employability. One of the things that prompted me to be here today is my experience with dental care in Maine over the course of the past several months. As I stated, I have had dental insurance for most of my life, and I've taken advantage of it. I go every 6 months for preventative care, and I've had my fair share of dental work, including fillings and root canals. I've had the privilege of being able to afford these procedures. I'm 38 years old and still have all of my teeth. One Friday afternoon, I broke a tooth, wasn't in any pain, and called my regular dentist the following Monday. I was fit in for an appointment on that Wednesday. It took me 2 days to get an appointment. When the dentist arrived, she examined my tooth, and we decided what the best course of action would be. When I checked out of the office, the receptionist ran my insurance, and the exam and procedure were covered. I didn't know anything out of pocket. My experience is not the experience of Mainers who have Medicaid. My best friend has also lived in Washington County for his entire life. He is 34 years old and receives Maine Care. He has had 8 teeth pulled. His experience at the dentist has caused him extraordinary dental anxiety. Anxiety I imagine most of us would have if every time we went to the dentist, some of our teeth were removed. As a result of the dental pain, he asked me to help find him a dentist that would work with him to examine his teeth and to determine next steps. In Washington County, we have 4 public health centers that practice dental care on a sliding scale. After calling, he was given an appointment that was roughly 3 months away. When his appointment day came, transportation fell through and he was unable to go to the dentist. As I'm sure you are aware, because dental care is not a Medicaid covered expense, he cannot access the Maine Care transportation rides that bring him to his other appointments. The missed appointment resulted in him getting a no-show at the health center and having to start the process of scheduling a new appointment. Shortly.
Whoops, we just lost your audio.
We called the dentist where the appointment was scheduled. What's that?
We just lost your audio and visual for a minute. Go ahead.
Oh, am I back?
You're back.
Shortly after the missed appointment, one of his teeth broke and began causing him pain. We called the dentist where the appointment had been scheduled, and they could not get him in. We called the remaining public health centers, who also had no availability. Knowing the tooth was likely to come out, we called the dentist in Penobscot County, 80 miles away, who accept Medicaid. We explained the tooth and the pain. The next available appointment was 4 weeks away. As the tooth continued to cause him problems and pain, we began calling dentists again. We called private dentists who said the cost of an extraction would cost between $300 and $500 without insurance. We called the dentist where he was originally accepted as a patient, and they had no availability. We called the dentist where the extraction was scheduled and explained the tooth and the increasing pain, and they could not see him any sooner. He was forced to wait another
Elizabeth.
2 weeks to be seen by a dentist 80 miles away so that he could, at 34 years old, have his 9th tooth pulled. As a person with dental insurance, I was seen in 3 days and didn't know anything out of pocket. My friend, a person without dental insurance, a person already missing teeth, a person experiencing pain, waited a month to be seen by someone to take out his teeth. It is absolutely unacceptable. Teeth are instrumental to our physical and mental health and should not be treated as optional or elective body parts. Thank you.
Thank you for your testimony. Next, we'll hear from Courtney Moran.
Thank you, Senator Claxton, Representative Meyer, and distinguished members of the Committee on Health and Human Services. My name is Courtney Moran, and I am the Vice President, Actuarial and Underwriting at Northeast Delta Dental. I'm here today on behalf of the Northeast Delta Dental Board to support LD 996. This is a critical bill to address the vast unmet oral health needs of adults and children in Maine. As a not-for-profit company and the largest dental benefits insurer in the state, advocating for a MaineCare adult dental benefit in Maine is a mission-sensitive board directive. The Northeast Delta Dental Board feels strongly that oral health care must be available to all, not only to those who can afford it. MaineCare adults deserve quality oral health care beyond extractions and pain management, and we are grateful for the opportunity to help advance this important issue. As part of this effort, we examined the most recent claims data available for MaineCare adults from 2016 to 2018 under the current benefit outside of the emergency room. There's 2 elements I'd like to highlight for you. The first is the cost of the services already being provided, and the second is the nature of services being provided. In 2017 and 2018, the total cost of care was $5.6 million, with about $2 million of that cost borne by the state. And it was similar numbers for 2016 and 2017. 73% of those services were oral surgery and related procedures. 17% were for restorative and endodontic services. And lastly, 10% were for diagnostic services, which were typically just a problem-focused exam. 0% of the services provided to adults went to preventive care. These claims only reached 12% of MaineCare adults, which is both unsustainable as a fiscal policy and an improper way to provide care. Northeast Delta Dental strongly believes that by working together with the legislature, the Department of Health and Human Services, and numerous stakeholders dedicated to improving oral health, we can make an adult dental benefit a reality for MaineCare adults in the state. We support a sustainable adult dental benefit that will result in the greatest access to oral health care providers in Maine at the lowest cost, and we believe a managed care carve-out program will be the most sustainable for Maine. We believe that through our partnerships and leadership of various stakeholders, we can build an adequate dental network to provide care. By developing a comprehensive plan for the adult dental benefit now, we can ensure the program is sustainable, produces long-lasting healthcare benefits to the citizens of Maine, and reduces healthcare costs over time. We're grateful for the partnership of other stakeholders, including Community Dental, Maine Equal Justice Partners, Consumers for Affordable Healthcare, the Partnership for Children's Oral Health, and the Maine Dental Association. Thank you for the opportunity to testify in support of this important bill, and thank you to Speaker Fecteau for his championing of a MaineCare adult dental benefit. Thank you.
Thank you. Now we'll hear from Grace Denker. You want to unmute and join us? Are you there, Grace? Why don't we go to Helen Crabtree and come back to Ms. Denker? Helen Crabtree, if you'd like to unmute and join us. Welcome.
Thank you, Senator Claxton, Representative Meyer, and honorable members of Joint Standing Committee on Health and Human Services. My name is Helen Crabtree. I live in Auburn, Maine. I'm here to support LD 996. My personal experience will help put in context the gap in having access to dental care. The gap in having access to dental care makes it so dentists can't help main care recipients. The ER prescribed a one-time antibiotic prescription to help clear the infection that had developed from an open wound to my gums and caused my face and jaw to swell. I was unable to chew food with a cracked tooth cutting into my gum. My ear and my head hurt. The pain was excruciating, causing difficulty sleeping and eating. My untreated oral disease had a large impact on quality of life and productivity. After 4 dentists turned me away, I finally found a dentist whose Christian values and concern for my health led her to see me. I'd lost so much weight because I couldn't eat or sleep. As a vegetarian, I couldn't even bite into an apple or a banana without pureeing. I had to prepare food in a blender, known to me by a neighbor, a luxury tool many people do not have access to. I currently deprive myself food to pay the bill. There's an exorbitant $12 interest per month, and it's an unnecessary financial burden for someone without an income, like all who have main care. Employment seekers are encouraged to smile because it increases their chances for employment. Smiling becomes a challenge when you are toothless or have decaying teeth. My oral infection prevented me from getting gainful employment and from being a productive member of the community. The right side of my swollen face compromised my looks, dashed my confidence and ability to smile. I hope you can empathize and agree that healthy teeth boosts one image and self-confidence. It means everything from an employment perspective. I'm asking you to acknowledge our teeth as you do our ears, our heart, lungs, and limbs. It is an unconscionable injustice to acknowledge only parts of our anatomy for treatment, but not the whole. That's why I'm kindly asking you to support LD 996 today. You all need to and deserve dental care. Please do not take dental care lightly. It is for our overall economic benefit. Thank you.
Thank you for that testimony. Now we'll go to Jeffrey Wallawender. Welcome.
Thank you. Good afternoon, committee members. My name is Dr. Jeff Wallawender. I'm the Executive Director, Chief Dental Officer, and a full-time practicing dentist at Community Dental. I'm going to keep this really brief and hopefully a minute to spare your time, but I echo what everyone else says. I just wanted to mention that without changes to the main care adult dental program, our safety net dental clinics will not survive. Before the pandemic hit, main care reimbursement rates were insufficient to cover the cost for many procedures, and now this is even more common due to the cost of increased infection controls. Community dental in 2016, 17, and 18 operated significantly in the red. We have a senior management team of 3, and I practice dentistry full-time in addition to this. We no longer even have a single manager at any of our 7 offices. Maine must seize the opportunity to support the Medicaid dental provider network in this state. I have learned the most valuable asset for a successful dental program is its provider network. If you lose the network, it's extremely difficult and expensive to rebuild it. The cost of just a single clinic with 12 dental chairs can run to $1.3 to $1.6 million alone, not including annual operating costs. As the executive director at one of the largest Medicaid and uninsured dental clinics in Maine, I urge you to consider supporting the network and in supporting the adult Medicaid dental benefit. Thank you so much.
Thank you, Dr. Wallawender, for a very succinct testimony. And now we'll try next to go to Grace Denker.
Mr. Chair.
Hi.
Yes, hang on a minute. I'm sorry, there's a question for just a minute. Go right back to you. Yes, Representative Zager, thank you.
Thank you very much, Mr. Chair. Dr. Wallawender, thank you for your testimony. If I understand you correctly, you're saying that this bill, what's at stake in this bill is not only preventing all that suffering in those ER visits, but if we don't pass this bill or something like it, you're saying that the system that you are operating within is going to crash and that we're going to have even more of those consequences. Is that?
Sure. So, I mean, I think that you're going to see that the less successful clinics, even among us, will slowly start to cut off, our arm, or you can even use the analogy of extracting a tooth. As we find that one of our dental centers might not make as much as the other one, we'll probably close that dental center to prevent the whole organization from going under. And I'm pretty sure you'll see that some of the other, dental centers may have that same problem. But as we, right now, what we do is we try to schedule our days for emergencies. And we know that scheduling an emergency is not a profitable thing in the dental world. Here we are, we're seeing somebody who hasn't been to the dentist in, God knows how many years, 20 years that you've heard some people. And that here you are, you have to, in your system include all of their medications, do all of their medical history. And the reimbursement for that limited exam is going to be, around $40 or so with the x-ray. So that's not a profitable way. We really need to do it the way other dental practices do. You have an exam, you have a cleaning, you have you can predict your budget and your finances much more easily with patients who come in every 3 or 6 months versus someone who's only coming in once every 20 years. And as we close down one dental center, the effects on the other dental centers are extreme. Their payer mix is going to go higher to Medicaid, and all of a sudden their sustainability is reduced. And then all of a sudden the person who had to try calling 15 dental clinics that you heard earlier to try to get an appointment is going to have an even longer waiting time. So, the less dental clinics that you have, the harder it's going to be for patients, and the harder it's going to be when this benefit does eventually pass. The longer we wait, the harder it's going to be. And I have plenty of data to show you that, and we work really hard, and we have trimmed every expense possible, including, myself still treating patients every day, in order to make this financial model even partially work.
I appreciate that. Thank you, Mr. Chair. It seems like, especially for our rural Mainers, especially critical. Thank you.
Okay, now we'll go to Grace Denker.
Hello, Senator Claxton, Representative Meyer, and the honorable members of the Joint Standing Committee on Health and Human Services. My name is Grace Denker, and I live in Brunswick. I am here today to testify in favor of LD 62, LD 72, and LD 996. I'd like to say I've been clean and sober for 7 years, and addiction is a disease and can affect dental health as it has for me. I am considered to be low income and have struggled with dental issues most of my life. I have spent hundreds of dollars on teeth, even with insurance. I would often avoid taking care of something as simple as a filling or a root canal because of affordability, even with insurance. It gets really bad and I'm in excruciating pain and must spend money I don't have. A tooth pull is less expensive than a root canal. People will often visit the ER. I have, putting me further into debt. I currently owe a couple thousand in medical debt. ER staff must treat a dental emergency a dentist can take care of. Those with little money have to deal with the stigma of having missing teeth, and that's painful emotionally. People see you as poor or uneducated, and no one seems to like that. I know about this firsthand. Dental health is a serious medical concern. Besides the pain and possible serious ailments, we need teeth to eat. I'm 39 years old and I'm considering dentures I have no money for instead of lifelong dental pain. I'm 39 years old. A dental infection can be taken care of before it gets that bad if there were affordable dental care. It can increase the risk of heart disease and stroke. A dental infection can turn into sepsis or septic shock, and one can die from that. I don't think it's right for an American of low income status to die while saving up for to see the dentist. Affordable visits can prevent painful dental problems. Dental pain is the worst pain I've ever felt, and that can be prevented with affordable dental care. This is a human right. It's not cosmetic. I no longer have dental insurance, and I need a tooth pulled. I'm going to community dental who have a sliding scale fee. I'm very grateful for this. However, I must show up early in the morning and sign up to actually wait on a line to be seen. I could get called that afternoon or that morning or not at all. There's more important things that I'd like to do to spend a day than to see the dentist. I'm grateful for this service, but I think there could be a better way to do this. Good dental care is reserved for the wealthy, I suppose. Why the poor keep getting punished, I do not know. That's not sarcasm. That's my experience, and that's the experience of many others. Finally, according to Maine Equal Justice, an investment of $2.7 million, the net cost to the state of Maine of a Maine Care adult dental benefit is expected to yield an economic return of $21.6 million. I thank you all for listening, and if there's any questions, I'd be happy to answer them to the best of my ability.
Thank you for sharing your story and for your persistence through some technical challenges. I don't see any questions, so now we'll go to James Berry.
Good afternoon, Senator Claxton, Representative Meyer, and members of the Committee on Health and Human Services. I'm James Berry, testifying on behalf of LD 996. I'm a family physician and addiction medicine physician from Portland, current president of the New England Society of Addiction Medicine, which represents physicians and other substance abuse treatment providers in Maine, New Hampshire, and Vermont. Dental disease is an overlooked facet of the Maine's opioid epidemic. Now, we've already heard from Senator Moore and Grace Decker about some case examples of this problem. Access to adult dental care, especially restorative care, is a key component of early recovery for our patients who are entering treatment. Many present with diseased teeth and decayed teeth resulting from years of lack of attention to dental care. But not only that, the disease of addiction itself leads the teeth to deteriorate. And many also suffer from a poor nutritional state and malnutrition. And in recovery, they have trouble maintaining their nutritional balance because of inability to eat properly from their continued poor teeth. So this problem particularly affects young women entering treatment. Most of them are victims of abuse, and they already suffer from low self-esteem and from shame related to their addiction. And as they prepare to enter the workforce, they're entering in jobs that involve interaction with the public. With their poor-looking teeth and missing teeth, this prevents that from happening. They also often become pregnant in early recovery, and we've heard about the ill effects of poor dental conditions on pregnancy. And then the pain itself from untreated decay leads people back into opiate use. And many of my patients began their opiate use from getting pain medicine from prescription opiates for dental pain. So in summary, passage of this bill was the important step in addressing Maine's opioid epidemic, which we know took over 500 lives last year of Maine people.
Thank you for your testimony, Dr. Berry. Are there any questions for the doctor? Thank you for your work.
Thank you. Thank you.
Now we'll go to Joshua Capilla. Excuse me for messing up your last name.
Coppola, yes. Thank you.
Okay.
Good afternoon, Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. My name is Joshua Coppola. I use they, them pronouns. I live in Bangor, and I'm here today to testify in favor of LD 996. I'm 35 years old, and I've lived in this state for 10 years now. Early this year, I broke a molar. Which is a significant issue for anybody, but this was the last molar on my lower jaw. A long period of pain, anticipation, and dread, and worsening mental health ended with that major chewing surface broken. A new, heartbreakingly familiar period of anxiety began. Late February, I had that broken molar removed, the 12th extraction I've had performed in my adult life. The only reason I could afford that procedure is GoFundMe, because my insurance at work hadn't started yet and would only cover a small portion in any case. I'm poor. I've been poor. Healthcare has always been a bonus of those rare good jobs, and my ongoing struggles to maintain mental health and housing and transportation and food has made keeping those jobs difficult. Broken and failing teeth meant nutrition was hard to maintain. I was drinking supplement drinks 2 meals a day, all while working a very physical job. Dental care is expensive. Most of the jobs I've had over the last decade didn't include comprehensive dental care. Before the Medicaid expansion, I applied and was rejected by MaineCare, falling in that little gap. Policies that restrict access to dental care meant that I had to learn to live with pain, that I had to choose to wait and throw a tooth away because to fix it meant I couldn't have a car or a place to stay. The feeling I was left with was, because of how much money I had, I didn't deserve to have functioning teeth. As a queer person who had to leave their home state to come out of the closet, as someone who has lived in their car, as a person in their 5th year of recovery from alcoholism, I'm no stranger to pain or struggle. The shadow that tooth pain and unaddressed dental needs has cast over my life has added unneeded pain and despair. It is my deep wish that you support LD 996 and prevent this from happening to anyone else, because we need to chew to eat and we need to eat to live, and everybody's got a right to live. Thank you.
Thank you, sir, for sharing your story, putting a face on the conversation we're having. Next, we're going to hear from Judith Feinstein.
Yes, good afternoon. I have testimony from two organizations. Do you want me to do them just back to back and identify which testimony it is?
If you would.
They're both, I've tried to shorten both of them as much as I can.
Sure, if you
Okay.
would.
All right, I will do that. Thank you very much. Senator Claxton, Representative Meyer, and honorable members of the Health and Human Services Committee. My name is Judith Feinstein. I live in Hollowell, and the first testimony I will provide to you is as the coordinator of the Maine Oral Health Coalition. It was founded over 20 years ago as the Maine Dental Access Coalition. We continue to function as a network and maintain a close interest in policy and systems changes that can work to improve access to services and oral health status in Maine. We enthusiastically and emphatically support all three of these bills today, 996, 62, and 72, in their common intent to expand dental coverage to adults in the Maine Care program and in the other changes and initiatives proposed among the three bills to improve access to dental care to all people of Maine. As I said, it was co-founded about over 20 years ago by staff at the Maine Children's Alliance and myself in my position as the director of Maine's oral health program in the Maine CDC, and I held that job until about 6 years ago. My experience was that a week and sometimes a day did not go by without multiple calls from individuals desperate to find needed care from for themselves or from a health or social services professional on a client's behalf, much like some of the people that you have heard speak to you this afternoon and who will be speaking after. These are people whose care would have been covered by Maine Care if the provisions of these bills had been in place. The challenges posed by limitations in Maine Care for adults are among the reasons that the coalition was founded. It wasn't just about children. Current limitations to adult dental care in Maine Care equate to a downstream approach that does little to intervene in the disease process, never mind to prevent it. We can do better. And as Representative Fecto said when he introduced 996, we came so close to getting a good start last year, and I'm very hopeful today. I am going to skip right through here. You've heard a lot about the effects of poor oral health on overall health, and I would echo those comments. And I think you will also hear more from the Health Policy Institute study that there is a tremendous financial savings, a potential financial savings over a relatively short time frame if we make these changes. And I think that the overall improvements, the improvements in overall health can't be overlooked either. There's more in my written testimony from the coalition, but I just want to thank you so much for your consideration of these bills. I'd be happy to answer any questions and now or as you proceed in your deliberations. Shall I just go to the other one?
Sure.
Okay. So my name is still Judith Feinstein, and this time I'm providing testimony in support of the three bills as a board member of the Maine Children's Alliance. MCA is a statewide, nonpartisan, nonprofit research and advocacy organization whose mission is to advocate for sound policies and promote best practices to improve the lives of Maine's children, youth, and families. I'm going to provide just a few high points of the longer testimony that was submitted to you in writing, with the expectation that you will ultimately consider the three proposals as related. We do support their overall and shared intent, which I won't repeat. we're all agreed on what it is. We want to ensure better overall health outcomes for all residents of our state. But there are 2 points that we do wish to emphasize, knowing that you have and will hear more from others with supporting data and examples of experiences of real people here in Maine. First, oral health is important for overall health. And second, when parents have access to care, their children are more likely to get care as well. Prevention matters. Preventive care can avoid more expensive and often invasive care for many diseases, and dental issues are no different. Without access to main care coverage for individuals over 21, dental problems may too often go untreated and they do not fix themselves. Bottom line, and of great importance to the Children's Alliance, is that when parents are in pain because of untreated dental issues, they cannot provide the best parenting for their children. When parents are in pain or having to go to the emergency room for non-definitive care, they cannot work and provide for their families. When parents are unable to advance in employment, the economic impact affects the whole family. We also know that when parents have access to healthcare, their children are more likely to receive healthcare services. The same is true for dental care. Expanding Maine Care's dental coverage for adults means they can more easily establish relationships with dental providers, address their own oral health needs, establish the family with an ongoing source of care, and begin to break a pattern of multi-generational poor dental health. Improving access to affordable oral health care is a key to a door that we have an opportunity to open. Thank you for your consideration of both of my sets of comments, and I would welcome any questions or provide information today or later on. And you will be hearing from me on the other bill later on.
Okay. Okay, very good. Are there any questions, Ms. Feinstein? I'm not seeing any. Thank you again for being here. We'll go to Caitlin Morse.
Good afternoon, Senator Claxton, Representative Meyer, and esteemed members of the Health and Human Services Committee. My name is Caitlin Morse. I live in Westbrook, and I am the Policy Associate for the Alliance for Addiction and Mental Health Services in Maine. The Alliance supports each of the dental health bills in front of you today, LD 62, 72, 996, and 1501. How are mental health and dental health connected, you might be wondering? For several reasons. The integration of oral health, behavioral health, and substance use services is actually a topic that is receiving more and more attention among mental health providers, as it should be. This morning, I even received an email about an event that the National Council for Behavioral Health is hosting regarding this subject. If you're interested in checking it out, I'll send the information. Without basic prevention for people of all ages, unnecessary visits to the emergency room increase. An emergency room is not well equipped to handle issues of oral health and dental pain. Proper preventative care decreases the chance of a patient heading home with opioid medication for their pain. I'll give full testimony and share more information on LD 1501, but our particular concern at the Alliance is that patients receiving oral health care in an emergency department are significantly more likely to receive an opioid prescription than patients treated in a dental office. These bills make dental prevention available to people of all ages, and access to care is one of the issues we feel strongest about at the Alliance. Please don't hesitate to let me know if I can answer questions.
Thank you very much. Are there any questions of Ms. Morris? I think then, at the suggestion of one of our members, we'll take a 10-minute break. We've been sitting for about an hour and 3/4, and it's time to move about. So we'll be back at 2:50. That's be 11 minutes. Apologize for those who are still waiting to testify, but thank you for being here. Thank you, Representative Griffin, for that suggestion. I'll be looking up replacement seat pads tonight. Okay. Next, we can hear from Candy Cleaves. Thank you for your patience.
No problem. Good afternoon, Senator Claxton, Representative Meyer, and esteemed members of the Health and Human Services Committee. First, let me apologize that my submitted testimony accidentally has 966 instead of 996. It seems to be a trend. I'm Candy Cleaves of Garland. I'm speaking in favor of LD 996. In 2000, I had a surgery that sent my acid level to extreme highs. At that point, I had not seen a dentist in over 6 years because I could not afford the cost. It would be another couple of years before I had the ability to. When I did, I had several issues happening that required treatment, including 2 root canals. In between my appointments, my fillings were falling back out and some teeth crumbling. The destruction from one week to the next was mortifying. Had I been able to get regular checkups and care all along, the acid would not have been able to get such a hold on my teeth. So rather than my new dental care being a stepping stone to better health and confidence, it became a goodbye tour for my teeth. It was too late to be able to save my once beautiful smile. Tooth by tooth, over the next few months, they were removed. When it came time for my front teeth, my mental health spiraled even farther downward than what it usually was. I literally fled the state and hid at a friend's home for a week after the brutal removal. This year, I will withhold showing you the photos that I shared last time. They were quite gruesome. No one should have to go through that type of brutality because they cannot afford dental care. 3 months later, I was lucky enough to be able to get my dentures. Unfortunately, medical issues do not always let me keep them in, an issue that my regular teeth would have not been having. 19 states provide dental coverage for adults who have low income. That's extensive coverage, and only 3 provide no coverage. While Maine is known frequently for leading the nation, we fall short in providing the needed care to keep Mainers with low incomes in better overall health. Not only is it the right thing to do for individuals, but it's the right thing to do to help maintain a healthier workforce. It's the right thing for taxpayers so that our money can provide care at the dental office rather than the emergency room, which costs far more. I no longer qualify for Maine Care, and this bill will provide no coverage for my husband and I. But this bill can help my husband and I financially by allowing us to keep more money in our pockets rather than it needing to go to help loved ones in need of dental care who would be covered by it. So please, vote in favor of LD 996. Dental is health, medical is health. Thank you.
Thank you for sharing that story. Next, we'll hear from Kate Endy. Welcome.
Thank you, Senator Claxton, Representative Meyer, members of the Joint Standing Committee on Health and Human Services for this opportunity to provide comments in support of LDs 996, 62, and 72. My name is Kate Endy. I use she, her pronouns, and I'm the Policy Director at Consumers for Affordable Health Care. We're a nonpartisan, nonprofit organization that advocates for Maine people to be heard, respected, and well served in a health system that provides coverage, access, and quality affordable care to all. As designated by Maine's Attorney General, CAIC serves as Maine's Consumer Assistance Program for health insurance, and as such, we operate a toll-free, confidential helpline staffed by trained experts in eligibility and enrollment in private and public health insurance. We also serve as the Ombudsman Program for Maine's Medicaid program, Maine Care, and help people with applying for and navigating Maine Care coverage. It's our experience assisting people in Maine with navigating healthcare and coverage systems, including the gaps in those systems, that drives our support for this bill today. Often when people call our helpline with dental care needs, they've done so after exhausting all other possible resources and have reached a point of crisis and desperation. Without access to preventative services, Maine Care members are forced to endure painful, even debilitating conditions that require expensive emergency interventions. These are conditions that could have easily been stopped in their tracks had routine dental care been available when they needed it. Studies of the effect of cost-sharing requirements on people with Medicaid coverage have shown that cost is a significant barrier to accessing care in a timely manner. Excluding dental care from coverage discourages people from getting the preventative care that they need and leads to delays in care for as long as possible. A 2010 report found that the top diagnostic reason for visits to the emergency department among main care enrollees for young adults and adults ages 25 to 44 was dental disease. And in 2007 alone, there were close to 33,000 visits to the emergency department that were due to preventable dental conditions, half of which were paid through main care coverage. Our mouths are part of our bodies, so it is no surprise that numerous studies have also found that oral health is closely tied to overall health of the rest of our body, and that poor oral health is associated with diabetes, heart disease, and stroke, as well as other conditions. Studies have also shown that dental and oral health can significantly impact an individual's employment and economic opportunities. According to the American Dental Association, 45% of Maine adults with low income avoid smiling due to the condition of their dental and oral health. And more than 1 in 3
seconds, please.
With that, I'll just say I was submitting written testimony and that this bill is about promoting the overall health, financial well-being, and dignity of Maine people. And for those reasons, we ask for your support. Thank you very much.
Thank you for your testimony, Ms. Endy. Now we'll go to Kathy Kilrain Del Rio.
Thank you. Good afternoon, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. My name is Kathy Kilrain Del Rio. I use she, her pronouns, and I'm the Director of Campaigns and Healthcare Advocacy for Maine Equal Justice, a nonprofit legal aid provider working with low-income Mainers to increase economic security, opportunity, and equity for people in Maine. Today, I'm submitting testimony in support of LD 62, 72, and 996, but my testimony is focused mostly on 996. And we really appreciate all of the sponsors and co-sponsors of all 3 of these bills. As you've heard from many others today, our oral health touches on many aspects of our lives, affecting what we can eat, our employment, chronic conditions like diabetes and heart disease, prenatal health, mental health, and our ability to smile even with our families and loved ones. At Maine Equal Justice, we've heard from many people about the ways a lack of access to dental care has caused harm. The stories can be heartbreaking, infuriating, frustrating, just like those you've heard today, but they all could have been prevented. Maine's limited emergency dental benefit for adults in our Medicaid program is not sufficient to ensure good oral health for Maine care members. Currently, this limited emergency benefit only covers relief of pain, infection, and imminent tooth loss under defined circumstances. As a result, the oral health and physical health of low-income Mainers is being negatively affected by a lack of access to the full range of dental care needed to live a healthy life. LD 996 is an important solution to our state's oral health challenges. It creates a comprehensive dental benefit. And in addition to that, it also encourages participation from people who are transitioning from coverage as a child to coverage as an adult. It seeks to address racial and ethnic disparities. And it also asks for a report after 5 years about how this goes so that we can learn from that and see make sure that we're meeting our intended goals. I also want to highlight that this benefit would allow Maine to bring in more than $17 million a year in new federal healthcare funds and lower state spending on emergency care by $4 million a year. The Health Policy Institute of the American Dental Association found that providing this benefit to Maine care members with diabetes or cardiovascular disease and to those who are pregnant would save our state $2.7 million annually due to the connection between oral health and those conditions. This translates to $1.41 per enrollee per month. Furthermore, HPI's research found that the broader economic impact of investing in this benefit would be $21.6 million annually, with nearly half of that economic activity occurring in rural areas where approximately 48% of Maine care members reside. And several people have referenced this report, and I couldn't figure out how to attach it with my testimony, so I just emailed it to all of you, so you should have it in your inboxes. It's not surprising, given the importance of our mouths for many aspects of our lives, that people with poor oral health face negative consequences to their well-being. At Maine Equal Justice, we hear all the time from people who are suffering due to a lack of dental care. They tell us the stories just like those you've been hearing today. And in wrapping up, I also just want to say that this is also an investment in our workforce development for our state. We know that this impacts employment, it doesn't make any sense that our mouths have gotten disconnected from our bodies when it comes to healthcare coverage. So please, I'm asking you today to make Maine smile by passing LD 996. And I'm happy to answer any questions that you have.
Thank you for that. I'll look forward to checking my email.
Thank you.
Thank you. Next, we'll go to Kayla Kalel.
Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee for Health and Human Services. Good afternoon. My name is Kayla Kalel. I'm a resident of Bangor in Penobscot County, and I'm here to testify in favor of LD 996. The bottom line is that all Mainers should have access to healthy mouths. Unaddressed tooth pain and the problems that come as a result can turn into a whole host of health issues, which cost even more money to address. I am a single mom with Maine Care as my primary insurance, of which I am so grateful. However, lack of dental coverage has become a significant barrier for me. I'm set to graduate with my bachelor's in just a few weeks. Through the last 4 years of my undergraduate studies, I have made it a personal goal to not take out student loans. And until very recently, I have done well at maintaining this goal. I have several college peers who are graduating with crippling debt, and I have worked hard to ensure that I did not have to take this route. This often meant working 50-hour work weeks, lots of overtime hours, and long shifts while balancing motherhood and studies. I have a lot of work that needs to be done in my mouth, both to stop severe and chronic pain and to address problems so that I can keep the teeth I do have left. Without dental care insurance, I have backed myself into an unavoidable corner where the last several semesters I have had to take out $2,000 per semester in student loans just to cover a small portion of what needs to be addressed in my mouth. This is concerning particularly because the $2,000 per semester will equate to significantly more when we think about interest and additional fees. Interest can be as much as $3.50 per day, which is so disheartening when we remember that this is my reality simply to keep the teeth that are in my mouth and to reduce daily chronic pain. The other thing I want to mention is that if I would have had access to consistent preventative dental care as throughout my adult life, a lot of this work would have been significantly reduced. Tooth pain is distracting. It's unbearable. It causes me to divert my attention from worthwhile, meaningful volunteer engagements, work, and school to then be thinking about incessant mouth pain, which often leads to infection. I'm trying to care for my teeth now so that I can continue to be present for my daughter and all of my life responsibilities. I think it's important to also mention that folks like myself who identify as being in long-term recovery will continue to have a hard time doing the amazing work in the community if our physical health needs are not met. When I was in early recovery, I had to work extremely
30
hard
seconds, please.
to build up my self-esteem. I couldn't imagine going to a job interview while feeling like everyone was going to be staring at my teeth, or in some spots of my mouth, lack thereof. Maslow's hierarchy of needs from 1943 has underlined how extremely difficult and often impossible it is to expect people to address higher levels of existence, like going back to school, maintaining long-term recovery, keeping a stable job, when they do not even have their basic human needs met. Simply put, dental care is healthcare. As a main stakeholder, I would ask you to support this bill so that single moms like myself can thrive and operate at our highest potential. I'm happy to answer any questions, and I'm grateful to be here.
Thank you for your testimony, and good luck with the rest of your path, wherever that takes you. Next, we'll hear from Kimberly Hamill.
Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. I'm here today to testify in favor of LD 996. My name is Kimberly Hamill and I live in Levant. My pronouns are she, they. This is my third time testifying in favor of this bill. The last year has been a nightmare. My teeth are crumbling out of my mouth. I need new dentures. The denture I'm wearing now is broken and it barely stays in place. I have had a temporary crown on a tooth for years too long. I struggle to pay for dental care for myself and also for my daughter. My daughter has TMJ, temporomandibular joint dysfunction, and needs regular access to the dentist due to chronic severe jaw pain. She needs her wisdom teeth removed. She has a number of teeth in varying degrees of decay, and sometimes she's up in the night crying from pain. I work full-time at a mental health clinic and have a full roster of clients. I have anxiety about my dentures falling out while I'm working with my clients. It's unnecessary and it's an upsetting distraction. My daughter's a junior in college and her graduation date and my bank account balance loom heavy in my mind. I worry that her teeth will affect her job opportunities when she graduates. I also know from experience that an appearance is incredibly important when you're looking for a job. It also affects confidence and the ability to communicate effectively in the workplace. My daughter covers her mouth when she smiles and speaks sometimes, and she's self-conscious. I worry poor dentition will affect her overall health, and we're trying to come up with the money now to fix her teeth.
We're having trouble. We're having trouble with your audio. You may need to turn off the video.
Oh, okay. Sorry about that.
No. That's one of the technical problems we anticipated today.
I worry that poor dentition will affect her overall health, and we're trying to come up with the money now to fix her teeth, which is estimated to cost our family thousands of dollars. We don't have that money at this time, and I know that she's in pain and it causes me emotional distress. With permission, I'm willing to submit the cost estimates for both our dental work for the work session, because it's like a low estimate is $20,000, and what average citizens could afford that amount. The cycle of poverty is the central reason why dental care is so inaccessible. My daughter will be blocked from getting ahead because our healthcare system doesn't see dental health as part of our overall health. Treating dental and eye care as if they're not essential elements of human health is ridiculous. People like my daughter are being set back and barred because she's poor. Smile is the first thing that a person sees, and a healthy set of teeth have a huge impact on a person's confidence and sense of self-worth. Appearance is also known to have a direct impact on employment status and rate of pay. Please champion this issue this legislative session and vote ought to pass on LD 996. Please look at my beautiful daughter and find a way to fully invest in her access to dental care. Thank you so much for your consideration.
Thank you for bringing that story forward. As far as posting the bills, that's up to you. And we understand when you say $20,000, it's a big number.
Yeah, and I just don't know that there are average citizens who could pay that amount. And, you know, it's certainly distressing to me. Thank you.
Thank you. Next, we'll go to Maddie Magnuson. Welcome.
Thank you. Can you hear me?
We can.
Great. Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. My name is Maddie Magnuson, and I live in Bath, Maine, and I'm here today to testify in favor of LD 996. I want to build upon some of the testimony you've already heard. For example, Carolyn Silvius, who had similar issues, it sounds like, to myself. I also had childhood unusual teeth things. So due to the luck of my genetics as a child, I was missing 6 adult teeth. The baby teeth were fused to the bones of my jaw and need to be surgically removed. As a teen, my mother decided to take on the debt to get me 2 dental implants for the teeth I was missing on the bottom and a partial denture for the 4 teeth I was missing on the top. I am grateful for the medical debt my mother took out on me as a child. However, the financial strain put on my single mother was incredibly stressful for me as a child. She worked 2 jobs, one as a high school secretary and the second working evenings at Bed Bath & Beyond to make sure we had food on the table and a roof over our heads as she paid off the debt from the dental care. If we had had comprehensive coverage for dental care, we would not have experienced the financial stress we did, and she would have been able to be more present for me as a child. I am partially here at the recommendation of my therapist due to anxiety and mental health struggles to issues like this. As a 30-year-old, I am going through the same financial stress again related to my teeth as I went through as a child. I recently had to have a tooth extracted after it was being reabsorbed due to the stress put on the area after 15 years of wearing a partial denture for 4 teeth, which is why I want to stress in the bill the importance of restoration for missing teeth, not just dentures, but implants. Restoration should cover the best option for the long-term health of the patient, and especially like we heard from Karen Silvius, long-term dental wear is very painful and not a best long-term solution. So I now need to get upper implants since the partial denture is no longer a good long-term solution. Even with dental insurance through my job, I need to take out $25,000 in debt from the procedures I need because it will not be covered by medical insurance since it's considered dental and the dental plan will only cover $1,500. This has been incredibly stressful for me. I now, like my mom, am taking on additional night and weekend work to help make ends meet. If I had been able to get all the implants I needed as a minor, I likely would not have lost my seventh tooth and be in this stressful situation again today.
30 seconds, please.
It should go without saying that dental care is medical care. To separate it out and not cover it is both ignorant and inhumane. Without a full set of teeth, I've struggled with eating, mouth pain, and mental health. Everyone, especially individuals and families with low incomes, should have access to comprehensive care, which includes dental care. I urge you to pass LD 996 and do all that you can within your roles as legislators to ensure that all Mainers have access to affordable health care, including dental care. Thank you.
Thank you for that testimony. And I have to at least say that I hope the courage to offer it is a step on your pathway that's healthy. Thank you. Now we'll go to Megan Hannon. Welcome.
Good afternoon, Senator Claxton, Representative Meyer, ladies and gentlemen of the Joint Committee on Health and Human Services. I am Megan Hannon, Executive Director of Maine Community Action Partnership, and we support LD 62, 72, 996, and 1501. For more than 50 years, Community Action has served as a dynamic and community-based force addressing the causes and conditions of poverty throughout Maine and in the country. Our 10 community action agencies deliver services for people with low and moderate income, including the Home Energy Assistance Program, or HEAP, Workforce Development, Current Rental Relief Program, Head Start, and more. One of our agencies includes a federally qualified health center, which includes a dental clinic, and several provide forms of oral care, dental care, from tooth sealing for children to a mobile dental unit. Somebody mentioned this earlier. How did the mouth and teeth get separated from the rest of our bodies? Who decided healthcare skipped right over our mouths? We know that our mouth and teeth are an important part of our health, from eating and drinking to the biome that lives within them. It is also one of the first things people see when they meet you. Your smile puts people at ease, shows them you're friendly, and lets people approach you openly. When your smile shows missing teeth or rotten teeth, people judge you differently, and that makes a difference. It's harder to find a job, especially customer-facing jobs. It's harder to make friends or find romance. It puts you out as someone of low income. Ensuring all children have access to comprehensive dental care sets them up for healthier, happier adulthood. The more accessible care is, including at school, this is for 1501, the more likely the program is to be used consistently, and we know that dental health consistency is key. Adding comprehensive preventive, diagnostic, and restorative dental services to basic Maine care benefit means more than just the ability to get your teeth cleaned twice a year or to repair damage. It can literally change a person's life for the better. The person will be healthier, certainly, physically, mentally, and emotionally. It is not a luxury or expensive benefit to add, yet is an important one. Thank you very much. I'm happy to answer any questions that you have.
Thank you. And I'm not seeing any questions, so we'll go to Megan LaSala.
Good afternoon. My name is Megan LaSala. I use she and her pronouns. Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. As I said, my name is Megan. I live in Portland, and I'm here today to testify in favor of LD 996 on behalf of the Southern Maine Workers Center. Thank you so much for hearing our testimony on this important bill. I'm the interim executive director of the Southern Maine Workers Center. We're an organization of everyday Mainers working together to win our human rights, including the human right to healthcare and the right to work with dignity. We support LD 996 because healthcare is a fundamental human right, and it's a right that will never be realized until comprehensive dental care is made fully available to all people. Our mouths are part of our whole bodies, and dental health impacts our whole health. Many of our members are main care recipients and have struggled to get necessary dental care. You will be hearing and have heard from several of them today. This legislation will have an immediate impact on the lives of our members. Last year, when I testified on behalf of this bill, I traveled to Augusta with a person named Emily. Emily is a main care recipient and had recently spent over 6 weeks hospitalized because of a tooth infection that spread to her hip. Dental care can literally become a matter of life and death. Increasing evidence links poor oral health and serious medical conditions, including heart disease, diabetes, arthritis, cancer, and diseases of pregnancy. Lack of access to routine preventive care is one way society tells poor and low-income people that their lives are disposable. There are many aspects of our healthcare system that are unjust and inhumane. With this bill, we have the opportunity to move our system closer to one that respects human rights. Dental care is healthcare, and healthcare is a human right. Please move our healthcare system in the right direction by voting to move forward this legislation. I'm available to take any questions, and thank you for your time.
Thank you for being here. I'm not seeing any questions. So we'll go to Michael Mosley.
Hello, good afternoon, Senator Claxton, Representative Mayor, and the distinguished members of the Health and Human Services Committee. My name is Michael Israel Mosley. I'm a resident of Waterville, and today I'm speaking in support of LD 996. Quickly, I'm going to share my own story. My wife spent about a year and a half with a broken tooth. For most of that year and a half, she tried to use every other alternative that she could. That includes Oragel, that includes clove oil, that includes bone wax, which I didn't even know was a thing, and including over-the-counter pain medication. The only way that I could convince her that we could spend the money to have her seen was when her face got swollen with an infection. It then took another month before we could find anybody who would take us on main care. And I myself, just on my own experience, I haven't seen a dentist in more than a decade. I've seen one once, that was like 2 years ago. And I was told that I would need to spend $1,250 out of pocket just to figure out if I need to have teeth removed and replaced, which would be an additional expense all its own. That's just my story in a nutshell. But this isn't the first time that I have spoken on this issue. And I have included my testimony from the last session because I believe it's an important reminder of why we're here today. Today you heard stories and will hear stories and experiences and expert analysis. Unfortunately, it's not the first time for any of these people who have come here today who have had to share what are often embarrassing and difficult experiences. They have done so repeatedly, and each time there's been more support given by both the public and members of the legislature. And yet we're here meeting again and nothing has changed. So I will simply leave you with the words of Langston Hughes. What happens to a dream deferred? Does it dry up like a raisin in the sun? Or fester like a sore and then run? Does it stink like rotten meat or crust over and sugar over like a syrupy sweet? Maybe it just sags like a heavy load, or does it explode? Thank you for your time.
Thank you, Michael. Next, we'll go to Michelle Gagne.
Hi, everyone. Good afternoon, and thank you for taking the time to hear my testimony today. Senator Claxton, Representative Mayor, honorable members of the Joint Standing Committee on Health and Human Services. I'm here today to testify in favor of LD 996. My name is Michelle Gagne, and this is my second time testifying for this dental bill. I am praying it passes for the governor. I know you guys were all in favor last time, so huge prayers. I live in Winslow, and I'm a single mom of 3 boys. And when I stood here before, I was a student at KVCC, going through college, and now I graduate in May with my MERT-C as a case manager. And I am helping 20 other clients and others, and even my family, on getting our teeth fixed. And where I work, of course, in the mental health field, only making $15 an hour and trying to provide possibly dental for my family is really tough, especially getting paid biweekly, but that's another story in the mental health field. We're only making, enough as if like we're a Domino's pizza delivery driver or something, but which is really sad. But on the other note, dental care is very important, and I advocate this all the time, every day. There's times at night where my jaw is out of aligned and I wake up, massaging that. My other half had to have 14 teeth extracted, and this is actually him before getting his teeth extracted, and he is now currently right here. Just needs help on getting a job and having that smile. So our smile is everything, and just thank you for taking the time to hear my testimony, and I hope this bill LD 996 does pass and helps all Mainers that deserve it, and we all deserve it. Thank you.
Thank you for being here. Next, we're going to go to Mickey Rice. Oh, Mickey Rice, or do you want to unmute and join us? Okay, let's come back to Mickey and Patty Kidder. Are you ready?
I am. Thank you. Senator Claxton, Representative Mayer, and honorable members of the Committee on Health and Human Services. Thank you for the opportunity to speak to you today. My name is Patty Kidder, and I live in the village of Springvale, located in the city of Sanford. I submit these remarks as a representative of the Maine Unitarian Universalist State Advocacy Network, a faith-based organization which affirms and promotes justice, equity, and compassion in human relations, and the inherent worth and dignity of every person. My faith motivates me to speak in favor of LD 996, an act to improve dental health access for Maine children and adults with low income. Also, I am a low-income adult who would have benefited greatly had this law been enacted years ago. I could have received the preventative dental care that could have saved my back teeth. Instead, they became infected, full of decay, and had to be removed. Now that I only have one molar, it is very difficult for me to chew my food with only my front teeth. I bite the inside of my mouth on a regular basis when I eat because my bite doesn't line up anymore. I need to have either partial or full dentures, which I cannot afford, but this bill would provide. I am here to give a voice to my other low-income friends who need Maine Care to cover their dental health care. We all need to have a healthy smile. We need to keep our mouths healthy because it can affect the rest of our bodies. I heard that having a regular dental exam can even identify other medical issues that could go undetected for years. Having poor dental health can even cause depression and anxiety, and it makes it harder to get a living wage job. You can't prove discrimination, but people judge you when you have poor dental health. You can help low-income Mainers prevent tooth decay and losing their teeth prematurely like I did. As a person of faith and someone who needs the dental care that this bill would provide, I urge you to please support LD 996 and provide full dental care to low-income Maine children and adults. Thank you so much for your time.
Thank you, Ms. Kidder, for your testimony. Thank you for being here today. Let's go back to Mickey Rice. Are you with us? Can you unmute and join us? I'm not seeing any response there, so let's go to Rebecca Wartell.
Senator Claxton, Representative Mayor, and honorable members of the Joint Standing Committee on Health and Human Services. My name is Rebecca Wartell. I live in Gorham. I use she, her pronouns, and I'm a member of the Southern Maine Workers Center. I'm here today to speak in support of LD 996, both as myself and to share words from a couple of medical professionals who were unable to be here today because they're at work in the emergency department at a local hospital. I also support LD 62 and 72 and the ways that these bills complement each other. To start, I have a statement from Emily Bays, RN. As an ER nurse, I witness frequently firsthand the consequences of poor access to routine and preventative dental care. Patients present to the ER in agony, seeking help for a problem that has often been developing for months or years. They often seek care when their pain has become unbearable, interfering with daily life and impairing their ability to eat. At times, their infection has become so severe that they're systemically ill and medically stable, requiring emergency intervention. It is frankly disgraceful that Maine Care does not include dental coverage. The health of our teeth and gums is integral to the overall health of our bodies, our ability to eat the food we love and that nourish us, and our general quality of life. Access to dental care under Maine Care would prevent the desperate suffering I routinely see as a result of our current inadequate system. I also have words from Christopher Hassling, MD. As an emergency physician, I take pride in caring for Mainers who arrive at our ER with a condition at any time of day or night, regardless of background or ability to pay. We treat and stabilize emergencies and direct patients to the care they need. Far too often, patients present with complications that arise from an inability to afford dental care to learn that we have shockingly little to offer them. If they've developed a life-threatening emergency, such as dental infection that is spread to the bloodstream, brain, or is impairing their ability to breathe, we're able to admit them to the hospital to be treated by a team of doctors and oral surgeons. The cost of this compared to a simple dental extraction is astronomical. If their infection has not yet reached this degree of severity, we're left with limited options. These patients are sent home temporizing measures, but we cannot fix the underlying problem. We hope that they can find a generous dental practice that can provide free care, but often this is not an option. This deep flawed system. Access to dental care is imperative for the health of all Mainers. I'd like to use whatever time I have remaining to share a conversation I had a couple of years ago when I went to the Dentists Who Care Free Dental Clinic Day. This clinic happens once a year by the generosity of dentists who choose to participate. It's first come, first serve, and you have a choice of one service, either cleaning or extraction. It's free, and it's often the only non-emergency medical care that people without dental insurance are able to access. It was a really cold, windy, early November, and a long line of shivering people ran along the side of the building, many of whom had taken time off from work, still losing needed money to be there. I ended up talking with someone in line who told me she comes to every year. This isn't the extent of her dental care, but it's ritual because she knows the importance of dental health. The previous year, she had gotten a cleaning and they found a cavity. She had to wait an entire year to come back and have that tooth, which by this point was causing her excruciating pain, removed. And even while waiting in her turn in line, she was worrying about skipping her cleaning this year to have extraction and wasn't sure the right choice. No one should be in this position. This bill is an important step in seeing dental care as a component of full body wellness. I often hear teeth jokingly referred to as luxury bones in that way that we do to laugh to keep from crying. But really, oral health needs to be taken just as seriously as heart health or other vital bodies. In fact, it's intricately interconnected with those systems to an extent that we're only just beginning to understand. Dental care is healthcare. This is the humane and just thing to do, and also the economically sensible thing to do. Thank you.
Thank you for that testimony. Next we'll go to Sass Lincoln. I understand you have to leave at some point. Sorry if we're making you late.
No worries. Thank you so much. Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. My name is Sass Lincoln. I use they, them pronouns. I live in Skowhegan, and I'm here today to testify in favor of LD 996. Some of you may remember me from the last time I testified for this. I'm going to give similar testimony. Growing up in poverty and being chronically homeless from age 16 to 23, I know the impacts of inadequate dental coverage. Due to losing my dental coverage while I was homeless, I ended up stuck wearing my top braces for 5 years and my bottoms for 7. The sustained dental neglect resulted in a chronic gum infections that eventually led to an antibiotic-induced intestinal infection that almost killed me. And it resulted in thousands of dollars in medical bills due to a 4-day hospital stay that I had to have. I'm 42 years old today, and I have almost no natural teeth left. At 39, I was forced to put almost $6,000 onto credit to have the teeth that were ruining my health extracted and to replace them with partial denture. This has deeply impacted my life, though I do want to just note that having access to credit at all is a huge privilege that I didn't even gain until I was in my late 30s, because when you're poor, there's a huge barrier to getting credit. And if I didn't have that credit, then I would have almost no teeth. As a result of this borrowing, my bills became so high that I faced needing to file for bankruptcy a year after losing my teeth, and was only saved from having to do that because at the last minute, right before I was about to file, I received a raise that gave me just enough to cover my minimum payments. If I were to lose the job that I have today, I would absolutely need to file for bankruptcy right away due to that borrowing. I have pulled myself from poverty into the working class, and these are the real and very lasting impacts of not having access to dental care. People in poverty are already under the stress of having their basic needs unmet, like food, housing, heat, transportation, childcare, and more. Those of us who have been lucky enough to pull out of that struggle to meeting just our basic needs like I have, will inevitably continue to be pulled backward by the implications of the medical neglect that results from not having your very real dental health needs met.
30 seconds.
Teeth are important. As Becca said, they shouldn't be considered luxury bones, only fitting for those who can afford them. I also saw them referred to that way recently in reference to how employers and health insurance companies seem to see them. And I thought it was pretty fitting to include here, since we still aren't covering dental care for low-income adults in Maine. So please pass LD 996 to show people who are struggling in our state that they matter to you, and that they're every bit as deserving of dignity and health as anybody else. Thanks for listening.
And thank you for sharing your story. Appreciate your being here. Next, we're going to go to Ronnie Flannery. Welcome.
Good afternoon, Senator Claxton, Representative Meyer, members of the Committee on Health and Human Services. My name is Ronnie Flannery. I use they, them pronouns. I'm a community organizer for the Southern Maine Workers Center. I believe healthcare is a human right and that dental care is healthcare. Today, I'm reading for a beloved friend and member, Kirk Robbins, who couldn't be here today, but has been fighting for this healthcare solution for many years. Kirk shares, I support LD 996 that would add a dental benefit for adults on Maine Care. And I want to share my story about why access to dental care is so important for me and thousands of other Mainers. My dental issues go way back to before I had Maine Care. I grew up poor and have worked low-wage jobs most of my life. And like many people in those circumstances, I never had insurance. In fact, I never had insurance until I got Maine Care when I was 50 years old. The problems with my teeth started about 10 years before that, when I developed a bad toothache. During a visit to a clinic, they told me that I was in the middle stages of periodontitis gum disease, diagnosed on the spot. I had no insurance, and they didn't give any kind of indication of what to do. It got worse in the 10 years after that. My teeth would get so loose, I could just pull them out of my mouth. My teeth were a mess. They were black and jagged, and if I opened my mouth, I looked like a Halloween jack-o'-lantern, which, as you can imagine, does wonders for a person's self-esteem. I would get toothaches. I really struggled with eating. I felt like my mouth was making the whole rest of my body sick. I felt sick and drained. And also during those years, I was drinking a lot to cope. In 2009, I got really sick and had liver failure. And through that experience, I was finally able to qualify for main care. I got a caseworker through Shalom House. And when the caseworkers meet with a new client, they set a goal for what the client wants to achieve. Their goal for me was to get dental help. That's all they wanted to do. But even with main care and 2 caseworkers, they couldn't get me any help. I was on main care for 5 years before I got the dentures I actually needed. 5 years. And my caseworkers, my healthcare providers, everyone knew that that was what I needed most, was dentures. And I couldn't get them. I couldn't get the dental care I desperately needed because main care wouldn't cover it. When I finally got fitted for dentures through a community program that was on the verge of closing down, the dentist told me that because I'd had untreated periodontitis gum disease for so long, that my gums had deteriorated badly and that it would be hard to get a good fit on the dentures. They almost didn't go through with the operation because my gums were so bad. Even today, the dentures are loose and I have to tape them every morning. I can't help but wonder if I hadn't had to wait 5 years after getting main care, if it would have been different. Maybe my gums wouldn't have deteriorated so badly. Maybe my dentures would fit better. It's time for main care to cover adult care. No one should have an experience like mine. And the bottom line is really simple. Dental care is healthcare, and healthcare is a human right. 2 sentences that you really need to hear, and you shouldn't need to hear much more than that. Thank you on behalf of Kirk Robbins.
And thank you for bringing his testimony to us. Next, we're going to go to Salim Salim.
Thank you. Good afternoon, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. Thank you for the opportunity to submit these comments in support of LD 996, an act to improve dental health access for Maine children and adults with low incomes. I'm here in support of LD 62, 72, and 996, and my testimony this afternoon will focus on LD 996. My name is Salim Salim. I use he, him, his pronouns, and I arrived in Maine 11 years ago with my family from Iraq. We became citizens in the summer of 2015, and given my background transitioning into this country, I know firsthand that this bill will directly impact a large number of my fellow community members, and because they are my family, my friends, my colleagues, and also my mentors. I currently serve as an assistant to the Senior Community Health Worker team at a Maine Access Immigrant Network, which is a nonpartisan nonprofit organization that's working to improve access to health and social services for all, with a focus on our refugee and immigrant communities in Maine. So Maine builds a stronger multicultural community and addresses refugee health literacy, healthcare enrollment, and coordination of healthcare benefits and non-clinical care. The team provides resource and referral information that is culturally and linguistically appropriate in English, Arabic, Somali, French, Lingala, and Swahili to ensure equal access to programs and services for our client community. This includes access to and the effective use of affordable or oral health care. Many of Maine's clients are Maine Care members. Our team of professional community health workers help our client with Maine Care understand how to best utilize Maine's healthcare system, emphasizing the importance of preventative health and regular wellness visits. Yet when a client comes to our office in agony from their dental pain, we feel helpless. More often than not, a Maine Care client's only option for pain relief is the emergency room, where Maine Care will only cover tooth extraction. Many of Maine's clients, all too frequently, our team witnesses these clients leaving the emergency room with pain medications or a tooth extraction and absolutely no access to follow up with a treatment or to resolve the problem. Without comprehensive oral health care, our client will never fully heal and will continue to endure unnecessary pain, health risks, and or avoidable tooth loss, which we know could have been prevented through less invasive and more cost-efficient preventative care. So good dental health is crucial to overall health. It's also humane. Adding a dental benefit to
30
Medicaid,
seconds, please.
adding a dental benefit to Medicaid would mean that more Mainers, our neighbors, who contribute so much to this great state, can get the necessary regular dental care that they need. Thank you so much for your time.
Thank you for that testimony. I want to try one more time with Mickey Rice. Are you there, Mickey? Looks like you're still muted if you did want to join us. Okay, then let's go to Stephanie Chase. Welcome. You want to unmute and join us?
Hello. Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. My name is Stephanie Chase, and I'm here today to testify in favor of LD 996. I live in Augusta with my 4 children. There was a time when my teeth were a mess, and I felt like I would never fit in. I would always cover my smile when I laughed. My then 4-year-old would ask me why my teeth were so ugly. You can explain poor dental health to a small child, but it is hard to explain a broken system that no longer cares for you once you are an adult. It was embarrassing. When I was 19 years old, I went to the dentist for a filling. I was told that my teeth were perfect. When I was 21, I had my first child and my teeth began to get weaker. For years, I had no preventative or diagnostic care. My teeth went from healthy at 19 to unhealthy at 21 and deteriorating at 25. It was hard to have 2 young children while suffering tooth pain. The pain would wake me up in the middle of the night. It felt like a lightning bolt and had me on the floor. It was hard for me to get a job. I couldn't speak in public. I often felt judged. For years, I was in a domestic abuse situation, and when I was 29, I was finally able to escape to a women's shelter. I was able to get grants for college and a grant to fix my teeth. I had to prove that I needed to have my teeth fixed by writing a letter. I had all but 5 teeth removed and was fitted for dentures. The organization that paid for my dentures saw that my teeth were a barrier in my life. They knew that I needed a better smile if I wanted to be able to move up in the world. For the longest time, dental care was attached to the fantasy of winning the lottery. If I had a ton of money, I would hire a dentist to help my friends and family. Many people want a car or a house. I want teeth for my friends and family. Many people's fantasies revolve around material things. For me, it's healthcare needs because I see how high the need is. Getting dentures to improve my life. I can now laugh without covering my face. I now have the confidence to stand here in front of you and engage in other public speaking. I would not be able to do this if my teeth were not fixed. The story is hard for me to tell, especially since domestic violence was what led me to actually being able to get help. I want this care to be available so that people can be their best selves. Thank you, and please vote to pass LD 996.
Thank you. Thank you for sharing your story. We'll hear from Whitney Parrish and then Dan Moran. And if you're in the attendees column and haven't testified, please put your hand up. But go ahead, Whitney Parrish.
Thank you, Senator Claxton, Representative Meyer, and distinguished members of the committee. My name is Whitney Parrish. I'm the Advocacy and Communications Director for Health Equity Alliance and a resident of Hollowell. Health Equity Alliance is a nonpartisan nonprofit public health and harm reduction organization that envisions and works toward a world where all people are valued and celebrated and health justice is realized for everyone. We're here again in strong support of LD 996 because everyone deserves the best chance at better health and a better life. And we believe dental care is absolutely critical to achieving these goals. Health Equity Alliance serves 2 groups of Mainers in a clinical capacity: people who use drugs and people who live with HIV and AIDS. Dental care is one of the single most important pieces of healthcare for these 2 groups of people for several reasons, like you've heard today. For people who use drugs, specifically destigmatization, pain control, such as a situation where pain could contribute to resumption of use if someone is in recovery, preventing serious conditions like endocarditis, as you've heard, which a recent Maine study on injection drug use and endocarditis has shown a median cost of $150,000 for treatment per person, and combating HIV and hepatitis C transmission. I do want to underscore that as the city of Boston announces today a significant HIV outbreak among residents who use drugs. This is incredibly important. Dental issues are one of the most prevalent comorbidities related to drug use. Drug use, no matter the substance, can decay teeth and lead to generalized dental caries, periodontal disease, promotion or intensification, of serious infections. We're particularly concerned because of the uptick of methamphetamine and other stimulant use, which really dries out the mouth and can lead to terrible dental issues that are very painful. The impact of dental problems that go unaddressed, as you've heard, disrupt a person's chance and ability to live a healthy, fulfilling life, feel comfortable around their community where they could gain connection and support, especially in the face of other barriers and stigma. I know many here have spoken to the importance of people in recovery receiving the dental care they need. Everyone, including people who use drugs right now, deserve dignity and care. It does quite literally mean the difference between life and death. So, we believe that to truly claim we're doing all we can to support people who use drugs, people who are in recovery, and combat the crises we see ourselves in, we must make dental care available and accessibility to the people who need it most. The preconditions for recovery, including finding income and meaning through employment, become insurmountably challenging. I'll wrap up. When individuals are living in debilitating pain, battling life-threatening infection, or simply cannot smile. With that, we thank you for sitting through this long hearing. I know many of you have heard these testimonies before, and we're incredibly grateful to you and Speaker Fecto for his leadership, and strongly encourage you to vote ought to pass on LD 996. Thank you for your time and attention. I'm happy to answer any questions.
Thank you for your testimony. Next, we'll go to Dan Morin. Welcome, sir.
Good afternoon, Senator Claxton, Representative Meyer, members of the committee. I'm Dan Morin, Director of Communications and Government Affairs for the Maine Medical Association. We represent over 4,300 physicians, residents, and medical students across all specialties, organizations, and practice settings. We're here in support of LD 996, and I can see from my second paragraph I didn't write LD 62 and 72, but it says we also support, so you can insert any bill there and take advantage of the mistake in my testimony. Having access to dental care is just as important as having access to a primary care physician. That's the belief of our members of our legislative committee and our board of directors. They chose this bill to have us come and testify in support of it. You've heard the growing evidence that linked to oral health, particularly periodontal disease, and several other chronic diseases, including diabetes, heart disease, and stroke. What's the solution? Regular visits to the dentist. How can we do it? By passing this bill. If you take a look at one of my paragraphs, it actually references, I found this interesting, the 21 years ago, Surgeon General's report on oral health in America, the major message having to do with oral health care identified inequities and disparities that affect those least able to muster the resources to achieve optimal oral health. At a time when we're focused on inequities and disparities so appropriately, we need to look back at a study from 21 years ago that talks about inequities and disparities in oral health care. If you take a look at the 2020 Surgeon General's report on oral health care, and I have the link there, it has a couple slides that I thought were interesting. One, geography influences oral health care. And if you look at the first chart, the first PowerPoint slide, it says percentage of US adults 65 and over with no natural teeth. Take a look way up on the top right, dark blue, Maine. That's one of the lists we do not want to be on the top of, and we need more coverage to address that. The second one I thought was interesting, cost being a major obstacle to healthcare. We are constantly in these committees, whether it's insurance or here, talk about medical care, prescription care, mental health care. Take a look at that bar chart and see where dental care positions itself in the percent of people who didn't get selected healthcare services they needed in the past year because of cost. It overwhelms medical care, prescription care, and mental health care. You've heard emergency rooms are where people go. We know now because of the pandemic, that's not the place to go. Not only because of capacity, but because emergency care is not health care. It's costly and forces people to wait until illnesses are severe and potentially life-threatening. So we urge the committee to vote ought to pass and join other New England states such as Connecticut, Massachusetts, and Rhode Island in providing extensive child and adult medical dental benefits under Maine Care. Thank you, and we'll take any questions and be at the work session.
Thank you, Mr. Moore. I'm not seeing any questions. Thank you for being here.
Thank you.
Next, we'll go to Cameron Hamill. Welcome.
Hello, thank you for having me.
Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services, I am here today to testify in favor of LD 996 and all other dental-related bills. My name is Cameron Hamill, and I live in Bangor, Maine. I use she, her pronouns, and this is my second time testifying in favor of this bill. I turned 21 in the middle of the pandemic in 2020. Due to the virus, many dentist offices were closed for months. Unfortunately, this closure happened to occur at a time when I could have used the last few months of my remaining coverage to help improve my dental health. I lost the opportunity to fix a rather large cavity in one of my front teeth, thus losing the opportunity to improve my chances and my self-esteem. This is nearly only my dental story since the last time I spoke to this committee on this issue. I'm a junior in college, currently on the dean's list, and pursuing a double major in anthropology and political science. As members of the political sphere yourself, I trust you know the importance of a first impression. Human behavior dictates conclusions of character within the first 5 minutes of knowing someone. This judgment is drawn largely off your physical appearance as a facade of character. Unfortunately, mine has holes. I trust you all know the importance of emotions that can be displayed in a smile. Without a smile you trust, how could your constituents trust you? How could you ensure them that you are fit for the job your office entails? I do not have this privilege. This argument can be applied to many spheres of my life. I will graduate in a year, underprepared for the most important internships and job searches of my career. I will also miss out on important social connections that come from bad impressions. Having a trustworthy smile is a luxury for all Mainers at this point in time. For a state which prides itself on community, this is an absolute shame. Next, I feel I would be remiss if I didn't point out the large flaws in dental care coverage as it stands if LD 996 was to fail here. Did you know that even if I was to achieve dental health, picture perfect dental health, I could not preserve it with regular cleanings under main care? Or that if my dental health worsens, I will not be able to receive assistance receiving dentures because eating with your teeth under this system is considered a luxury. I have watched my family and friends hold on to mouthfuls of painful, crumbling teeth simply because they have no other options to do something as basic as eating. The system is full of holes. Please vote ought to pass on LD 996. Thank you.
Thank you for hanging in there so you could testify. Well done, and congratulations on your academic career.
Thank you.
Next, we'll go to Christine Hasted.
This is Chris Hasted. I'm not speaking on this bill. Thank you very much. I'll talk to you later this afternoon.
Okay. So is there anybody else here who'd like to testify in support of LDs 6272 or 996? If there are, please put your hand up, and I'm not seeing anybody. I also don't know of anybody who wants to testify against or neither for nor against. So that will conclude the public hearing portion of our consideration of those three bills. Are there questions that we should direct to Aaron in anticipation of a work session? No homework for Aaron for the work session. Yes, Representative Zager, thank you for coming through.
Thank you, Mr. Chair. I don't have a question so much as I noticed that Director Probert submitted written testimony. I would assume that she or a delegate would come to the work session.
Yeah, typically Molly is there, but do you want someone from main care to be there as well, or is
no? Just in her testimony, her written testimony, she had identified some technical things, some timelines and so forth, and that might involve some negotiation in order to get this where we might want to get it to, but also to make it workable. So for those discussions, it might be good to have somebody who could speak about that. Marley would be great, but
okay.
Just a suggestion. Thank you.
Thank you.
Thank you. Are there any other requests in anticipation of a work session? There being none, we'll conclude with this portion of the afternoon. And I'm going to hand over the chair to Representative Meyer to take us the rest of the way while I step away for a bit. Thank you.
Thank you. So we will revert back to a more traditional way of hearing bills, taking testimony in the following order: the sponsor, any co-sponsors, and other legislators, those providing testimony in favor of the bill, then those opposing, and finally neither for nor against, but with additional information for the committee. We will run a 3-minute clock on testimony, and you'll receive a prompt when you have 30 seconds left asking you to bring your testimony to a close. We will hear the remainder of this afternoon's public hearings in the following order: 1501, 1302, 1424, and finally 1460. With that, I will open the public hearing on LD 1501, an act to protect oral health for children in Maine, and welcome the bill's sponsor, Representative Gramlich.
Thank you, Representative Meyer. I don't see an opportunity for me to turn my camera on.
Oh my.
Oh, the host asked me to start my video. Well, thank you, host. I'll jump.
There she is. Welcome.
Don't we love the technology? Well, thank you. I know that you have all had a very long afternoon, and I will try to have a little bit of brevity here. This is a topic that you are all now quite familiar with. So thank you, Representative Meyer, and in absentia, Senator Claxton, and my distinguished colleague, the Joint Standing Committee on Health and Human Services. I am indeed Lori Gramlich, and I represent House District 13, which is the lovely seaside community of Old Orchard Beach. I am honored to present today LD 1501, an act to protect oral health for children in Maine. As some of you may know, in addition to my work in state government with the Department of Health and Human Services, I also worked for a number of years with the City of Portland's Public Health Division, directing the Family Health Program. Part of my responsibilities for the Family Health Program included oversight of the Children's Oral Health Program. There, I saw firsthand the incredible work done for kids in need of oral health care. Unfortunately, over the last decade or so, we have seen many of our effective prevention-based programs endure a multitude of cuts to the point of these programs no longer being effective. And sadly, the Children's Oral Health Program is but one of many of these impacted programs. Because the system is not working, and you've heard this with the bills preceding this, another overview of what's happening as a result of our failed system in terms of oral health care. We are failing to prevent oral health problems, which means that kids are missing out on learning. Dental disease creates, as you've heard, a whole cascade of health and economic outcomes that prevent kids from developing into the productive adults that we all want them to be. I know this because I've seen it in my own career. I've seen the difference between kids who are struggling with oral health problems and kids who get their oral health care needs met. Not only does poor dental care impact school academic performance, it also has been shown to affect children's mental health as well. Inadequate access to dental care in childhood has also been linked to negative health outcomes for adults, which can certainly be more costly in that the problems which could have been addressed and prevented in childhood instead follow children into adulthood, as you've heard from previous public hearings today. Accessing oral health care is not only challenging for adults, but coverage of preventive services, as you've heard, is not always guaranteed. LD 1501 hopes to provide some solution for some of this in terms of prevention care for kids. It requires that the Department of Health and Human Services expand the preventive oral health services provided in schools through the School Oral Health Program to all schools in Maine by January 1st, 2025. This expansion of the School Oral Health Program to serve all schools in Maine will also establish an oral health coordinator at the Maine CDC. Additionally, LD 1501 instructs Maine Care to pilot a value-based purchasing initiative for school oral health services to explore the ways in which to invest these services differently and maximize federal matching dollars. This pilot would also include implementation of prevention and early intervention strategies, disease management, and care coordination services for oral health services delivered in schools and in early child care settings. This pilot project must be in place by July 1st, 2022, and last no less than 24 months. The department would further be required to submit a report to this committee on the results of the pilot project. Ultimately, LD 1501 ensures that all Maine children have access to comprehensive oral health care. And we know that including this care through our schools will assure that care is delivered on a consistent basis. I strongly urge you to support LD 1501 and appreciate your consideration for this important legislation. Thank you very much for your time and your patience and your indulgence, and I'd be happy to try to answer any questions for you.
Thank you, Representative Gramlich. Question from Representative Perry.
Yeah, thank you. And I guess I am trying to sort of sort out, I do believe there is some sort of a program, or was, and I'm not sure which way it goes, where dental hygienic services, dental exams were done mobily to schools throughout the state. I guess my question is that still in existence, or are we looking to repeat that?
Thank you for the question, Representative Perry. That had been part of the bigger picture children's oral health program through the Department of Health and Human Services, and that certainly was my experience 12, 15 years ago when I worked for the city of Portland. However, it was not comprehensive. A lot of those services were delivered through schools throughout the state that were fortunate enough to have a program. There were some mobile units, certainly within the city of Portland, that did go to other schools where there was not a school-based health center, but it certainly was not universal. And the other piece of that equation, Representative Perry, is the fact that the funding has been decimated to assure that we have a hands-on oral health coordinator working for the state of Maine. So that's what this bill aims to kind of work towards making whole again.
Thank you, because I know we did have it throughout Washington County and it was very valuable.
Mm-hmm. Thank you.
Seeing no other hands up, thank you, Representative Gramlich. And
thank you.
Will welcome Senator Maddie Daughtry.
Thank you, Madam Chair. Good afternoon, Representative Meyer, Senator Claxton, and distinguished members of the Health and Human Services Committee. I am Senator Maddie Daughtry, and I represent State Senate District 24, which includes the towns of Brunswick, Freeport, Harpswell, North Yarmouth, and Pownell. And I'm here today to speak in support of LD 1501. Keeping your mouth healthy is a critical part of living a healthy life. Though we may hear about exercise and eating healthy more often, keeping up on dental health is equally important. And this is especially true for children and young adults. Making sure young people maintain good dental hygiene and develop good habits early on can lay the groundwork for a healthy life. But at the same time, a failure to get regular cleanings and keep up with brushing and flossing could lead to a lifetime of pain, expensive procedures, and additional health issues. Unfortunately, today, there are many Maine children not receiving adequate dental care, and this has only been exacerbated by the pandemic. In fact, about 40% of children consistently covered on Maine Care and 30% of children consistently covered on commercial insurance plans did not receive preventative oral health care services over the last year. LD 1501 will help address this issue. It'll get more dental care services to kids all over Maine by expanding the school-based oral health program and would reinstate a critical oral health coordinator position at DHHS. In addition, the bill would require that oral health is covered in the annual report from DHHS and allowing us to legislate more effectively and address issues that arise. Poor oral health at a young age can lead to a plethora of issues down the line. We must do our part to support Maine children and ensure that they don't grow up with pain and disease that could have been stopped with simple proactive care. And as an aside, I was joking slightly with a group of friends as we were talking about the importance of this, and all of us could immediately list off the name of our dental hygienist as children who definitely taught us good habits / put the fear of X, Y, and Z into us about why this is so important. So for all of our students, they should be able to access this in our schools to make sure they too have the same good habits ground into their memory. Thank you, and I'm happy to answer any questions as well.
Thank you, Senator Daughtry. Questions from the committee? Seeing none. Thanks for being here today.
Absolutely. Have a good afternoon.
You too. We will welcome Angela Westoff. Angela.
Thank you, Representative Meyer and Senator Claxton and distinguished members of the Health and Human Services Committee. My name is Angela Westoff, and I'm the Executive Director of the Maine Dental Association. The MDA is a statewide association dedicated to advancing excellence in dentistry, and we represent about 85% of the dentists with 774 members. On behalf of the MDA, I'm pleased to provide testimony in support of LD 1501, an act to protect oral health for children in Maine. The bill seeks to ensure children with MaineCare receive at least one preventive oral health visit annually, and it would expand oral health services to schools across Maine, and also begin a pilot project for oral health value-based payment models within MaineCare for dental services delivered in school and early childcare settings. And then lastly, the bill would reestablish the oral health coordinator position within the Maine CDC. We believe it is important to have a statewide oral health program with dedicated staffing in order to address the oral health needs of Maine's children. Cavities are one of the most common chronic diseases of childhood in the United States. Untreated cavities cause pain and infection and impact a child's ability to eat, play, speak, and learn. Children with poor oral health often miss more school and often have lower grades than other kids who do not. The good news is that cavities are preventable. With proper care, daily brushing, fluoride varnish, and sealants, we can prevent decay. In order to track and measure the impact of oral health programs, we support adding the functions of data analysis, performance management and reporting, program planning, and evaluation, all to appropriately monitor and objectively assess the impact of such programs and pilots. Further, the MDA recommends annual reporting on the number of MaineCare children eligible for oral health services through the school oral health program, as well as the number of children that are referred to a dental office for additional necessary treatment. Also, given the significant amount of information that arrives home in a child's backpack, the MDA also recommends that MaineCare, in working closely with school-based oral health providers, develop some sort of a mailer system with a perforated permission slip for the services provided by the school oral health program, and that mailer could contain information about the scheduled dates of service. Lastly, we would also respectfully suggest that perhaps a dentist serve in an advisory capacity for the statewide oral health coordinator on an as-needed basis. In conclusion, we urge you to support LD 1501. Thank you. I'd be happy to answer any questions, and I will be at the work session.
Thank you. Questions from the committee? Seeing no raised hands, appreciate your being here today.
Thank you.
Barbara Covey.
Hello, and thank you. My name is Barbara Covey. I live in Oakland, Maine, and I'm here today to testify in favor of LD 1501. And thank you, Representative Meyer and Senator Claxton, and honorable members of the Joint Standing Committee on Health and Human Services for hanging in there to hear these testimonies. As a physician, I have worked in primary care internal medicine, where I learned the importance and efficacy of preventive health care. I also worked as an emergency department physician, where I witnessed all too vividly what happens when access to preventive services is limited. Dental disease, the most common chronic childhood disease, is a preventable illness. Knowing this, it has been deeply disturbing to so frequently see children in the emergency department with dental disease. I have treated children as young as 4 years old with painful dental abscesses, seen children who have become aware of the societal stigma of dental disease, holding their hands over their mouth while speaking to hide their decayed teeth. And I have searched for treatment programs for opioid-dependent teens whose first introduction to opioids was for painful dental disease. I am a longstanding board member of Waterville Community Dental Center, a nonprofit safety net dental center serving central Maine and currently delivering oral health services to over 5,000 community members, 70% of whom are children. But even working to full capacity, our dental center cannot begin in isolation to provide the solution to our community's oral health challenges. As Senator Daughtry had mentioned, over 40% of insured children, 30% of Medicare children do not receive preventive oral health services. And I can only assume that among children without dental coverage at all, it is worse. School-based care offers a community-centered means of providing consistent preventive oral health services that can reduce the burden of dental illness in Maine's children. Unfortunately, more than 400 of Maine's over 600 schools are not currently served by Maine CDC's School Oral Health Program. Also, Maine's ability to address oral health challenges has been reduced by reduced funding for public health and loss of staff positions in DHHS. The passage of LD 1501 will extend the School Oral Health Program to offer core preventive services in all schools. The bill also provides funding for an oral health coordinator in the Department of Health and Human Services to lead the Maine Center for Disease Control and Prevention's public health functions related to oral health. It takes a team to provide optimal health care of any sort. And as we have seen most recently with the COVID pandemic, public health leadership is essential for healthcare teams to be able to serve our whole population. I urge you to approve LD 1501 to provide Maine with the basic resources and tools needed to protect our children's oral health. I thank you for your time, and I will be happy to answer any questions you might have now or in the future.
Thank you. Questions for Dr. Covey? Seeing none. Becca Matusevich.
Good afternoon, Representative Meyer, Senator Claxton, distinguished members of the Committee on Health and Human Services. My name is Becca Matusevich, and I am Executive Director of the Partnership for Children's Oral Health. It's okay, it happens all the time. I'm here today to speak in strong support for LD 1501. The partnership is working on improving and reforming our oral health systems from multiple angles, and the elements in this bill are key pieces in this puzzle. Since there are many speakers here today, I want to focus my testimony on a couple of the provisions of this bill that you might hear less about. First, this bill calls for inclusion of children's oral health in the Maine Care Program's annual reporting to HHS. In my attached handouts with my testimony, you can see that Maine has fallen to 49th in the nation on the percentage of Medicaid children who receive at least one preventive dental service. Only North Dakota was worse. And if you look at the whole child core set of Medicaid measures, Maine is performing well above the national median or right around it on 16 of the 20 child core set measures. Preventive dental care is the only one where we're more than 10 points below the national median. To help address this disparity, we're asking that you, as the HHS committee, require this annual reporting in order to ensure that as a state, we are upholding our legal and ethical responsibility to make preventive dental care accessible to all Maine Care insured children. A second point I want to speak to is that this bill also directs Maine Care to initiate a value-based purchasing pilot for school-based oral health services. This aligns well with the department's stated goal of moving more services to value-based payment models, and school oral health services are a prime candidate for this approach. We feel really strongly about the goal of maximizing Medicaid funding to pay for school-based oral health services because this increases the financial sustainability and the impact of the state's investment. There's another handout attached to my testimony that explains how this plays out. It looks like this. The main takeaway here is that each state general fund dollar triggers $2.50 in federal matching funds and generates $5 of immediate economic activity when providers receive the reimbursement. There are few investments the state can make where one state general dollar can generate this big a bang for the buck. But the biggest challenge with this whole diagram is at the entry point. In our traditional approach to children's oral health care, the entire burden is on the family to access the services. And for too many families, those barriers have been insurmountable. By making oral health services widely available in schools and preschools, we can remove the biggest barriers and kick the cycle into gear. The benefits on both the economic and the health side of the diagram then drive a cycle with positive impacts that build on each other, both immediately and for the long term. In closing, this bill asks for the bare minimum in funding support so that the state can work together with the rest of us in a public-private partnership. This is a winnable battle if we all do our part, and this bill provides the critical corner pieces to the puzzle. Having lived in Maine for almost 30 years now, I know that 3 things Mainers love best include doing right by our kids, supporting our schools and communities, and getting a good value for our money. LD 1501 hits a home run on all 3. Thank you for your support. I'm happy to answer questions and we'll plan on being at the work session.
Excellent. Questions for Ms. Matasovich?
You're a quick learner.
Seeing none, we appreciate you being here today.
Thank you.
Up next is Beth Pierce.
Good afternoon again.
Welcome.
Senator Claxton, Representative Meyer, and distinguished members of the Health and Human Services Committee. I am Beth Pierce, and I serve as the Oral Health Coordinator at the Maine Primary Care Association, or MPCA. MPCA is a membership organization that includes all of Maine's 20 community health centers. The Primary Care Association supports LD 1501 that Representative Gramlich, and thanks Representative Gramlich for bringing this extremely important and timely legislation forward. A number of our health centers participate in the the state school-based health centers. It's been a long afternoon. I think you guys can all attest to that. Or run their own independent in-school care programs. But there are many schools that the CHCs do not currently serve. Making school-based oral health services available in all schools across the state would promote greater access to care by removing barriers for children who need these valuable services. And in return would serve to improve their oral and overall health, as well as allow them to focus more time and attention on their education. As the value and necessity of school-based oral health services are considered, we respectfully ask that the department and other interested parties collaborate with and leverage the existing oral health work already being done by community health centers in school-based health centers and others in the community that they serve. Strengthening, complementing, and expanding the existing network will best utilize Maine's valuable resources to meet the needs of our children. In closing, as a former early periodic screening, diagnosis, and treatment, or EPSDT coordinator with the Office of Maine Care Services, I'm keenly aware of the importance of promoting good oral health and the impact the reduced state funding for public health and loss of the staff positions in DHHS has had as an overall effect on oral health. To address some of these unmet needs and ensure focus on the key elements of oral care, we support reestablishing a full-time oral health coordinator position within the Maine CDC. On behalf of the patients, staff, and volunteers of the Maine Community Health Centers, we urge the passage of LD 1501. Thank you for the opportunity to testify in support of the bill. If there's any additional information that the MPCA or our members could provide, please do not hesitate to contact me.
Thank you very much. Questions from the committee? Seeing no hands up, appreciate you being here today. We welcome Dr. Haidu. Sorry for mispronouncing your last name.
That's okay, Dr. Haidu. It's very common mistake. Thank you. Thank you, Representative Meyer and Senator Claxton and the esteemed members of the Committee of Health and Human Services for the opportunity to speak with you today. My name is Dr. Erica Haidu. I am a resident physician who lives in Falmouth, Maine. Today, I am speaking on behalf of the Maine chapter of the American Academy of Pediatrics as a trainee member, testifying in support of LD 1501. Training in the combined specialty of internal medicine and pediatrics, I take care of people throughout their lives and have personally witnessed the effects of poor dental care. Poor dental care has been shown to affect children's mental health, school attendance, and academic performance, but dental disease does not just affect children. Poor dental care in childhood has been linked to other negative health effects like obesity and hypertension in adulthood. Dental care can be difficult to access as an adult, and coverage of preventative services is not guaranteed. Many of my patients have fueled my passion in addressing dental health disparities in Maine. One particularly stark example was a woman in my clinic who had to get her teeth pulled due to severe decay while hospitalized for a major infection. She came to me asking for help with dentures at 24 years old. Had she had adequate access to preventative services in childhood, this may have been avoided. While accessing dentists that care for children has never been easy, the pandemic has made it even more difficult. About 40% of children with main care and 30% of children with commercial insurance did not receive preventative oral health services in the last year. Dental disease does not affect all children equally. Children below the poverty level and of racial and ethnic minorities are more likely to have tooth decay and less likely to have access to preventative services like fluoride and sealants. School-based sealant programs have been shown to improve sealant rates in all children, but especially in those high-risk populations. With over 400 of the more than 600 schools in Maine ineligible for the school-based oral health programs under the current guidelines, this creates disparities across the state, especially for lower-income children in wealthier school districts. Preventative services like fluoride and sealants work. According to the CDC, dental sealants prevent 80% of cavities in the molars where 90% of cavities occur. This is an issue of equity, and providing dental services to children in schools meets them where they already are, regardless of their access to services in the community or the income of their parents. We need to invest in pediatric oral health now and expand services across the state, because neglecting to do so will impact not only our children of today, but our adults in the future. Thank you.
Thank you. Questions for Dr. Haidu? Seeing none, we appreciate you being here today. Welcome, Ilmi Carter.
Good afternoon, Senator Claxton, Representative Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services. My name is Ilmi Carter, and I have been a school nurse for the Rockland School since 2005. I currently work at Oceanside High School in Rockland. The 6 schools in RSU 13 serve the towns of Rockland, Thomaston, Owl's Head, South Thomaston, and Cushing. I've enjoyed working as a school nurse in several of the local schools over the past 16 years. Families in many communities in Maine struggle to provide adequate dental care to their children. Our school's free and reduced rate is greater than 60%, with one school close to 80%. About 14% of Rockland's residents live in poverty, and 44% of the children enrolled in Maine care are in Rockland. This data outlines the financial stress our families live with. Knox County does not have any dental homes that are open to Maine care families. I've recently completed a research project on dental insecurity in Maine, where I was fortunate to receive information about Maine Care's rate system evaluation study. When Maine Care updates the rates, that will hopefully encourage more dental offices to begin accepting Maine Care patients. However, the need is now and ongoing. In my school system, our elementary schools have been fortunate to be able to participate in the state school oral health program, but our middle school and high school have not been able to. We have a mobile dental hygienist who comes to the school to see a few students who have Maine Care and no dental home. This is far from adequate. The need is greater than this one hygienist's ability to provide care for all students who are enrolled in Maine Care. LD 1501, if enacted, will allow for the expansion of more dental providers to provide necessary oral health care to the underprivileged families. Dental care should not be a luxury. I want to thank you for allowing me to speak in favor of LD 1501. The increase we are seeing in poor nutrition, self-esteem, and absenteeism have a direct interaction with lack of dental care. This bill will support families in obtaining and maintaining a basic human need. I hope you will vote to pass LD 1501 respectfully.
Thank you. Questions for Ms. Carter? Seeing none, we appreciate you being here today. It is 4:23. We've been sitting for a while, and let's break until 4:30. 4:30. Thank you very much for indulging us with a quick break. We will resume testimony on LD 1501 and welcome Judith Feinstein.
Yes, thank you. Thank you, Representative Meyer and Senator Claxton and members of the Health and Human Services Committee. Thank you for your patience all day. It's been a long one and you have time to go. My name is still Judith Feinstein and I am providing this testimony again as coordinator of the Maine Oral Health Coalition, which I told you about earlier. But I want to reiterate that I served before this as director of the Maine CDC's oral health program until June of 2015. And that was a position that I had for about 15 or 17 years after working in the program. And I want to talk in this testimony more about the coordinator position that LD 1501 includes. I also want to thank Representative Gramlich for introducing this bill and including the three very important pieces of it. So let me say that I support 1501, but also the coalition wholeheartedly supports it and its intent to take crucial steps to reestablish a fully functioning state-level oral health program in the Maine CDC. And I'd like to give you a few reasons why. We all look to a state-level oral health program as a resource for evidence-based public health approaches and best practices in implementing community-level dental disease programs. With a full-time program coordinator, the state program can become the go-to resource for reliable oral health surveillance data to describe the oral health of our population and to design and target effective community interventions to improve oral health for all people in Maine. National guidelines for state oral health programs offer guidance to health agency officials in the development and operation of strong oral health programs at the state level. My written testimony includes a reference and a link to those guidelines. I will say that they are aspirational and don't look at them as being, don't let the perfect be the enemy of the good when you look at those guidelines. An oral health program can address health inequities, coordinate with other state health agency programs to ensure that the relationships between chronic and infectious disease and oral health are considered when providing care, when facilitating those types of programs and planning programs, and can help bring up-to-date scientific evidence to bear in informing policy decisions.
30 seconds, please.
Whoops. All right. So I'm going to just say that since leaving state service 6 years ago, I've been working nationally with the Association of State and Territorial Directors, Dental Directors, which is the source of those guidelines. And as the Maine Oral Health Coalition Coordinator, I represent Maine with two national organizations that have goals similar to ours. From those perspectives and based on my experience here, I want to add that our program was increasingly under-resourced over a period of years, even before the program was downsized and effectively eliminated in 2015. Doing more with less is possible only up to a point. There's so much that a fully functioning program can do, and there are many stakeholders and partners, as you've already heard, who are ready and willing to work together to improve the oral health of all Mainers. And I thank you very much for your consideration. I urge you to support 1501. I'd be very happy to try to respond to any questions that you have, and I do plan to attend the work session.
Excellent.
I care about all of this, but this one comes very close. Thank you.
Thank you. Questions from the committee? Seeing none, thank you for spending your day with us here today. Next, we'll hear from Kaylee Williams. Welcome.
Hi, good afternoon, Senator Claxton, Representative Meyer, and honorable members of the Joint Standing Committee on Health and Human Services. My name is Kaylee Williams, and I am a dentist and the clinical director at Waterville Community Dental Center. I am also a graduate fellow with the Partnership for Children's Oral Health. I am here today in support of the bill LD 1501. And I'm hoping just to give a little bit of perspective and tell a little bit of the stories of some of the patients that I see every day. I work at a nonprofit dental center. We see majority main care population, and 70% of our patient base are children on main care. So we have a really huge volume of children coming through. And one of the hardest things I think to see as a provider is children who are coming to me for the very first time and ever going to a dental home. And it's because they're in pain. And that pain usually is not something small, unfortunately. Kids are pretty resilient, and they usually will want to eat, and they'll usually want to sleep regardless of what's going on. So by the time they get to me, it's a pretty serious condition. Now, this bill is going to help people like me who are already out there doing what we can do for the patients who get to us. But this bill is going to put some support behind the services that really are necessary to help get these kids seen and screened before they get to that point of dental emergency. It's pretty heartbreaking to have to sedate kids who are not even a year old or 3 to 5 years old because the dental disease is so dramatic that they couldn't withstand treatment in the office. It gets pretty heartbreaking, and the saddest part is when you start to be used to getting your heart broken regularly, and it becomes that common of an occurrence. So I really urge you all to really understand the importance of a bill like this. If we can get kids seen sooner, if we can even get them screened, some of these kids who are dealing with incredibly traumatic long-term effects of this dental disease could be stopped and found earlier, and we could be in control of this disease rather than constantly trying to get ahead of it with the few resources that we really have available to us. So I know you've heard from many of my colleagues already about the specifics of what is important in this deal and why it's important to fund this. But I hope that I've also left you with some information perspective from the patient standpoint, and you can really understand where the providers are coming for and hoping to support a bill like this. Thank you.
Thank you. Questions from the committee for Dr. Williams? Seeing no hands up, appreciate you being here today. Caitlin Morse, welcome.
Good afternoon, Senator Claxton, Representative Meyer, and esteemed members of the Joint Committee on Health and Human Services. I am Caitlin Morse, a resident of Westbrook and Policy Associate of the Alliance for Addiction and Mental Health Services. The Alliance represents Maine's safety net, community-based mental health and substance use treatment agencies. We advocate for sound policies and evidence-based practices that enhance the quality and effectiveness of Maine's behavioral healthcare system for people at all ages. On behalf of the Alliance, I, of course, am here today to support LD 7262, 996, but more importantly, 1501. A comprehensive oral health program for people of all ages would enable Maine to start disrupting the link between dental pain and the potential for addiction to opioids in later life. The connection is clear. Here are the facts. In 2010, the top diagnostic reason for an emergency department visit among both main care and uninsured young adults ages 15 through 24 and adults ages 25 through 44 was dental disease. A 2018 Journal of the American Dental Association study found patients receiving oral health care in an emergency department were nearly 5 times more likely to receive an opioid prescription than were patients treated in a dental office. Research also shows that teens taking an opioid during these vulnerable years are 3 times more likely to misuse drugs in the succeeding years after their initial introduction to the prescribed opioid. We know that young people are at an increased risk of addiction. The part of the brain that releases dopamine and reinforces the sensation of pleasurable experiences is heightened for them. At the same time, the prefrontal cortex, the part of the brain responsible for self-control and decision-making, doesn't fully develop until the mid to late 20s. Teens who have taken an opioid during these most vulnerable years are 3 times more likely to misuse drugs. 2 in 3 adults treated for opioid use disorder first used opioids when they were younger than age 25. Dental pain is the most common chronic childhood disease. In many cases, the first opioid prescription a young person receives is for oral pain due to poor preventative care or the removal of wisdom teeth. Anecdotally, I remember that this was the case for me. My mother was a nurse in a local pain clinic in the early 2000s. While I recovered from wisdom teeth removal surgery, I remember she watched me like a hawk to make sure I was smart about the prescription. I had no trouble after the fact, but not everybody has a mother who, because of her work, was on the phone with the district attorney every day as the epidemic broke. Youth prescribed an opioid without a mom like mine may experience a reduced sense of risk for using and assessing opioids later in life. Making oral health a priority in schools and making it easier for young people to access preventable dental care would simultaneously
30 seconds,
provide
please.
necessary care and eliminate the well-documented unnecessary ripple effect of addiction. Please vote ought to pass.
Thank you. Seeing no hands up for questions, we appreciate your being here today.
Thank you.
We'll hear from Morgan Hind. Welcome.
Thank you. Good afternoon, Representative Meyer, Senator Claxton, and distinguished members of the Joint Standing Committee on Health and Human Services. My name is Morgan Hind, and I am the director of the Bingham Program, a small charitable endowment held at Tufts Medical Center, established in 1932 to promote health and advance medicine in Maine. I'm here today to testify in favor of LD 1501. I am also a longstanding member of the Maine Oral Health Funders, a group of philanthropies in the state that funds work to improve oral health. For many years, the Maine Oral Health Funders has supported efforts to improve oral health for children in communities around the state. While these efforts, to some degree, expanded access to dental care and strengthened community-based efforts to improve oral health, none has ever come close to fulfilling the need for a comprehensive, statewide oral health and disease prevention program for Maine's children. The oral health coordinator position that would be created by LD 1501 will provide the backbone for such a program. This position did exist, as Judy mentioned earlier, at Maine CDC for many years, but was cut, and there is no longer a dedicated staff person overseeing the state's oral health and disease prevention efforts. Instead, this work currently falls to the Director of Rural Health and Primary Care, which is an incredibly important and busy position that doesn't have the bandwidth to also run the state's oral health program as effectively as it should be run. The state needs a dedicated staff person focused on improving oral health for all Maine people. While the rest of this legislation is focused on school-aged children, the oral health coordinator will be charged with oral health promotion and disease prevention more broadly for all ages. With our current fragmented and under-resourced system of oral health care, we need someone at the state level who can effectively and strategically manage programs, identify gaps, and secure federal grants to improve the oral health of all Maine people. Put simply, evidence-based disease prevention efforts like the school oral health program simply will not improve or grow to meet the needs of all Mainers without dedicated staffing and leadership from our state public health agency. Oral health is an essential element of overall health. Oral disease is the most common chronic disease of childhood, and it is one of the leading drivers of emergency room visits among adults. With a long history of systemic barriers that keep the majority of Maine people from accessing regular preventive
30
care,
seconds, please.
it is time for the state to step up and provide leadership on this issue. This is a winnable battle, and you have many partners who've been working hard to tackle it, but we need leadership on the public side of this public-private partnership to make significant progress. Therefore, I encourage you to vote in favor of LD 1501 to ensure Maine CDC has adequate staffing to run the state's oral health program. As you have heard today or will hear, this is a modest investment that will pay dividends in better health outcomes, better learning in school, and better economic opportunity for all Mainers. I thank you for your time, and I'm happy to answer any questions.
Questions from the committee? Seeing none, we appreciate your testimony. Stephen Mills, please.
Good afternoon, Representative Meyer, Senator Claxton, and members of the Joint Committee. My name is Steve Mills. I'm a board certified pediatric dentist, and I'm going to speak in support of LD 1501. I've been a dentist for 40 years and I've been a pediatric dentist in Maine for 34. During that time, I've tried to treat as many children as I could. The practice I started, Just for Kids Pediatric Dentistry in Scarborough, consistently ranked as one of the most receptive to Maine care children within the state of Maine. Over the years, I've realized that no matter how hard I worked and how many kids I tried to see, I could only treat a fraction of the pediatric population. I've heard all about the access to care issues. I've come to realize, though, that the access to care issues is not a simple one. There's no simple answer to it. Oh, sure, I'd love to reimbursements to be raised. I'd love a simpler and easier system and bureaucracy. I'd love patients to show up consistently. I'd love parents not to have to be able to miss work. I'd love to have all dental offices accessible to everyone. And I would love to develop a culture in Maine that values oral health as much as I would like it to. But you know, that's a tough thing to say, and that's a lot of issues to kind of tackle. So basically, my feeling over my years is, how can we get to these kids to treat them? What's the best way? These kids meet with, and their families meet with so many barriers. Well, LD 1501 removes a lot of that barrier. In this case, we're going to the kids. We're not demanding that they come to us. We're actually trying to greet them in a place where they are. A school-based oral health program just makes so much sense, especially over the years that I've worked, doesn't it? It does a lot of things for us. First, kids are at school all the time, right? So you know that that's true. It targets prevention, which will lead to a lifetime of dental health, not just access just those problems as they exist. It will be able to connect these kids most at need through this program to get the care that they need outside of the school. It's critical. And it will help shape a culture of health, oral health in this case. But as you've heard time and time again, oral health is a large component of total health. And so it has to be part of our culture. So how's this going to be done? And who's going to make sure it's done? Well, that's another good part. You need, as a business person myself, you need a boss, you need a supervisor, an administrator, a health program manager, or an oral health care coordinator that's been mentioned so many times. This is obvious, isn't it, that you need this person, but it really should not be a job for someone to be taken as a sidelight to other jobs. This is a big job, and
30
it needs
seconds,
to be
please.
a focus. Thank you. As I move away from day-to-day practice, I hate the word retirement, to the broader world of oral health of the children in Maine, I see an awful lot of excellent opportunities out there to help kids. This LD 1501 is one of those excellent opportunities. I'd love to answer any questions. I have a lot of experience with this over a lot of years, and any help I can be, I would love to be there for you. Thank you.
Thank you. Questions from the committee for Dr. Mills? Thanks for your testimony today.
Thank you.
Providing testimony neither for nor against is Nicole Breton. Nicole. Ms. Breton? Give her a second. Nicole Breton? It does appear Chris Hastet is providing testimony in support. I didn't see you there, Chris, so why don't you, while we're waiting for Ms. Breton, welcome.
Thank you very much, Representative Meyer, Senator Claxton, distinguished members of the Health and Human Services Committee, and a heartfelt thank you to Representative Gramlich for introducing this important bill. My name is Chris Hasted, and I'm the Senior Policy Advisor at Maine Equal Justice. Maine Equal Justice is a nonprofit legal aid provider working with and for people with low income in the state, and on their behalf, I'm speaking today in strong support of LD 1501. Today, you have very patiently and very thoughtfully listened to a great deal of testimony about the urgent need for access to dental care in Maine. But it's a unique afternoon entirely when earlier in the day you've heard all too vividly about the consequence of a problem that, while surely needing solutions today, for many people started many years ago in their childhood. Now with this bill, LD 1501, you have an opportunity to address that problem at its roots. LD 1501 can protect Maine's children today from having to tell the same hard to hear stories that you have been hearing all afternoon. Beyond the stories, there's also compelling data corroborating the need for strong action to ensure that Maine children, especially those with low incomes, those who live in rural areas, and children of color have access to the preventive dental care and planning capability that this issue would provide. While access to dental care has improved in recent years, not everyone has benefited equally from that improvement, and those are the children I just mentioned. Some of you are very familiar with the so-called Early Periodic Screening, Diagnosis, and Treatment Program, or EPSDT, which is part of the Maine Care program and was designed to ensure comprehensive and preventive healthcare services, including dental services, to children under age 21. Under this program, the state is required to measure certain core performance indicators, including access to preventive dental services. As you heard earlier, but it really bears mentioning again, by this indicator, Maine ranks second worst in the nation, falling well below the national average, falling well below the ranking of our New England neighbors. And it is, we are the last in line just before North Dakota. Just a year ago, the Maine DHHS published a report pursuant to a legislative resolve showing that in 2018, just under 1/3 of all eligible children receiving Maine Care under age 9 received a preventive dental health visit. As you
30 seconds, please.
heard today, Maine faces. Thank you very much, Representative. As you've heard today, Maine faces persistent and consequential oral health problems. Multiple strategies are needed to address the problems of this magnitude. And to that end, this bill wisely includes both provision for direct access to preventive care and for the establishment of a planning component that would create an oral health coordinator position. This position will bring greater capacity to focus on ensuring that access to dental care is more deliberately and thoughtfully integrated into our state's public health strategy. Thank you very much for listening to our testimony today and for considering this important bill. I'd be glad to answer any questions, and I'd be happy to appear at the work session. Thank you.
Thank you, Ms. Hasted. Questions for Chris Hasted? Seeing none. Ms. Breton, welcome. You are muted. Oh, there you go.
There we go. Senator Claxton, Representative Meyer, and members of the committee, my name is Nicole Breton. I serve as the State Director for the Offices of Rural Health and Primary Care, a program of the Maine Center for Disease Control and Prevention Office, through the Maine Department of Health and Human Services. I'm here to provide information on behalf of the Maine Center for Disease Control and Prevention related to LD 1501, an act to protect oral health for children in Maine. Maine CDC is neither for nor against LD 1501. This bill amends the current statute in several ways. First, the bill expands the Maine School Oral Health Program to all schools in the state. The School Oral Health Program is one of many activities implemented by the staff at the Maine CDC in prevention. It provides a range of services, including oral health education, oral health screenings, fluoride treatments, dental sealants, and assistance with care coordination to a dental home. In order to direct services to schools where children are most likely to have difficulty accessing dental services. A portion of the program relies on school participation, the percentage of free and reduced lunch rate of the students in the school. We currently have funding only available to meet the need of 200 elementary schools. The majority of those schools are in rural areas of the state. The bill directs the department to begin a pilot project for oral health value-based payment model within the Maine Care. That includes prevention, early intervention, disease management, and care coordination services for oral health services delivered in the schools in early child care settings in the payment model. Finally, the bill provides funding for one health program manager to fulfill the role of oral health coordinator within the Maine CDC Rural Health and Primary Care Program to lead Maine's public health functions related to oral health. This position has been vacant since 2015, when all of the funding lines that were dedicated to the oral health program were redirected to other positions within the Maine CDC by the previous administration. The Maine CDC offers the following information to be considered. Tooth decay is still the single most common childhood disease. You've heard this over and over today. I can only share with you some of our early data from our school oral health program that through COVID and the lack of dental services the amount of dental emergencies in children has increased considerably. A major theme of the Surgeon General's report on oral health is that oral health means much more than healthy teeth, white teeth, and healthy gums. It's being free of dental pain, oral cancer, birth defects, and other diseases or problems that affect our daily function. Children who have dental abscesses and chronic dental pain are more frequently absent from school. In fact, more than 51 million school hours are lost each year to dental-related illnesses. There are many barriers in dental care that cause children to needlessly suffer from dental disease. These include cost, lack of transportation, lack of knowledge about the importance of preventative care, language and cultural differences, and fear. School-based oral health programs are just one way to overcome these obstacles and ensure equal access to oral health services for all children. To eliminate the oral health disparities that we currently see across the state of Maine and ensure that oral health of children as well as all of Mainers, it will take a strong infrastructure to be rebuilt at the state level. A crucial component of the state structure needs a dedicated leader who can provide leadership, educate and empower, mobilize partnerships, develop policies, and evaluate program effectiveness. Thank you for your opportunity to provide information of this impact of this bill to expand the Maine School Oral Health Program and strengthen the state's public health infrastructure.
Thank you for being here today. Questions for Ms. Breton? Seeing none. That concludes testimony on LD 1501. I would ask the committee for any requests for additional information for the work session from our analyst. Seeing no hands up, I will close the hearing on LD 1501 and open the hearing on LD 1302, asking if Representative Stearns, there he is. Welcome, Representative Stearns.
Thank you. Representative Meyer, distinguished members of the Joint Committee on Health and Human Services. I'm Paul Stearns and I represent House District 119 in Piscataquis County. And I'm seeking your support today to correct what I believe was an oversight in a piece of legislation that was passed in the 129th legislative session. LD 1007 from the 129th made some changes to educational requirements for behavioral health professionals providing home and community-based treatments to children. Some schools have their own school-based programs that provide these same services, but in a school setting. Schools that provide these services must meet certain criteria to do so. When I discovered that school-based programs had been omitted from LD 1007, I approached then Representative Guttine to see if he could shed some light on the matter. We determined that it was a simple oversight and we're in the process of seeking a correction when COVID-19 brought everything to an unceremonious halt. Today, I'm asking the committee to consider allowing school-based behavioral programs to have the same training criteria for their potential employees as their home and community-based counterparts, thereby putting them on an even playing field. and I'll do my best to answer any questions that you may have.
Questions for Representative Stearns? I am seeing none. We will welcome Carrie Bickford. Actually, I don't think she's made it here to provide testimony in support of 1302. And I don't believe there's anyone else signed up to provide testimony. So I would turn to the committee to see if there's any requests for additional information for the work session. Seeing no hands up, thank you very much, Representative Stearns, for bringing this forward.
Thank you.
Close the hearing on 1302 and open the hearing on LD 1424. Resolved to change the educational requirements of behavioral health professionals providing services for children, and welcome Representative Salisbury to introduce the bill. Welcome.
Thank you very much. Senator Claxton, Representative Meyer, and distinguished members of the Health and Human Services Committee. My name is Sue Salisbury. I represent House District 35, which includes part of Westbrook. I am here to present LD 1424, a resolve to change the educational requirements of behavioral health professionals providing services to children. I know that Representative Stearns just submitted a similar bill, and I'm happy to work with the committee and Representative Stearns to come up with a bill that will address the current needs of clarifying the educational requirements for behavioral health professionals. This resolve changes the educational requirements for behavioral health professionals providing services for children, regardless of the setting in which the service is provided, to a minimum of 60 credit hours in a related field, 90 credit hours in an unrelated field, or a high school diploma with a plan for supervision and training. The same changes to the educational requirements apply for a behavioral health professional to be eligible to receive training to provide specialized services. This resolve also requires the Department of Health and Human Services to amend or establish contracts for training behavioral health professionals to train any number of additional individuals within existing resources, and authorizes the department to charge individuals or their employers fees for training. I have been working closely with Mallory Shaughnessy, who is the Executive Director of Alliance for Addiction and Mental Health Services of Maine, who I believe is here and can answer any specific questions that you might have about this bill. Thank you for your time today. I know you've had a busy day.
Thank you, Representative. Questions for the bill's sponsor? Seeing none, we will turn to Mallory Shaughnessy. Welcome.
Thank you, Representative Meyer, and doesn't look like we have Senator Claxton, but rest of the members of the Health and Human Services Committee. My name is Mallory Shaughnessy. I'm the resident of Westbrook and the Executive Director of the Alliance for Addiction and Mental Health Services, and here to speak in support of LD 1424. And I have to make a note that Carrie Bickford's testimony was actually more intended for 1424. She has both 1301 or 2 and this one in hers. Just she posted it to the wrong one, she told me, and then she had to go to work. So just an FYI before I start mine. So to share a little bit about LD 1424, it's designed to align the requirements of becoming a behavioral health professional, or BHP, across the different Maine Care services or programs. There are very different requirements for these same positions across the different sections within Section 65 and Section 28. It adds complexity, it creates a barrier to hiring and retaining staff, and it really doesn't make sense. Many providers that hire BHPs offer several of these services, and it would ease staffing concerns if a BHP could work within the different programs that they run. It would allow a provider to offer a full-time position, which many people are seeking. It also enables movement of these staff when other staff are out due to vacations or sickness. And through this COVID pandemic, we are continuing to see outbreaks, and then staffing becomes an issue, and we can't move these positions around, even though they are all BHPs. There's no real reason to continue with different requirements because it's basically what they do is the same across all of these services. A BHP should be a BHP. And currently, I've got some data in here around the dashboard for children's services, home and community. There's 600 kids on wait lists. They wait upwards of 6 months. We need to get rid of any barriers to this kind of hiring and retaining of the workforce to do this work. And anything we can do to improve this without reducing effectiveness is important. So I've, be happy to bring more additional information to the work session, but all of these direct care workers began within 30 days of hire, specific training to become a BHP. I share in my testimony curriculum overview. There's a link to details of the curriculum. And I also go through and show in the, what that looks like. And then in the timeline, which is put together by the folks that do the training for BHPs, that timeline included in my testimony talks about how in 2018, they actually remerged the school-based BHP curriculum and the 35-hour community BHP curriculum together with one certificate for all BHPs, yet they have to have different requirements to do the same job in different locations. It's a barrier. And if you look through my testimony, highlight all the different sections in section 65 and 28 and all the various ways that they are or not required to have different trainings for eligibility. We need to have one set thing that crosses all of these services. And the ones that are in the bill that Suzanne Salisbury, Representative Salisbury put forth makes them all have an equal eligibility with the supervision and the experience needed to do the job, plus the training. And there's also attached at the very end of my testimony, put together again by the folks who do the training at Woodford's Family Services. They have the state contract to do this training. There's like a flow chart, 2 pages of green, blue, orange squares that show you the complexity of how you have to try to go through to work in these different places. And then on the second page of it, it shows that pretty much they're all the same job once you get there. So just it's trying to rationalize the system, align them all together, and a BHP is a BHP, and they can do the work of a BHP. So that's our pitch, and we would hope that you could provide an ought to pass support for this bill. We need to reduce any barrier we can to hiring as long as we retain effectiveness. So
thank you.
Be happy to bring more information.
Sure thing. Questions for Mallory? Seeing none, that concludes testimony on this bill. And I would ask the committee if they have any requests for additional information from Aaron Dooling. Seeing none, I will close the hearing and thank you for being here today.
Thank you guys for your hard work today.
Finally, LD 1460, an act to revise the Department of Health and Human Services rehabilitation and reunification process, presented to us today by Representative McCray. Welcome, Representative. Representative McCray. Perhaps he has stepped away. There he is. You're on mute, Representative.
I didn't know the order that was coming up, and I was expecting a phone call to say, okay, you're on in 10. And
well, you're on now. Welcome.
Well, I have a couple of people that I was going to notify also. So I will do my part and go from there. Anyway, yes, I am, in fact, Representative David McCray. Good afternoon, Representative Meyer and the very honorable members of the Joint Standing Committee on Health and Human Services. I live in Fort Fairfield, and I represent the 9 communities that comprise House District 148 up in the center of Aroostook County. I am visiting you to present LD 1460 an act to revise the Department of Health and Human Services rehabilitation and reunification process. In my opinion, LD 1460, if enacted, will vastly improve the success rate of rehabilitating and eventually reunifying families whose children have been placed in foster care. I have had many conversations with former Attorney General, State Senator, Attorney and Guardian ad litem extraordinaire, Michael Carpenter, regarding his work, surrounding the topic of this bill. Mr. Carpenter has worked with hundreds of these families, and he has made it clear to me that all too often the biological parents do not truly understand the degree of progress that must be made during the year of foster care for successful reunification of their family. Pardon me. LD 1460 would require a mid-year meeting. Just tell him we're on. I'm sorry, that's one of my guys. Okay, mid-year meeting to assess the progress that is or is not being made, with the end result being an increased likelihood of the successful reunification of their family. Should appropriate progress be in place, that would be great. However, if corrective action need be made, it is imperative that the biological parents be made aware of the need for improvement rather than waiting for the full year to pass without the needed progress. This midterm meeting shall include the biological parents, the foster parents, and the guardian ad litem, as well as any professionals who have worked with the situation. I am hopeful that others, and I will see to it perhaps in subsequent testimonies as I notify them, that others with more direct knowledge will offer testimony later in this hearing. I would be happy to answer any questions that you may have of me, and I thank you for your time and consideration.
Thank you, Representative.
It's like you've had a string of education committee members, boom, boom, boom.
We have.
So there we are. Anyway.
Questions for Representative McCray? I am seeing none. I have a note here that a Jennifer Sweet was going to provide testimony in favor, in support of the bill, but yes. I do not see her.
I think you have someone from the department to testify in opposition, and I will notify the other people after that, if that's okay with you.
Okay, that's fine.
I'm sorry.
So moving on to testimony in opposition is Dr. Landry. Welcome.
Well, good afternoon, Representative Meyer and members of the Joint Standing Committee on Health and Human Services. I'm happy to inform you I will not be sharing any information with you today regarding oral health or dental procedures. For the record, though, I'm Todd Landry. I'm the Director of the Office of Child and Family Services within the Department of Health and Human Services, here today to offer testimony in opposition to LD 1460. As you've heard from the sponsor, the bill would require OCFS to convene a meeting with all parents and the guardian ad litem, as well as any other interested parties, to evaluate efforts and progress made on performing or achievement of elements under the rehabilitation and reunification plan for the child. The meeting would be held within 6 months of the issuance of a jeopardy order by the court. So our opposition to this bill is really twofold. First, the bill seeks to codify a practice expectation and work that is already part of a child protective case. OCFS has policies and procedures on family team meetings, and we reference Child and Family Services Policy 4D6 on that topic. FTMs, as they're often called, occurred throughout the life of the case to evaluate progress, update the family plan and child plan, and generally to just bring the team together to discuss the case, including progress made and services or referrals needed. Throughout the life of a case, there are also regularly scheduled judicial reviews of the case in court every 6 months pursuant to 22 MRSA 2048, where many of the same topics are, of course, discussed. The second reason for our opposition of the bill is the language of this bill is concerning to us, given that it does not allow for any statement or information brought forth at the meeting to be used in a judicial proceeding. This provision appears to be meant to ensure open and honest communication during the meeting without fear that that information might later be used against a parent in the future. Now, while OCFS understands that this may be the desire of parents and or their counsel, it is not, in our opinion, what is in the best interest of the child or the children who are the subject of the child protective case. Children involved with the child welfare system benefit when the court has all of the information possible as they make child safety decisions. It is inevitable that relevant information will be discussed at these meetings, and the department would be precluded from bringing forth that information at a subsequent hearing, thereby impairing the department's ability to make sound recommendations to the court and help ensure child safety. OCFS, as you've heard in previous testimony from me, is working with the Muskie School on updating and revising policies throughout our child welfare practice. This includes FTMs and family plans. We believe this evidences our ongoing work to refine and improve the process and ensure these meetings are beneficial to all parties. We do not believe this bill is necessary given the current system of FTMs. And furthermore, as I said, the language of the bill prohibiting the use of information obtained during the meeting from being introduced in a court proceeding, we believe threatens the safety and well-being of the children who are currently in state custody. For these reasons, we urge you to vote ought not to pass on LD 1460. Thank you for the opportunity to be with you today and what has been obviously a long day for you. I'm happy to answer any questions that you may have.
Questions for Dr. Landry? Seeing none, we appreciate you being here, Doctor. Circling back to testimony in support of 1460 is we would welcome the Honorable Mike Carpenter. Welcome, Senator Carpenter.
Thank you, Representative Meyer. So nice to see some of the folks that I served with, yourself, Representative Javner, Representative Stover, even Representative McCrae and Dr. Landry. I will be brief. This was an idea that I had prior to my election in November, where obviously I didn't prevail. All I do in my legal field, in legal work now, is guardian ad litem. I just walked through the door after doing 3 DHHS guardian ad litem visits. So I do know a little bit about the topic. And here's what I'm trying to accomplish. Dr. Landy is correct that by policy, the department has these FTMs, family team meetings. Sometimes the folks show up, sometimes one parent shows up, sometimes another. At the very beginning of a DHS case, the department will prepare with the parent a rehabilitation reunification plan that says the parent will accomplish this by this time, the parent will do this, the parent will do this, the parent will do this. What I'm trying to do is at about 6 months, because at about a year is when the department starts to talk about terminating a parent's rights if they're not doing what they're supposed to do. So my idea was that about halfway through, we're going to get everybody together in a room, basically everybody but the judge, but most particularly the parents. And they're going to say, here's where you are. Here's your rehabilitation reunification plan. And here's where you are. Dad, you haven't done anything to speak of. You've been missing drug tests. You're not consistent with visits. You're not doing it. Mom, you're doing a little bit better. And to bring them up, because oftentimes when it comes to the end of one of these cases and the parents have not done well, it's what we call TPR, termination of parental rights. That may start at 9 months to a year, oftentimes is not concluded for 1.5 to 2 years. At that point, it's very easy to get confused about what did the parents do, who did they visit, how often did they visit, how did they do in therapy, they changed the therapist twice, they missed this many drugs. It gets very confusing. what I'm trying to do is to help both the department and the parents at about the halfway point to say, okay, folks, here's where you are. I put the language in there, or I suggested the language that said you couldn't use what was said against a person for this reason. It's traditional in the law that discussions that take place during negotiations are not later admissible in court. We want people to be frank and honest. We want people to be open. We want people to be able to discuss things. I have no problem with taking that out. I have no problem with modifying that section. I think it may be entirely appropriate. There's no, I don't want to say penalty. This department tries hard to schedule family team meetings and to get the folks to come in and talk about what's going on in the case to this point, and have the guardian ad litem come in and say what he or she is finding. There's no, there needs to be an incentive for the folks to show up at these meetings. And currently there is none. Sometimes they show up, sometimes they don't. If they can't go to the trouble of showing up, then later on down the road, I want the court to know that. And I want it to be in some sort of an official way. So that's what I was trying to do. I was trying to be able to have everything come together in one meeting at about the halfway point, both for the department to be able to keep track of things and to point out to the people, here's the rehabilitation plan that you signed that was submitted to the court, and here's what you haven't done over the past 6 months. And so that was my purpose. I thank my good friend, Representative McCray, for putting this in, and I'm just delighted to be able to get a chance to say hi to you all.
Well, we're very pleased to see you, and thank you for your testimony.
Thank you.
Questions for Senator Carpenter? Seeing none. Take good care, Mike.
Thank you. And I'm not going to send any goodies your way because I never served on your committee, okay? Take care. Thank you.
We would welcome Jennifer Sweet. Jennifer, do you want to unmute?
Yep, are you able to hear me?
We can hear you, yes, welcome.
Sorry about that. I apologize for not having video. I appreciate you taking the time to hear from me. I am a foster mom to 3. I've been doing this since 2017, and I reached out looking for assistance on the current process. It gets convoluted over time, and many times since I've started this, it seems that the kids get forgotten, even though a lot of the policies I read and when I reach out for questions tell me it's about the children. But I go to the family teams meetings, and I've taken kids to miss visits, and I've taken that kid home and I've watched them pick their skin off and throw up and cry. And I sit there and wonder, do the parents really know that they're supposed to be there? That this isn't just about them getting better, which does need to happen. But there's a human being on the other side of this that is becoming traumatized and doesn't know that the parent might be still using or didn't show up or to a family team meeting, I should say. And I wanted to see some kind of change that really makes it frank to parents where they stand in the process. I saw in the DHS policies and then that was supposedly what was happened, but I haven't seen that frank conversation, as they mentioned, saying, this is really where you stand. This is really the consequence. And just trying to get that clarity out there so that hopefully kids in the state of Maine can have a little bit more to stand on, if that makes hopefully some sense.
Thank you, Ms. Sweet, for coming here today and sharing your story and for the work you're doing as a foster mom. Questions from the committee for Ms. Sweet? Seeing none, I don't see anyone else in the queue to provide testimony. Representative McCray, did you have someone else lined up?
No, Madam Chair.
Okay, thank you.
Thank you very much for your indulgence.
Absolutely. That would conclude testimony. So I would ask the committee for any requests for additional information from Aaron for the work session? I am seeing no hands up. With that, I will close the hearing on 1460. Hope that our analyst has nothing else for us today.
Thank you, committee.
Thank you, Representative McCray. Thank the committee for a long day and your rapt attention, and would ask for a motion to adjourn.
So moved.
Second.
All in favor? We will see you tomorrow. Have a nice night.